check, hello, hello, check. Check, hello. Full on the check, hello, hello, check, hello, hello, check. 1, 2, 3, 4, hello, hello, check, check, check. 1, 2, 3, 4, hello, check. Check, hello.
స్లైడ్ చేయొచ్చు కదా, దే కెన్ పుట్ ద స్లైడ్ అప్, రైట్? సో ఈ ఒక్కొక్క ఫ్యాకల్టీకి ఒక స్లైడ్ ఉంది, ఆ స్లైడ్ వేసి లేకపోతే నువ్వు కట్ పేస్ట్ చేసుకొని చేసుకో కావాలి. ఇప్పుడు నేను చూపిస్తా చూడు. ఇప్పుడు ఇది ఇప్పుడు ఇట్లుంది, అందరిది ఉంది. ఇప్పుడు డాక్టర్ శ్రీ అందరిది ఉంది ఇట్లా, ఒక ఈ స్లైడ్ ఉంది, తర్వాత మేడంది ఉంది, డాక్టర్ జోషిది ఉంది. యా యా అంటే అజెండా ఇచ్చేస్తే అయిపోతుంది, అజెండా ఇచ్చేస్తే అయిపోతుంది.
Hello, check 1 2 3 4. Hello, check. Hello.
Hello. Off ఎట్లా? ఎక్కడ? Good morning, everybody. Please, all the PGs out there, I request you to join the seminar. All the PGs, please join. Good morning, ladies and gentlemen. Welcome to the third Interventional Pain Management course at Gandhi Medical College and Hospital, organized by Department of Anesthesia and Critical Care. Let's make this conference not only an insightful one, but also a memorable one. Now, at this juncture, I must extend our heartfelt appreciation to Dr. Sridevi Ma'am, Organizing Secretary, whose planning, tireless efforts, and dedication are the cornerstone for the conference, truly embodying the spirit of excellence and collaboration. So now, I welcome Dr. Sridevi Ma'am onto the stage to introduce the course director.
Good morning. Good morning, distinguished guests, my fellow colleagues, and my dear postgraduates. A warm welcome to all of you to the third Interventional Pain Conference. This is the third time we are doing the pain conference and the workshop from the Department of Gandhi Medical College. I would like to welcome Dr. Ram Pasupuleti. He is the course director, and he is behind the starting of the pain clinic in Gandhi Medical College, and always constantly helping the department to do the work on the pain. And this is the first time we have started a pain clinic in the Telangana state, and that's all because of Dr. Ram's help. He is a director of Center for Pain Management in Kentucky, USA. He is always there with the Department of Anesthesiology. Whatever we want, he is supported. He actually donated a RF machine to the Department of Anesthesiology to improve our pain management services. And this conference, every time we will be doing to improve the clinical point of view, like the PGs are sitting in the OP clinics to check the patients. So what type of patients we are getting and how to go on, because as anesthesiologists we lack clinical touch with the patients because we are behind the scenes. So how to approach to a patient and how to examine a case of pain. So every time we were planning to improve this one, like to train the PGs in the clinical point of view, and also what are the interventions we are doing to them, whatever maximum can be done through the government hospital. So this conference is the third interventional pain management conference. We are morely stressing on low back pain and knee joint pain, because lot of patients are suffering more than I'll say everybody in their lifetime, maybe one time or other they'll be suffering with low back and knee joint pains. So we are getting lot of cases, volume of cases of low back and knee joint is more than any other pains. So we thought it will be very good clinical point of view, knowledge point of view, and the intervention point of view. If we do only knee joint and low back pain, it will be very good for the practitioners and also for the PGs who are sitting in the pain clinics to examine the patient. So this this conference will be stressing on only low back and knee joint pains. And I would like to thank Dr. Ram sir for conducting and for accepting to conduct this conference for all of us. I would like to welcome Dr. Ram Pasupuleti to introduce the course for the today's program. Dr. Ram sir.
Good morning, guys and girls. Good morning. Come on now, good morning. You got to be more involved in this. You just can't sit there and watch, so you got to be more involved. So we want you, this is for you, right? This is not for me. This is for you, so you got to be more involved, more focused so I guess anyone outside, please come in. We're getting started, we're already behind, so please come in. So I'll get started with the introduction, and before I do that, I wanted to thank every single person here. I can't take names because there'll be too many. But I can definitely thank the Department of Anesthesiology, and the first thanks goes to Dr. Sridevi. She's been the backbone of the pain clinic, and like she said, this is the first of its kind in Telangana, in a government hospital. That's a luxury for us. So now I think the Medical Council of India and the NMC requires any institution to have a pain clinic. So we are ahead of the game here. 3 years ago, we started this pain clinic. So 2017, yeah, so 5 years ago, 6 years ago actually. So let's get started here. So this is done under the auspices of the Department of Anesthesiology and Gandhi Medical College Global Alliance, which I'm the president of. I'm the president of the alumni, which is an alumni association based in the United States, and I'm the president of that organization. Gandhi Hospital and Gandhi Medical College and the Center for Pain Management, that's my institution in Kentucky. That's where I am from. So we all came together, and then we're doing this. And we are fortunate also to have Dr. Lingaya garu here. If you're sitting in this building, and if you see the staircase out there, Dr. Lingaya garu is entirely responsible. Please give him a big hand. I don't know how many of you know, how many of you are Gandhi students here? Okay, so the old hospital had that staircase, what you see there. That was completely almost, taken from there and put here. And Dr. Lingaya had a lot to do with that. So we should thank him again. So now, my name is Ram Pasupuleti. Some of you know me, some of you don't. I'm the president of the Kentucky Society of Interventional Pain Physicians. I'm president of the Gandhi Medical College Global Alliance, and I teach for American Society of Interventional Pain Physicians. Also, I happen to be guest faculty in Gandhi Medical College. How many of you knew that? Okay, so you can approach me the same way as you approach Dr. Sridevi, because I'm faculty as well. So that's why I never separate myself from Gandhi. So I'm just as much faculty as she is, but only the word guest is added there because I'm not here all the time. So, so feel free. to talk to me anytime. And there's no outside funding. In fact, no grants or industrial support for this presentation. I always support this meeting. Nobody supports me. So, so let's start with the structure of the course. This is a 2-day course, as you know. 1 day of didactic lectures and video demonstrations on the 27th, and a half day of live demonstration from the operating room, and a half day of didactics tomorrow. I don't need to tell you all that. You have the agenda with you, right? So why are we doing this? Why do we need a course like this? So Dr. Sridevi started off with a good note, and I'll finish this. Interventional pain management is a rapidly growing field of medicine, particularly in India. Low back and knee pain are two of the most common pain conditions in India. It is important for clinicians in this field of medicine to understand the pathophysiology of these painful conditions, to enable them to diagnose and also acquire the skills to provide the best treatment options and quality of care for patients. So that is the reason why we are doing this. So actually, we sat down and put our heads together. I asked Dr. Sridevi, what are the most common conditions that you see in the pain clinic? And she said low back and knee pain. So that's why we said, okay, let's do the most common conditions that you as PGs will see in the pain clinic. And that's why we are doing this. So this is meant for graduates, postgraduate students, faculty, physicians from anesthesiology and related fields of medicine who are interested in the subspecialty of pain management with a focus on low back and knee pain. Objectives for this course: review and discuss pathophysiology, diagnosis, and treatment of painful conditions of the low back and the knee. Like we said, we are limiting to low back and knee only in this conference. At the end of the conference, you should be able to demonstrate basic interventional procedures, and we're going to demonstrate that, and radiofrequency thermocoagulation procedures for low back and knee pain in live demonstration from the operating room and video demonstrations. And that should enable you as participants to learn concepts and skills in interventional pain management with a focus on low back and knee pain. CME, I think the Telangana State Medical Council has awarded 2 CME credit hours for the 27th and 2 for the 28th for the delegates attending the course. Now coming to the faculty, course directors, myself and Dr. Sridevi, and the organizing chairperson, Dr. Baby Rani. A little bit about myself. I'm the president of the Kentucky Society of Interventional Pain Physicians, as I said, and I'm the guest faculty at Gandhi Medical College. This is the Gandhi Medical College that you see on the corner there. And I did my fellowship training in pain management from Texas Tech University, Lubbock, Texas, under the two, at that time, #1 and #2 pain physicians in the world when I did it. #1 and #2, Dr. Prithviraj and Dr. Gabor Rats. So I did my training under them. And of course, my graduate training is from this very medical college, Gandhi Medical College. This is the medical college that I went to in Bashir Bagh. Okay, Dr. Sridevi says and Dr. Lingaya garu went to that same medical college. Sir, this is the principal's office, sir, is it? This is the principal's office, yeah. As you entered the medical college, you saw this building there, right there. So, and this was the inside of the medical school. This is the medical school that I went to. You see yours truly there with Dr. Raj on the left and Dr. Rax on the right. So Dr. Raj was at my home. That was my home. I invited him for dinner that day, and he was there with me. Unfortunately, most of you know that he passed away, right? So Dr. Rax is still alive, but Dr. Raj is no more with us. I have about 20 years of experience in the field of pain management. I'm guest faculty. I am also, I said this, so I don't have to repeat all over. And I've done a lot of pain management workshops and courses across the world, Indonesia, India, UAE, and I've authored some book chapters in textbooks of pain management, and I have donated those textbooks to your department. So you have all the textbooks in your department. I'm the co-author of ACIP guidelines for safe opioid prescribing, chronic non-cancer pain, epidural interventions, facet joint interventions, bone marrow concentrate therapy. There's a lot of publications that I did. And I have to bring the name up here. I did this with Dr. Lakshmaya Manchikanti. Does that name ring a bell? You are sitting in the auditorium named after him, Dr. Lakshmaya Manchikanti. He donated this auditorium. Let's welcome Dr. Muralidhar Joshi is here. I was just about to introduce you, Murli. So, Yeah, you're right on time. So I've been teaching pain management since 2003, and I conduct and teach in several conferences and workshops in USA and in India as well. So my mission in India has been to create awareness to sustain, maintain, and expand the field of pain management. I've conducted the first live demonstration cadaver courses in pain management in 2006, first spinal cord stimulator trial for pain in India in 2007. And I take one back, I think Murli, we did the first in Apollo in 2003, I think, right? So with Murli. So that was in 2003. That was the first ever pain management course in Hyderabad. I brought the latest advances in pain management to India. I helped establish pain clinics in several cities, Kolkata, Jaipur, Chennai, and including the pain clinic here at Gandhi Hospital. I've helped establish it, and I've trained several physicians from India at my institution, trained several currently practicing physicians in India. I collaborated with the most prominent pain physicians in India. A good example is Dr. Joshi himself. So I've worked with him for over 15 years now. And this course is a part of a larger effort to establish and run a center for pain management at Gandhi Hospital. And my next goal is to make this a clinical center of excellence in pain management in Gandhi Hospital Medical College. And my next goal is to establish a pain fellowship. I see Dr. Sridevi cringing there, but that's my next goal. So whether you like it or no, I'm hoping I can get it. So I've tried and I keep trying. So at least we have the promise of the principal himself. Dr. Ramesh Reddy Murli promised us that he would work with us too. So, and we'll need your help again with that. So, faculty, I'll go quickly. The rest of the faculty, course director, Dr. Sridevi. All of you know Dr. Sridevi, right? Let's all give her a big hand one more time. If you see the pain clinic running here, it's because of her. She is from Gandhi Medical College, which makes her more special because I'm very biased towards Gandhi Medical College, as you can see. So because that's my alma mater. So so she's from Gandhi as well, and she's attended a lot of conferences. And actually, this is the third conference that we are doing here at Gandhi. So 2018 we did one, 2020 we did one. Unfortunately, because of COVID, we couldn't do. And then this is the third one that she has organized and conducted. And one more round of applause for her, please. This is Dr. Baby Rani. I don't think she's here. Is she here? She's not well, I believe. So she's the organizing chairman, and without her blessings, we would not be able to do this. So a round of applause for her as well, please. Now coming to the stars of the faculty. You know, Dr. Joshi, as you call him, I always call him Murli because he's always been Murli to me. So, I call him the Amitabh Bachchan of pain management in India. So, nothing less. He's a superstar of pain management. So, I mean, see, the smaller the font gets for the introduction, you know it's too much of introduction. So, Dr. Sridevi's teacher himself. So, and he's the first in so many things, as you can see, instrumental in following the first Android application in the world of interventional pain management. First to start a fellowship in pain management in India. Give him a big hand for that. First to author a textbook of pain management in India. And I'm a little biased towards it because I did contribute a chapter. He kindly asked me to do a chapter on it. I did a chapter in it. I think it was some disc-related thing. And I donated that book to your department. It's there in your department. So there are too many awards. And more importantly, he is the president of the ISSP, Dr. Joshi. The biggest organization, pain organization in India, and he's the president. And we are very fortunate to have him. Another round of applause, please. Anything I say about him is still less. So thanks, Murli, for accepting our, very kind of you. He's never did he once say no to my request, and I'm very proud and I'm very glad. Thanks, Murli. So we have Dr. Padmaja. I don't think she's here, right? I don't think she's here. So I'll skip. The point I'm trying to make here is that you have world-class faculty here. That's a point I'm trying to make. So you cannot get any better faculty for a conference than this. So that's the point. She's the head of the Department of Anesthesiology and Intensive Care of Nizams, one of the most prestigious institutions we have here. And then we have Krishna Poddar. She's not here. She's actually coming tomorrow. She had to cancel a conference in Chennai. Because of this conference, she's flying late tonight. And she's the vice president of the ISSP, his vice president. Give her a big hand. You will see her tomorrow. She's been a good friend of mine for a long time. And this is Dr. Rajshekhar Kollipara. He's from the United States of America. He also happens to be my cousin, but that's a different story. There is no nepotism here. So he's not here because he's my cousin, but he's a qualified anesthesiologist and a pain management guy. He's not here yet, so I'll skip over. And we have Dr. Uma Maheshwar Rao. Is he here yet? No, I don't think he's here. We'll reintroduce all of them. And Dr. Sachin Joshi. And if you look at these guys, Dr. Sachin Joshi, he's the anesthesiology, pain management, and critical care in Citizen Specialty Hospital. But you just look at the fellowship where he did in pain management, Kamineni hospitals, right? I'll come back to it. And then Dr. Lavkumar Reddy, Dr. Ashik, Anish Wagre. Look at where they all did their fellowships. Virinchi hospitals, right? One common factor. Who's the common factor for all of them? Dr. Joshi. Dr. Joshi trained all of them. So you have all of their training, it goes to Dr. Joshi. So the point I'm trying to make is still the Amitabh Bachchan of pain management. So I'm not going to go through each course. You have your agenda. The one point that I'm going to highlight here is the Dr. Prithviraj Memorial Lecture, which I'm instituting this year. A very, very important lecture. Yeah. The biggest name in pain management that you can ever know is Dr. Prithviraj. And we'll talk about him during the memorial lecture, but if you look at the topic, it's Advaita Vedanta, Consciousness and Pain Management, the first of its kind in the world. You are here while history is being made when we talk about this, because nobody has talked about this till now in the field of pain management. अरे थोड़ा तो applause बनता भाई. So it's a unique attempt at integrating our ancient knowledge systems to the modern scientific thought process. So, and Dr. Raj would be very proud, and that is why I'm doing this, because he was like that. He respected our knowledge systems, and he taught me whatever little I know in pain management, and he always, respected our knowledge systems. And he was from here, of course. He was born in Jaipur and went to Mysore Medical College, and then he went to England and stuff, but he always retained his connection to India. And that is the reason why I'm doing this lecture today. And of course, we have all of these topics here. What we tried to do was we picked all the painful conditions of low back and knee, and we were going to discuss the pathophysiology, the diagnosis and treatment of each individual condition, as you can see. Disc pathology, facet pathology, knee joint pathology, SI joint pathology, so on and so forth. And then we'll finish the day with video demonstrations of procedures. We'll demonstrate the lumbar epidural steroid injection, radiofrequency thermocoagulation, and spinal cord stimulation. So that will end today. And tomorrow we have the live demonstration workshop from the OR at Gandhi Hospital. And you will see live cases from the OR. As far as I can remember, we have lumbar epidural steroid injection, we have a caudal epidural steroid injection, we have an SI joint injection, we have a radiofrequency of the genicular nerve, we have a pulse radiofrequency of the saphenous nerve, and we have one more So we have radiofrequency of the medial branches. So we have 8 cases. So you'll see all of them live from the operating room. And then, of course, we have few didactic lectures in the afternoon. Rules of order, time is of the essence. I keep saying that, but doesn't work here. So Yeah, I just keep harping on that. I was here at 7 o'clock today. Nobody showed up till 8 or 8:15, so that's how it goes. So save all the questions till the end of the presentation to allow us to, we are already about 15 to 20 minutes behind, so save all your questions. All of us are available, and you can catch us during the breaks, and that way we can move forward, keep moving forward. You're here to learn, right? You're here to learn. So learn as much as you can. And questions are a good way of learning, but just hold on to them. So what is the only stupid question? What is the only stupid question? The one that you don't ask, right? That is the only stupid question. So please feel free to ask us, but it depends on the time. So we need to keep moving, and we can always catch us outside. Kindly turn cell phones off or put them on vibrate. If you have to take a call, please step outside, right? So no texting, messaging, accessing social media or internet during the sessions. It's just a disturbance for everybody else. So please sign in at the registration desk and collect your CME certificate. Is it tomorrow? Can they collect it tomorrow? Yeah, tomorrow around lunchtime you can collect the CME certificate. So again, acknowledgements to Dr. Sridevi, Dr. Baby Rani, faculty, postgraduate and graduate students and staff, Department of Anesthesiology, national and international faculty who are here, and event coordinators. I cannot go through each name, but I do thank every one of you for doing this. A big hand for all the coordinators, please. Superintendent Gandhi Hospital, principal who will be here for the inaugural ceremony, orthopedics and neurosurgery, general surgery, and other departments who are very kindly, I'm sure they had OR today, right? They let you go from the OR, and they were very kind. So, and equipment and service providers, Kumar is the AV guy. Give him a big hand. I think Sadiq bhai, cameraman, hai, unko bhi big hand, please. So yeah, they make it possible. They make it happen. So, and then the GMC GA, which I'm the president of, I'm always grateful for their support. I'm grateful for the support of Gandhi Medical College Alumni Association, which is a local association here. And Dr. Lingaya was the president of it, and he is currently the president of the AMES, the Educational Society as well. All the attendees, all of you, some of my classmates will be here later. My family will be here. My mom will be here later at 9:30. So, and friends. So that finishes the first part. I'm going to go with the next one. Kumar, next one, please. Clinical assessment of low back pain. I'm not going to waste much time, so let's move forward with the conference, and let's start with the next presentation, which is the clinical assessment of low back pain. And I think Dr. Sridevi mentioned the point that as an anesthesiologist, you may not have the necessary skills to examine a patient, because all you say is you are behind is open your mouth, count 10 to 1 or 1 to 10 or whatever, and then he's done. So for pain management, you need a different set of skills, right? So, and this set of skills is what you're going to learn here. I'm not going to go through all this. I use information from textbooks, from Lakshmaya Manchakanti, and so on and so forth. Start off with Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityorma Mritangamaya. So lead us from the unreal to the real, lead us from the darkness into light, and lead us from death to immortality. So as you can see, Gandhi Medical College's logo has Tamasoma Jyotirgamaya. So this is the prayer that we do. So all we are asking is to lead us from the unreal to the real, and from darkness into light. That's what you're here for, right? From ignorance to knowledge. So the objective for this talk is to provide an overview of the clinical assessment and diagnosis of low back pain. I've structured it this way. We'll start with the introduction, then go into the approach to clinical assessment, where we'll talk about the anatomical sources of low back pain. You have the anterior, the neuraxial, and the posterior compartments and other causes, and how to diagnose low back pain. Start with the history and physical examination and the ACP and APS guidelines, which are just guidelines, just for us to know. what are the imaging studies that we need to diagnose a patient of low back pain, and do we do EMGs and labs, and what are the kind of diagnostic injections we can do to diagnose low back pain, right? And then finally we arrive at our clinical assessment and say this is what the patient has. So it is a step-by-step process of diagnosing low back pain. Low back pain is an affliction that affects most, if not all of us, sometime or the other in our lives. So please raise your hand if you have never had back pain. Never had back pain. One person. So every one of us has had back pain sometime or the other. So, and if you didn't have it till now, guess what? You're going to get it sometime or the other. So if you're lucky, it'll be temporary. If you're not lucky, unfortunately, so let's not go there, but that's why we are here, right? So low back pain is one of the most common clinical presentations seen by physicians in general practice and also in specialties like pain management, orthopedics, neurology, neurosurgery. Every one of them sees low back pain. 70% of patients in my practice is low back pain. So if I see 10 patients, 7 have low back pain. So if you look at the global review, this was done by Manchikanti himself. The Manchikanti auditorium that you're sitting here, that himself. They showed that point prevalence to be 12%, 1 month prevalence 23%, 1 year prevalence 38%, and a lifetime prevalence of 40%. That is the United States population. Let's look at Indian population, because we are interested more in Indian population, right? This is Gautam Shetty and et al. Did this study, and they said that the point annual and lifetime prevalence was 48%, 51%, and 66%. So all of those numbers are higher than what numbers you saw in USA, right? So more than global populations, especially among women, rural population, and in workers. So as the population ages over coming decades, the number of individuals with low back pain is likely to increase, not decrease. So increasing the global burden, and that is the reason why it behooves us to address this burden by appropriately assessing and treating low back pain. So approach to the clinical assessment, what are the anatomical sources of low back pain? I'm sure every one of you knows how you divide the spine into 3 compartments, right? The anterior compartment, the middle compartment, and the posterior compartment, right? So the anterior compartment has the vertebral body and the disc, as you know, as you can see the picture there. The middle compartment has the spinal canal with its contents, and the posterior compartment comprises of the facet joints, the laminate, transverse and spinous processes, muscles and ligaments, and so on and so forth, right? So, and then in addition to that, the anterior, middle, and posterior compartments, there are other causes of back pain, right? SI joint is a very big one, big cause. And that's why I think we have an SI joint injection as well. Coccyx, coccydynia is very important as well. And then scoliosis and other spinal deformities. And failed back surgery syndrome is a big cause of back pain where I come from. So I did not get the statistics in India. How big is it, Murli, here? I mean, big? Failed back surgery syndrome? Yeah. So you see a lot? Post? Yeah. I know, I know. Yeah. That's right. So we'll talk about failed back surgery syndrome. I'm going to talk about it, but I hear that the incidence here is growing almost exponentially. So that's an important cause. And neuropathic pain, which is centralized pain, right? So let's start with the anterior compartment causes, right? Vertebral body, let's start there. So how can a vertebral body cause pain? If it breaks, right? Fracture is the first cause, and you can have compression fractures. They can be osteoporotic or pathologic fractures from tumors and stuff like that. So tumor, if you can see the picture there, that's a T12 compression fracture of the MRI. Can you guys see that? Can you guys see it? Pointer. This one? Okay. So compression fracture, see that? Right there. So, and then tumors, myeloma, lymphoma, you can see the tumor here, right there. That's a fracture from the tumor, right there. So, burst fractures are traumatic. You can see the burst fracture. Can you see this, guys? through and through, the burst fracture there. So osteomyelitis, again, see the osteomyelitis here? That's discitis and osteomyelitis of the two adjacent vertebral bodies. Degenerative changes, spondylosis, Small's nodes, spondylolisthesis, spondylolysis, all of that are from the vertebral body itself. As you can see here, spondylolysis, right, and spondylolisthesis here, L5 on S1, anterior spondylolisthesis with spondylolysis, right, spondylolysis. When the posterior arch fails to fuse, you call it as the spondylolysis, right? So ankylosing spondylitis is a big cause. Dr. Sridevi, do you see any ankylosing spondylitis here? You do? Quite a bit of it? Young folks usually, or? 25 to 35, ankylosing spondylitis, you do see quite a few of them. So I don't see that as much there because most of it goes to rheumatologists. I don't see, I mean, I see some, but not a lot. Non-specific pain, everywhere. Yeah. But I mean, you guys do see it, right? You see it. So the next anterior compartment cause is disc, right? Disc pathology can be without nerve involvement and with nerve involvement, right? Disc degeneration, internal disc disruption, annular tears, fissures, disc herniation, all are very, 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 very common things. As a pain management physician, these are by far the most common conditions that you're going to see is a disc pathology, right? Either it is DDD, as we call it, or annular tears, disc herniation. Discitis is a little more unusual. It's not that common. It could be from inflammation or infection, right? I'm not going to go through all the features here. It shows you the soup, the chemical soup that is in the nucleus pulposus, and it leaks out, and it can cause chemical radiculitis or mechanical radiculitis, right? What is chemical radiculitis? When the chemical soup leaks out and dings the nerve root, then you have radiculopathy, right? That's chemical radiculitis. When the disc itself goes and pushes against the nerve root, that is mechanical radiculitis, right? You have two kinds of radiculopathy. Now coming to the middle or the neuraxial compartment. So what does the neuraxial compartment have? The spinal cord itself with all its coverings, right? And the vessels that supply it and all that, the spinal canal contents, right? So spinal stenosis leading to neurogenic claudication is a very, very big cause of back pain. How can it happen? As you can see, there is bony canal narrowing there, see that? And facet and ligamentum flavum hypertrophy right there, and disc related. So when the disc pushes out, from here, it can cause spinal stenosis. When the facet hypertrophy, it can cause spinal stenosis, right? And then you have foraminal stenosis leading to radiculopathy. As you can see, the foramina here, sorry, narrowed foramen. That's the normal foramen, that's the narrowed foramen, and look at the disc there as well. Arachnoiditis is not that common. How much of those that you see, Murali, here? Not much. So it is usually rare, right? So it's not. Yeah, Dr. Rajshekhar is here, one of the faculty. Welcome, Dr. Rajshekhar. So that's a myelogram. As you can see, the myelogram there, and you can see the filling defects, right? And the irregular nerve roots, and you can see the filling defects there. And that is arachnoiditis. The clumping, you see the clumping of nerve roots, that is a hallmark of arachnoiditis. It could be idiopathic, infection, bleeding, myelography. Even myelography can cause arachnoiditis. Back surgery, spinal anesthesia. Encephalomyelitis, intraspinal tumors, spinal hematoma, and abscess. The bigger ones are subdural or epidural hematomas, as you can see here. Between the two arrows right there, that's a hematoma right there. Cauda equina syndrome, spinal stenosis, tumors, infection, injury, bleeding, and adhesions. Now coming to the posterior compartment, we have done with the anterior compartment, which is the disc and the vertebral body, the middle compartment, and now we're coming to the posterior compartment, right? What are the posterior compartment consist of? The facet joints, right? That is the biggest thing. So facet arthropathy, spondylosis, rheumatoid arthritis, spondyloarthropathies, facet joint cysts, trauma. And if you can see, there is a delayed uptake in the bone scan here. You can see the L3-4 lighting up right there. There's a facet joint lighting up, and that's a SPECT scan. You can see the facet joint light up there, and there. Then what other things are there other than the facets? You have the laminae of the vertebral bodies, the transverse and spinous processes. What can go wrong with them? Plenty. Fractures, trauma, and muscles and ligaments can have pain, sprains, strains, and spasm. All of that can cause back pain from the posterior compartment. Now, having done the three compartments, let us go to other sources of back pain, right? As we said, SI joints are a very big source of back pain, and they can be from degeneration, arthritis. Ankylosing spondylitis is a big cause of SI joint pain as well. And spondyloarthropathies, trauma, and ligament injury at childbirth is very, very important for SI joint. I'm sure you see some, right? I have seen some. Young postpartum woman comes with lower back pain. Suspect, especially if it is recent postpartum, because SI joints are stretched. Remember the anatomy of the pelvis? The SI joints hold in the back, right? So the pelvis has to stretch for childbirth. And that's when it puts a stress on the SI joints. And that's when they have pain, right? So coccydynia can happen from trauma, fracture, or injury at childbirth as well. I have seen coccydynia from childbirth. So when you see a young woman of childbearing age, you have to suspect these things. When they're complaining of low back pain or tailbone pain, you have to suspect that. Now, failed back surgery syndrome. It's a big deal. Actually, are there any neurosurgeons here? Yeah, they'll be mad when I say failed back surgery syndrome, spine surgery, because they'll say nothing like failed back surgery syndrome exists. So you can't say a failed spinal or a failed epidural. So how are you saying failed back surgery syndrome? So they're mad. But mad or not, it exists. And some neurosurgeons do not accept its existence. So look at the nice hardware there. Can't even get a better hardware in a hardware store, right? Look at the hardware there. Rods and screws and stuff like that. So why? We have an entire talk on it, so I'm not going to spend much time on it. Epidural fibrosis is a big thing, arachnoiditis, facet arthropathy, instability, loss of structural integrity of the three-joint unit of the back. So you have lost the structural integrity of that, and that's why you have spinal stenosis, SI joint arthritis, because you have fused 2 or 3 levels. So guess what? Something's got to give, right? Then the joint below takes the brunt, which is the SI joint. That takes the brunt. So adjacent level pathology, hardware malfunction, complications of fusion, and so on and so forth. So now coming to the most important part, we have talked about the anatomical sources of low back pain. Now coming to the diagnosis part of it, which is what you need to do. You can know all about your sources, but if you're not able to diagnose it, it's useless, right? So obtaining a meaningful and relevant history in a patient with low back pain provides clues to the origin and cause of pain and contributes to a substantial part of the diagnosis. So history taking is very, 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 very important, guys. If you take away one point from this lecture, do your history very well. And that's why we ask you to present them. Dr. Sridevi will ask you to present it in the rounds. What is the history? Where does the pain come from? So chief complaint in patient's words, right? A lot of patients these days walk into you and say, I have a herniated disc. Is that a chief complaint? No. So I said, no. You don't tell me the diagnosis, tell me where your pain is, right? So chief complaint has always to be in patient's words. Low back pain is a very good chief complaint, right? My back hurts is a very good chief complaint. My tailbone hurts is a very good chief complaint. So don't start off your present H&P with disc herniation. No, that's not the point. The disc herniation is a diagnosis. It is not a chief complaint, right? So And it always has to be in the patient's words. Mera kamar dukh raha is a very good chief complaint, right? In Hyderabad. Mera kamar dukh raha bolto, that's a good chief complaint. You can start off there and say, that's what the patient told me, right? So history of present illness is very important. How did the pain start? When did the pain start? Why did the pain start? Where did the pain start? How did it progress? What are the treatments that the patient got so far? So all these are very, very important to find out. And then you come to the characteristics of pain, right? Location, quality, intensity, radiation, aggravating and alleviating factors. How does pain affect the activities of daily living, sleep, social life, hobbies? Every single thing is very, very important. Aggravating and relieving factors. If a back pain patient tells you that when they cough or sneeze, their back pain increases, what is the cause, guys? What can it be? When they cough or sneeze, if their back pain increases, what can it be? It's an anterior compartment cause, right? Mostly a discogenic pain can cause it. It's not a for sure thing, but you can suspect that, right? So pain diagram, we'll come to in the next slide. Pain scales. We have to ask them what their pain is on a scale of 0 to 10, which is called the numerical rating scale, or you have the visual analog scale. You can ask that. Do you guys use those scales here in the clinic? Huh? VAS. Okay. So you show them the little thing and. So associated factors are very important, guys. Tingling, numbness, allodynia, hyperesthesia, weakness, spasms, bowel and bladder incontinence is the single biggest thing that you have to ask. So if that is there, then you're looking at a more serious pathology. So as soon as they mention bowel and bladder incontinence, the red flag has to go up in your mind and say that's where it gets serious. That's where the back pain gets serious, right? So swelling, deformity, skin color, hair and nail changes are also very important in the extremities, right? So if, let's say, they have pain in the back and going down both legs, and they have lost hair on their legs, and the nails are falling off, what do you think of? It is more of a vascular claudication than neurogenic claudication, right? Because vascular causes, you lose hair and stuff. So that's why this is important. Past medical history, surgical history, medications, allergies, social history, family history. I was seeing one of my drivers here, I was seeing him yesterday, and he had SI joint pain. He's gone to about 15 doctors here, and then, they told him he's a driver, not to drive. Easier said than done. You can't take the food away from that guy's plate. Easier said than done, Yeah, don't drive. Well, if somebody asked me, don't be a doctor, I'd laugh in his face, right? The same thing. You can't do that. You can't do that. So that's why you are there. You fix it and make him go back to work, right? So that's the point. Review of systems is very important. Constitutional, weight loss, and stuff like that. Weight loss is there. They draw you an S1 nerve root from the back to the butt to they draw a line there, and it's an S1 nerve root being pressed. So this is very important. That is the reason why this is very important. The pain diagram is very important, right? So these are the nerve roots: S1 root pain, L5, L4, L3. And the numerical rating scale is 0 to 10. Visual analog scale is this. There are plenty of scales, guys, but these are unidimensional scales. They only measure the intensity of pain. But there are multidimensional scales which we don't want to go into, very complex scales. And I don't know, I don't think they're very useful, Murli. Yeah. Yeah. Simple and easy, just unidimensional scale, 0 to 10. If they don't understand that, at least show them the smiley faces and just have them mark where they are. So now we are done with the history part. Now coming to the physical examination, right? Physical examination begins with observing how the patient walks in and ends with noticing how the patient walks out, right? So you have to be able to do that. See that, a hip patient's walk is a little different from a knee patient, right? A hip joint pain patient walks differently. An SI joint person walks differently. You know how a SI joint patient walks in? They walk on their toes, because when they put the heel down, the SI joint hurts. So they start walking on their toes. So seeing them walk in and walk out is very important, right? So Physical examination is done with the patient undressed and preferably in natural light. That is a lost art these days. I don't know how many of us are doing. Even I sometimes, good. Dr. Sridevi does it. Please do it. Please do it because it has to be in natural light. And undress the patient. If you don't undress the patient, you will miss so many things. You'll miss so many things. So you got to do that. Inspection and palpation. So what are the 4 cardinal things for history and physical examination? Inspection, palpation, percussion, auscultation, right? So in a low back, inspection and palpation are very good. Sometimes you can auscultate, but no, that's not as important. Percussion also is not that. You can percuss the discs in the back, and if it is discogenic, they have pain. So that's only place you can use the percussion, right? So, and then there are some specific tests to elicit specific signs. In addition to the standard general examination, the stress is on a focused examination of the painful area, mid and low back, hip, SI joint, bilateral lower extremities, with special attention to the musculoskeletal and neurological system. So when you're examining a low back, you have to examine all of this. Don't start at the low back, start at the mid back, right? Mid back. And then low back, hip, examine the SI joint, examine bilateral lower extremities, and then pay attention to the musculoskeletal and neurological systems. Physical examination transforms and sums up the clues obtained from history to a more objective and concrete basis of diagnosis. So after you finish your history, then that is subjective, right? Then this is the first objective part, meaning that you are assessing it, right? That's objective. So you get a more objective and a concrete basis of diagnosis. Spine, focus on the spine, hips, and SI joint examination. Inspection, look for scars, swelling, deformity, symmetry, posture, scoliosis, and range of motion. Ask them to bend forward, bend backward, rotation, side bending, right? Do they have pain with range of motion? If they have pain when they are flexing, it indicates one certain pathology. If they have pain when they are extending, it indicates one certain pathology, right? When they are extending, they're stressing the facet joint, so it may be facet joint pain. So pain and instability with weight bearing, guys, this is very important. Hip, anterior pain is always hip. Posterior buttock pain is SI joint pain, right? Palpation is very, very important. You push on the spine and find out if they are tender, right? Midline vertebral compression fractures, disc pathology. If you push in the midline, they are tender when they have a fracture, the compression fracture, or they have disc pathology, they are tender. And if they have paraspinous tenderness, facet tenderness, point tenderness over the SI joint, anterior groin tenderness for hip joint. So remember one thing, guys, if they point to their groin and they say it is hurting, it is almost always the hip joint, right? If they point to the back, it is the SI joint, right? So trigger points, do they have trigger points? And then palpate the muscles, paraspinous muscles. What is this test called? SLR, right? Straight leg raising. So what are you doing? You're just stretching the nerve. And when they have pain, that means that they have radiculopathy, right? Or radiculitis or radicular pain. So then KEMS test is for the facet joint pain. What do? You stress the facet joints. Where are the facet joints? They are in the posterior part of the spine, right? So how do you stress the facet joints? You ask them to extend, right? When you extend, you are stressing the facet joints, and you ask them to rotate, and when you rotate to the left, you are stressing the left-sided joints, right? When you rotate to the right, they have right-sided pain. That is the right-sided facet, right? So that's KEMS test. Patrick's test, SI joint pain, right? Flexion, abduction, and external rotation. I think we were doing it yesterday to some patients somewhere, yeah. So that anterior pain indicates hip. Posterior pain indicates SI joint, right? So now coming to the limb examination, again, inspection, palpation, skin, color, hair, temperature, nail, every single thing is important, right? If they are losing hair, vascular cause, so you need to think about that. Nail changes, edema, if there is edema, that's a different story altogether, right? Palpation, tenderness to palpation, muscle tone and strength. If they are exquisitely sore in the calf, what do you suspect? DVT, right? Homan's sign. So you have to palpate the calf. If you don't palpate the calf, you'll miss it, right? So limb length discrepancy. Homan's sign is specific for DVT. What is the Hohmann's sign? Dorsiflex, the foot, pain in the calf, right? That's Hohmann's sign. And remember one thing, guys, please do palpate the peripheral pulses. What are the two peripheral pulses in the lower limb that you palpate? Dorsalis pedis and posterior tibial, right? Those are the outermost pulses that you palpate. Yes, you can palpate the popliteal artery, you can palpate the femoral artery. They are big arteries. You will feel them. There's no point in doing. But the dorsalis pedis is a very small artery on the dorsum, right? And then the posterior tibial is right behind the medial malleolus, right? So you need to palpate them. If you don't feel a pulse, think more vascular causes, right? Think more vascular causes. Neurological examination. Gait is very, very important. Antalgic gait, right? When they have a fracture on one side, they will not like to bear any weight on that side. They are bearing weight on the other side. That is the antalgic gait, right? So sensory, touch, pinprick, temperature. I don't need to go through every single thing of this. Allodynia, hyperesthesia, hypoesthesia, paresthesia, anesthesia dolorosa, right? Make sure you understand the definition of each of these terms, right? And what is anesthesia dolorosa? What is allodynia? What is hyperesthesia, right? Motor, bulk, assess the bulk of the muscles, tone of the muscles, and the strength of the muscles, and deep tendon reflexes. And grading responses, I'm not going to go through all this. Basic neurology 101, right? Neurology 101. So just whatever, take a, hammer and test the reflexes and grade them accordingly, grade the muscle strength as well. So the ACP, American College of Physicians, and their guidelines in 2007, very simple guidelines. They said that clinicians should conduct a focused history and physical examination first to help place patients with low back pain into one of three broad categories. So when you see a patient with low back pain, you examine them, take a history, and put them in one of these three categories, right? Non-specific low back pain potentially associated with radiculopathy or spinal stenosis, and back pain potentially associated with another specific spinal cause. So these are the three categories that you can put a patient in. So the other causes are tumor, infection, cauda equina, ankylosing spondylitis, and other conditions with serious or progressive neurological deficits. So the reason why you need to do it is you need to understand if what degree of seriousness the back pain is, right? If it's a simple non-specific back pain, you treat it a different way. If it is, you suspect more serious pathology, you investigate more, and your treatment differs a little, right? So the history should include assessment of psychosocial risk factors which predict risk for chronic disabling back pain. So very, very important but neglected thing is psychosocial risk factors, right? So if they have psychosocial risk factors, then if somebody doesn't want to work, they don't want to go to work, they'll come to you and say they have back pain. So that's something that you need to assess and say, what is the motive of this guy coming to me? So if you don't assess their psychosocial risk factors, then you'll miss a lot, right? So clinicians should not routinely obtain imaging or other diagnostic studies in patients with non-specific low back pain. If there is a non-specific low back pain, the investigations are not warranted, right? But because it is self-limiting and you can treat it acutely. Clinicians should perform diagnostic imaging and testing for patients with low back pain when severe or progressive neurologic deficits are present or when serious underlying conditions are suspected on the basis of history and physical examination. The point of all of this is do a good history and physical first, and then you can talk about diagnostic tests, right? Clinicians should evaluate patients with persistent low back pain and signs or symptoms of radiculopathy or spinal stenosis with an MRI, right? That's the preferred modality. Why is it? Simple reason, no radiation. First, do no harm, right? So no radiation. So MRI, I would order 20 MRIs before I'll order one CT scan, right? Because I understand the constraint, MRIs are more expensive. I do understand that. So what is the cost of the average MRI, Murli, here? 6 to 8,000. So that is expensive, right? So yeah. So you can order an MRI or a CT scan. What according to ACP is only if they are candidates for surgery or epidural steroid injection, which has changed a little now. A focused history and physical examination should precede and guide any further diagnostic and imaging studies. So do this first, and then you can talk about other diagnostic. And you know, I have a lot of patients there, especially who walk in and say, have you looked at my MRI? I said, no, I haven't looked at your MRI. So then they say, then we'll walk away. I said, no problem. I can treat your MRI very well. Do you want me to treat you or your MRI? Right? So I can treat both. I can really treat your MRI very well, but it will not help you. So that's the point. The best outcomes in diagnosis and treatment of low back pain come from correlating history and clinical findings with findings on imaging studies. So your history and clinical findings are more important. Rajana, come on here. Mundu Grandi. Yeah. That's my cousin, my family, so. And what are the imaging studies that you order? Plain radiography is very good. You know, you can start with a X-ray. I see that most of our patients yesterday had plain X-rays that they came, and that's a very good starting point. Good modality to assess alignment and anatomy, bone and joints and fractures, post-op hardware, trauma. You can see the spondylolysis with spondylolisthesis here, and then you can see fractures here, T4, T6. Look at the fractures there. CT is the next one. The principal value of CT is the ability to demonstrate osseous structures of the lumbar spine and their relationship to the neural canal and the axial plane. 3D reconstruction can be done. So that's a CT scan right there. You can see the fracture through and through, and that is a 3D reconstruction, right? And neurosurgeons tend to order more CT scans, don't they? Myelogram and stuff like that, nobody's doing. I'm glad. So CT in conjunction with myelography, we were talking about that, provides better details of the spinal canal and compression of the neural elements. Unfortunately, most neurosurgeons in the United States order a CT myelogram. Most of them, even today. I keep arguing with them, why? Why are you subjecting a patient to a myelogram? So. CT in conjunction with discography provides detailed information on the presence and degree of annular pathology and disc degeneration. The extent of annular pathology on CT discography correlates with likelihood of a concordantly painful disc. If you can see the 4 pictures here, axial CT images, normal disc, see that? Normal disc, L34, right? Grade 0. Annular tear, right there. Posterior annular tear, grade 3, and then extensive L5S1 posterior annular disruption, grade 4. Look at that. The whole posterior border is occupied by the contrast. And then you can do the, this is a discogram, so you have injected dye into the nucleus. It's not much of pathology here, a little more pathology here, a lot more pathology here, and then these are the 3 views that this is a normal disc and this is disrupted disc, and both discs were painful. What is the point of doing discography? Is to identify the painful disc, right? So you inject dye and make sure that it is painful. Radionuclide bone scans, well known for high degree of sensitivity in the detection of a variety of bone lesions, fracture, infection, tumor, metastasis, and so on and so forth. And then SPECT. These are fractures. Both are fractures here, and then the L34 facet joint is lit up. MRI represents the most advanced form of imaging. Modality of choice for vertebral fractures, osteomyelitis, discitis, fractures, osteomyelitis, discitis, right there, and spinal canal pathology for multiple sclerosis, encephalomyelitis, trauma and infarction, epidural hematoma, right? So I think I'm kind of running out of time. I'll just go through this very quickly here. Myelography uses a contrast solution, can be used in conjunction with CT scan. Important diagnostics tool in arachnoiditis. Very important in arachnoiditis, right? Irregular filling defects, fusion of nerve roots, and the dynamic myelography is when you actually bend the patient while you're doing the myelography, right? And you can see the neurogenic claudication at L45, almost cut off completely. The dye is cut off right there. So discography is the, again, indication to identify whether or not one or more lumbar discs are responsible for contributing to low back pain. Anyone doing discographies these days? Not much. So I'm going to skip over this. I'm not doing them either. It's a painful procedure to begin with, very painful procedure, and the yield is not as much. So Labs, what are the labs that you can order? RA factor, very important for systemic illness. CRP, ESR, HLA, B27 for what? Ankylosing spondylitis, right? So, and then you can do some diagnostic injections as well, right? So to diagnose, if you don't know where the pain is coming from after all the investigations, then you can do an injection to find out where the pain is coming, right? So medial branch blocks are what? They are diagnostic. When you block them and they have no pain, that's a diagnostic injection. Then you can say that the pain is coming from the facets. And intra-articular injections can be diagnostic as well. Epidural steroid injections are both diagnostic and therapeutic, right? So diagnostic SI joint injections, you put a shot into the SI joint to see if they get good pain relief, right? Diagnostic discography. So this is done by, again, Dr. Manchikanti. You can access this study. It's an algorithmic approach to back pain. So when you have eliminated the impossible, whatever remains, however improbable, must be the truth, right? So that is Sherlock Holmes. My favorite, the most favorite detective in the world. So, and Sir Arthur Conan Doyle based him on his boss, who was a physician. That's how he diagnosed patients. That is the reason why. So when you have eliminated the impossible, whatever remains, however improbable, must be the truth. And that's how we diagnose people, right? So the combination of history and physical examination, diagnostic imaging studies, and labs should enable the clinician to come to a diagnosis assessment, or at the very least differential diagnosis. So can you come to a diagnosis all the time? No. At least get a differential diagnosis. So the emphasis is on trying to identify the source and nature of pain. So if you don't identify the pain, you cannot treat it, right? So you have to be able to identify the source of the pain. For example, a lumbar degenerative disc disease with discogenic pain, there is a disc herniation at L5S1 on the MRI, right? And then a right-sided lumbar radiculopathy, you've elicited an SLR on the right side, and then secondary muscular component with muscle spasms, you push on the muscle, they're very tender, that's your diagnosis. So it's just an example of low back pain. And with that, I end the presentation. Thank you.
Thank you, sir. That was an insightful lecture on history-taking, diagnosis, and clinical assessment of lower back pain. Now, I welcome onto the stage our dynamic professor, Dr. Sridevi Madam, for the lecture on lumbar epidural steroid injection.
Good morning, one and all. First of all, I would like to welcome my guru, Dr. Muralidhar Joshi. Because of him only I am here. He inspired me a lot when I completed my post-graduation and joined him in the Kamineni Institute of Sciences, that is Wokkad Kamineni Hospital. I met him there and I inspired because of his work, and I worked with him. Sir, because of you only, I am here today conducting a pain conference. Thank you for inspiring me and constant support for me, sir. Moving back to the lecture today. The lumbar epidural steroid injection, directly we are going to the injections, the disc pathologies, and what are the pathophysiology behind the pain will be dealt by Dr. Muralidhar Joshi, my guru. Now I'm directly going to the steroid injections. So as Sir Ram sir has told, he has given a overview that what are all the conditions what you get for low back pains. So now we are treating the low back pain directly. So this is the overview of the topic, like introduction, then small history, and then small anatomy. It's very brief it will be. Epidural steroid injections are considered effective because of their anti-inflammatory, membrane stabilizing, and anti-hyperalgesic effects. We are combining the epidural steroid along with the local anesthetic because the local anesthetic alters or interrupt the nociceptive input and alters or interrupt the reflex mechanism of the afferent fibers, and they alter the self-sustaining activity of the neurons and the pattern of the neuronal activity. So we are mixing the local anesthetic along with the steroid injections for more effective block. Then coming to the definition. Epidural steroid injection is an interventional technique to diagnose or to treat the pain that starts in the back and radiates to the lower limb. We can sometimes, as Dr. Ram said, we can diagnose low back pain with the diagnostic injections. There we may use a steroid or we may use only local anesthetic drug there. So it is both diagnostic and therapeutic. And we are injecting, the procedure is we are injecting a long acting steroid through the natural openings between the vertebrae to place the medication in the epidural space or directly onto the roots. Then coming to the history, this is started in 1872 and so many people have done it, but this has come to the limelight only in the 1990s. Coming to the anatomy, Dr. Ram sir has already covered. This is a very brief only to our point of view, like the steroid where we are injecting. So if you see from the vertebral body, in between the vertebral bodies there is a disc. From there you can see the nerve root coming out. This is the neural foramina from where the nerve root is coming out. So, and this in between is the spinal cord. So, our aim is this area or the epidural space. This is one more picture to show you the problems here. Like this is the compression here you can see, and here also you can see some compressions here. This is the normal, this is also normal. Here you can see the compression. Can you see here that because of the thickened posterior ligament and facet, it is compressing the nerve here, which is causing the radiculopathy. So coming to the indications. Indications are lumbar radiculopathy, spinal and foraminal stenosis, discogenic pain, maybe because of disc degenerative disorders or annular tears and disc protrusions or herniations, and failed back surgery syndromes, and neuropathic pains like complex regional pain syndrome or phantom limb pains, or for herpes zoster and post-herpetic neuralgia, and then vertebral compression fractures or coccydynia. These are the indications. So immediately after the indications, you should know what are the contraindications also for our epidural steroid injection. So sequestered herniation or cauda-equina syndrome, compressive radiculopathy, uncontrolled or any psychiatric disorders, acute medical illness, pregnancy and lactation, these are not absolute relative contraindications, history of reaction to the local anesthetic, and then any infections there or systemic or local infections, and then patient on anticoagulant therapy, you can stop the drug for 3 to 4 days and then you can go on. Then what are all the approaches we do for the lumbar epidural steroid injection? We have 3 approaches, that is interlaminar, transforaminal and caudal. Interlaminar, as most of the people here are anesthesiologists, we usually do the epidural anesthesia through the interlaminar route only. So this you can do like through the blind method. Every day we are doing that in the ORs, blind method, or you can go through fluoroscopic guided also. Mostly if you do the fluoroscopic guided, it will be better because we are injecting particulate steroids there. And then transforaminal, it should be fluoroscopic guided only. And then caudal can be done as a blind procedure, what we are doing as in the caudal anesthesia, or fluoroscopic guided, or through ultrasound. Yeah. Techniques and approaches, like what are all the 3 I have described here, everything is here in the picture. This is the interlaminar approach, and this is the transforaminal approach, and this is the caudal approach. And this is the AP view when you see from the back. This is transforaminal approach, interlaminar, and then this is the caudal approach. Here we are going and then blocking the nerve roots. So one more picture. I use lot of pictures because pictures will be printed in the mind. That's why I'll use many pictures are there, because this is little bit confusing. So that's why I'm using lot of pictures. One more pic of interlaminar and transforaminal, because as PGs you should know the difference where we are going and block, where our needle goes. So this is interlaminar and this is transforaminal. One more pick, same thing. Then coming to the equipments, these are the equipment and supplies for all the three approaches. So I am dealing the equipment, supplies, procedure, setup, everything for contraindications, indications for all the three. Then we'll go what are the specific problems or how we'll do a specific technique, like 3 techniques, that will be dealt separately. So these equipments and supplies are for all the 3 procedures. So fluoroscopy is needed. If you are doing a blind, then no need, but we'll suggest a fluoroscopy always. And the compatible table for the fluoroscopy and radiation protection equipment. Then what are all needed for the to do the procedure? Everybody here, they know how to do an epidural injection. For that we need a 2-Hoy needle, loss of resistance syringe, and non-iconic contrast. This is only to inject the drug to know whether we are there in a right place or not. Then the needles, appropriate needles and syringes, local anesthetics, and then steroid. So we have different combinations of the medications, like methylprednisolone. Usually we use methylprednisolone here, and then triamcinolone, and betamethasone and dexamethasone. Non-particular steroids we are using, like in Gandhi we are using dexamethasone and methylprednisolone. This is a particulate steroid, so if you are in a doubt, I will suggest to go through non-particulate steroid injection in the epidural space. And anyway, local anesthetic bupivacaine and ropivacaine. Now coming to the specific approaches, interlaminar approach. As you can see, we are in between the two bodies. Then procedure, what is the procedure or steps of the procedure? If you miss one step, you will miss the thing. So you have to be in a stepwise manner. It should be in your mind what are all the steps to do a procedure. So first set up the position of the patient, and then fluoroscopy. Then you can visualize the target. Choose the skin insertion, very very important. If you choose a skin insertion in a wrong place, you will end up doing a wrong procedure, some problems will be there. Then local anesthetic and sedation should be given at the skin insertion point, and then slowly advance the needle using the 3D technology and the gun barrel technique. Steer the needle, then final position of the needle tip should be assisted with a contrast, because we are entering a space which is very dangerous space, as anesthesiologists you all know. So after to confirm the position, use a contrast so that you can you are doubly sure that you are in a right place. Then after aspiration and injection of the contrast, then go and inject your medication. Coming to the position of the patient, interlaminar approach, you can give this, like do this procedure in prone or in a lateral position or in a sitting position. So table, everything should be set up equal, which is convenient to the person who is doing the procedure. This can be done in prone or in a sitting or in a lateral position. So this is the prone position, and you can see the patient prone position. You should put a pillow under the abdomen so that you can visualize these interlaminar spaces more prominently. Coming to the positioning of the fluoroscope, very important. First, orient to the fluoroscope. That means what is front part which is showing the image, which is showing the cephalad part. You have to note this point and get acquainted with the fluoroscope. Then you have to obtain first image by placing a metal density, whatever you have, you can place there. We usually place a artery forceps there. So placing a metallic density object so that the top of the image represents the cephalad part of the patient, and the left side of the image represents the left side of the patient, with the patient in prone position. So before proceeding, you have to get this image first get acquainted what are all the structures you are seeing and what is the right side or left side, then you can proceed. So positioning of the fluoroscope is very important, very important. Then how to advance the needle. So develop an educated finger. As anesthesiologist, I need not tell you that what are all the structures we are going through. Everybody knows. Your fingers will feel the structures you are piercing. So get acquainted, get an educated fingers. What are all the structures we are piercing are skin, subcutaneous tissue, then the supraspinous ligament, interspinous ligament, and then ligamentum flavum. Every day and day out, you people are all going through these structures as an anesthesiologist. So the same technique. Here one more pic so that you can know what is this. This is the supraspinous ligament, then the interspinous ligament, this is the ligamentum flavum. After you through the ligamentum flavum, there you will have a pop-up feel or giveaway feel. You can use the loss of resistance syringe with a saline or an air or mixed saline and air, then you know whether you are there in the epidural space or not. So I am not going to tell all these techniques because every day you are doing that. We will be dealing in detail to the transforaminal because we are not doing that every day as an anesthesiologist. So interspinous, interligamentum I am not stressing much. So this is where the fluoroscopy looks like. It's the L5 and the L4 and L3 vertebrae after positioning. Then aspiration and injection of the contrast, where the contrast should go. If you inject the contrast, it should go in some specific place, that you should know. Then the final position of the needle tip is confirmed by performing an aspiration and injecting a contrast. Then 2 cc or 1 cc of contrast you can inject, and the dye spread should be in the epidural space without intravascular or intrathecal or subdural spread. This is how it should appear in the fluoroscope. Then what are the complications of interlaminar? The same complications what you see in the epidural anesthesia, but little more because we are using some steroids and also some dye. So extra epidural placement of the needle can happen, intravascular placement of the needle can happen, preferential cranial flow of the solution. We need usually the down flow of the drug, but sometimes it may go up. Preferential posterior flow of the solution. We need anterior flow, it may go to the posterior flow. Then sometimes we have difficulty in placing the epidural syringe because of the surgical status of the patient, and difficult placement below L4, L5 interspace also can be seen, and deviation of the needle to the non-dependent side. We need some side and it will go to the non-dependent side. We encountered dura puncture so many times, and it should not happen, but it will happen sometimes, and trauma to the spinal cord is the last complication. Then there are a lot of complications for the injections, what we do every day: infection, bleeding, trauma, now spinal cord injury, paraplegia, dural puncture, and post-punctural headache, then intravascular injection and embolism, rare complications, air embolism. Yesterday I have seen a case outside that after epidural they have encountered on the CT, they have seen an air in the brain. This is an air embolism. I also shocked me after epidural. Can we see this? This is reported. It is there, very rare, but it is also a possible complication. Then contrast related complications like renal shutdowns and all. Then before injecting the contrast to the patient, get a creatinine done, then only go and inject the contrast. Don't think that we are injecting only 0.5 ml, 1 ml or 2 ml, but it can happen even with 0.5 ml also. Then medication related allergies, very, very important. While we are injecting, only some patients may go into shock if they are allergic to some drug what we are doing. So take the history properly. They will not give you the history, patient will not give you. You have to elicit the history. Then coming to the transforaminal approach, very important approach. Usually they are doing, all the pain physicians, they are doing transforaminal approach, and this is what as an anesthesiologist we are not doing much as anesthesiologists, so this is important for us. the purpose and objective of transforaminal. Why should we go for transforaminal? Anyway, we are going for the interlaminar, where we are injecting the drug into the epidural space. But what is the necessary to go to the transforaminal is, this is to deliver the corticosteroid very close to the site of pathology. Suppose you have identified the pathology in a single nerve root, you can directly go and block the nerve root. No need to give the injection to the total area. Like if you give it L4, L5, it will come down and block all the nerves. Here, you are specifically blocking it only inflamed nerve. So this is more advanced technique, only doing what you need, not disturbing other nerves there. Whereas caudal and interlaminar, as I already told you, they affect the presence or absence. Sometimes the drug what you have given may not reach down, or may not reach the correct place where you want the drug to go. Maybe because of where the ganglionic pain center of the nerve is located. Hence, blocking the transmission and processing of the painful stimuli. But this requires fluoroscopy, and technical skills are required for this. So what are all the 3 different types of approaches or techniques to the transforamen? Well-known approach is the classic subpedicular approach, and next is the Rast technique, and then next is the Jasper technique or retrodiscal technique. So we'll see what are the differences in these 3 techniques. Classic subpedicular technique, the position of the patient is prone with the pillow under the abdomen. Position of the C-arm, you have to take initially AP view of the lumbar spine. Squaring the inferior end plate of the level to be blocked. First, square the inferior end plate. See which level. I already told you, you can take a metal thing and then artery forceps or whatever. You can align that artery forceps at the level where you wanted to block. Then square the inferior end plate. Then go for an oblique view till the facet joint lines are visible and a Scotty dog view is obtained. Scotty dog view is new to us, so this like as an anesthesiologist is new, but for a pain physician, every time they will use the word. Lot of times I heard this word through Murli sir, because he used to tell when we joined Scotty dog. As an anesthesiologist, we didn't know what is Scotty dog. Then he used to show us this is a Scotty dog appearance. From that time, wherever the spine is there picture, our eyes are trained to see only spotty dog there, but we cannot see every time. It is only in the oblique view you can see the Scotty dog here. So this is a Scotty dog with broad legs, very big snout. This is a Scotty dog here. This is the head, ear, then the snout, front leg and hind leg. Small dog, you have to see it. Definitely it will be seen in the oblique view. So this is the Scotty dog. If you see from here, the nerve roots are come. That means just below the junction of the head and the body, the nerve roots will be coming down. This is a trajectory view, the inferior end plate and the superior end plates. Then the Scotty dog. From here, the nerve root will come out. Fluoroscopy is manual till the tip of the superior articular process of the level below is positioned below the pedicle of the level to be blocked. That is here. The superior articular process is below the level to be blocked. This is the superior articular process. You can see here. Then the skin entry point is chosen immediately above the superior articular process. Skin infiltration is performed and the block needle is inserted and advanced down the beam till the bony contact is made with the inferior aspect of the pedicle. Using a direction, depth and direction 3D technique, a lateral view is obtained and the needle can be advanced in small increments to slide off into the rostral aspect of the foramen with a tip in the mid or in the ventral aspect of the foramen. Slowly we have to go into the direction, you go inside, take the depth and then again go inside. So 3D technique, direction, depth and direction. If the paresthesia is encountered at this level, the tip is withdrawn about 1 millimeter and then the final view can be obtained with the needle tip lying inferior to the pedicle. You have to see that the tip should be inferior to the pedicle. That is the final position, and then you can go on. After confirming the final position of the tip, aspiration should be done should not be any blood in that. Then you can inject the contrast using the live fluoroscopy. If you inject the contrast, it should be like, it will be moving like this. The contrast should spread medially from the needle tip through the foramina around the pedicle, covering the segmental nerve with some epidural spread without intravascular uptake. Ask the patient to speak. We are giving a contrast to the patient. Continuously interact with the patient. There is no need to give any sedation here. Only local anesthetic will be sufficient. And the local anesthetic and steroid is then injected to the volume of only 2 cc or 2.5. That's all. Not more volume is required here, because we are specifically blocking a nerve root. Whereas in epidural and caudal, we need a lot of volume there. But here we are only going and blocking a single nerve root. 1.5 or 2 is enough. If you give more volume, that volume will compress the nerve coming out. So transforaminal approach after the contrast, it will be like this. It is moving medially up. Coming to the Rance technique, second technique. This here we are using a blunt needle with a curved tip. Little bit technically difficult, but as people say, this is, here you directly go hit the bone. So technique is different. Whichever way you are use it, depending upon the clinician point of view, you can use. And the blunt needle with a curved tip is used with an introducer to avoid the complications here. The technique follows most of the basic steps like of identification in the Scotty dog and all. Everything is same as in the subpedicular technique. The major difference here is the target point is the ear of the Scotty dog. Earlier the target point was the junction between the head and the body of the Scotty dog. Here it is the ear of the Scotty dog in the Rance technique. The needle is advanced till the bony contact is made with a superior articular process. There we have to maneuver or see the Scotty dog, the junction of the body and the head, you have to keep the needle. Here only you have to direct your needle to the ear of the Scotty dog. Tip of the needle, after go and hit the superior articular process, the needle tip should be turned 180 degrees to face laterally, and then slowly the needle it is slipped into the superior articular process, and the tip of the needle is then rotated back again to the 180 degrees to curve back towards the foramina. That means we are slipping into the foramina here in this technique. We are hitting the superior articular process, then slowly slipping into the foramina, and again coming not coming back, but we are directing our needle tip towards the nerve root. The needle is advanced till it pops through the intertransverse ligament. Coming to the Jasper technique, here this is described as retrodiscal technique. This is also called as retrodiscal technique. Everything is similar to the lumbar discographies. Ram sir was telling discography they are doing so many like US people are doing discography. Here in Gandhi we are not doing any discography. I don't know, maybe Dr. Murli sir is doing the discography. So it is a variation of one of the variation of transforaminal injection only, where radiographic spread of the contrast is described using more oblique ventral caudal approaches in the epidural space. And this is useful in patients with discogenic causes of radiculitis or back pain, specifically disc causes. So if you see here, this is a simple way because I was also confused about all these techniques. So this is a simple diagram where you can know what is the difference of the techniques. See, this is the nerve root. Yellow one is the nerve root coming out. Red is for retrodiscal or Jasper. Red is for retro. And then blue is the subpedicular, that is the Scotty dog head. Black is for the Rance technique, ear of the Scotty dog. Clear? So all this, sorry. If you can see here, you can, anywhere you can block the nerve. 3 techniques. So yellow color for the spinal, blue classic subpedicular, black retroneural, and red is for retrodiscal. That is Jasper technique. Then if you see the transforamina, you will see a term called safe triangle. What is this? This is a fluoroscopic view. This triangle is a fluoroscopic view of the transforamina. So the safe triangle is formed, that is it is not existing there. How we are viewing that Scotty dog, this is also a safe triangle view in the fluoroscopy. Base, it is the base is formed by the pedicle, and the outer vertebral body of the intervertebral foramina, the triangle, I am describing the triangle, how it is formed from of the base of the pedicle, outer vertical border of the intervertebral foramina, then the connecting diagonal nerve root and dorsal ganglion. So this is the safe triangle. So why you should use this safe triangle is, the needle placed into the safe triangle will lie above and lateral to the nerve root, and the target landmark is inferior aspect of the pedicle with the needle placement. Just below or at the position of the 6 o'clock position, you have to put your needle in this safe triangle so that you are lateral to the nerve root. Because it is called a safe triangle, because only the spinal nerves and blood vessels exits in this space, and but as I said, blood vessels, it is again you have to keep in mind what are the blood vessels they are coming in this space. So while approaching the safe triangle, very careful, because artery of Adam quiz is present in the safe triangle in 75% of cases. It usually comes from the aorta at the level of T9 to L1. So at the T9 to L1 level, it usually comes to the intervertebral foramina in this safe triangle area. So if we are blocking, and some in rare cases it may come from L2 to L4 level, at L2 to L4 level also. So if we are going and blocking in a safe triangle, putting the needle in the safe triangle, always see, be caution about this artery, which is the main source of anterior spinal artery. Again, if you can see here, this is the safe triangle above the nerve root. This may cause sometimes irritation of the spinal root during the injection in cases of severe spinal stenosis, because there is lot of congested space there. So going and putting a needle in this space sometimes causes severe pain of spinal stenosis, and going in this space is not easy in cases of epidural fibrosis, spinal stenosis, intervertebral disc degenerations. So an alternative transforaminal approach is a Cammin's triangle. If you are unable to go into the safe triangle, then one more triangle is described, that is a Cammin's triangle approach, in which the needle is located in the inferior posterior or lateral view, reducing the risk of irritation to the spinal root. If we are going into the safe triangle and in the cases of spinal stenosis or epidural fibrosis or some disc problems, you can go into the Cammin's triangle. What is Cammin's triangle then? This is a triangle formed by the path of the spinal nerve itself, and the upper border of the lower vertebral body, and the inner boundary of the upper vertebral pedicle. This approach reduces the nerve root stimulation, not like in a safe triangle approach, and the tissue damage around the nerves, and it prevents the tissue damage around the nerves and prevents the venous congestion and nerve edema and epidural bleeding also. So this approach carries the risk of injecting the contrast medium into the disc, because this triangle lies directly on the disc. This is the Cammin's triangle. Earlier, if you remember, the safe triangle was here, and this is the Cammin's triangle. This is very nearer to the disc. If you can see here, this is the artery. In a safe triangle, where the artery is coming out, if you go into the safe triangle, we should be cautious about the artery. Here, we should be cautious about the disc, because we are injecting the drug or contrast like epidural steroid into the disc. So you should be cautious when you are using the Cammin's triangle approach, but it is safe because arteries are not there here in this triangle. So if you see, both of them are represented in this one pic. This is the safe triangle, and this is the Camden's triangle. Here you can see this is the area of the location of the artery of Adamquiz. So from here to here it may come from anywhere. So if you don't want to go and do a damage to the artery, you can directly go into the Camden's triangle. But we have to keep in the mind that we can directly go and inject into the disc. One more pic. I think this is clear here. This is the Camden's triangle and this is the safe triangle. Then you can use the ultrasound guided also for the transforaminal injection. Then what are the precautions? This is a risky procedure because we are directly going onto the root or ganglion. So avoid injury to the nerve root and then arteries. We are injecting a particulate matter, so cautious about the blood vessels. One more pic of the blood supply. So you can see all the blood is surrounding, and wherever you go into the transforaminal, you can hit an artery. So it is ideal to keep the needle tip in the posterior aspect of the root canal, above or below the nerve. So Camden's triangle approach is better, I feel. So how effective is the transforaminal when compared to the interligamental? So comparison of interlaminar or transforaminal, there is a study here. The conclusion is transforaminal epidural injection for the treatment of lumbar radiculopathy result in a better pain relief than the interlaminar, but the differences was not statistically significant. So coming to the complications, intraneural injections, then neural trauma, technical difficulty because you are directly going into the foramen, intravascular injections, then spinal cord trauma. Coming to the caudal epidural steroid injection, every day in and day out, pediatric cases will be using caudal anesthesia. So anatomical part is same. Lowest portion of the epidural system and is entered through the sacral hiatus. It is a triangular bone that consists of the 5 fused sacral vertebra and articulates with the 5th lumbar vertebrae and the coccyx. So what are the indications for caudal epidural steroid? As an anesthesiologist, we will be using caudal anesthesia for the pediatric patients or for the post-op pain relief. But as a pain physicians, where we will go and use caudal epidural steroid injections? Disc herniations or spinal stenosis you can use. Sacral nerve root scarring. Coccydynia, a lot of patients with coccydynia will come. They will not be relieved with medications or exercises. Then you can go and do this caudal epidural steroid injection. Rectal pain, pudendal neuralgia, sacral fractures or post-radiation sacral radiopathy or sacral metastasis. With one finger you can locate the sacral hiatus, and the position, everything is same as any lumbar epidural steroid. This is the fluoroscopy view of AP and this is the lateral view. You can use ultrasound also to go and inject, but here the complications, you should know the complications first before doing any procedure. The requirement of the substantial volume of the fluid is more here in interlaminar or caudal. The volume is more, whereas in transforaminal the volume is very, very less. The dilution of the injected, we are using more of the volume, the amount of the steroid going to the nerve get diluted. The extra epidural placement of the needle can happen, intravascular placement of the needle can also happen. Because sometimes it will be fused, if you try also it cannot go because of atypical anatomy. We can go and do the dural puncture also. These are the complications. Now what are all the overall complications of the epidural steroid? Infectious, neurological, ophthalmological complications, very rare but they are reported. And then because of the dural puncture, then dural puncture complications as anesthesiologists we all know. But these ophthalmologic, neurological complications as a pain physicians we should know. Then take home or what are all the key points of this lecture? We are using corticosteroids because of their direct anti-inflammatory and neuromembrane stabilizing and inhibition of nociceptor C fiber conduction. Specific indications for lumbar epidural steroids are radiculopathy, spinal stenosis, post-laminectomy syndrome and low back pain syndrome. Absolute contraindications are coagulopathy, anticoagulant medication, sepsis, pregnancy, and local infections. Then fluoroscopy guidance ensures the proper placement. Therefore, the delivery of the medications will also be proper. Then tohai needle may decrease the risk of dural puncture because of it is blunt. And the technique, as everybody know, loss of resistance with air, saline, or the hanging drop technique. Then the transforaminal is to deliver the corticosteroid close to the site of pathology onto the inflamed nerve root. Then studies have demonstrated short-term benefits from interlaminar and especially in patients with radicular pain. Evidence for therapeutic lumbar transforaminal injections, they are strong for short-term and moderate for long-term in managing lumbar nerve root, and limited in managing pain secondary to lumbar post-laminectomy syndrome and spinal stenosis. Evidence of effectiveness of caudal epidural steroid injection was strong for short-term relief and moderate for long-term relief. The complications related to needle placement are infection, hematoma, formation of abscess, subdural injection, intracranial or air injection, nerve damage, intravascular injection, vascular injury, and cerebral vascular or pulmonary embolus. Pituitary adrenal axis, Cushing syndrome, osteoporosis, avascular necrosis of the bone, steroid myopathology, epidural lipomatosis, weight gain, fluid retention, and hyperglycemia, all because of the steroids what we are using. Any questions? Any questions? Thank you.
Thank you for the session, ma'am. It was undoubtedly a valuable addition to our knowledge base. Next, we have lecture on lumbar spinal stenosis pathophysiology, diagnosis and treatment by Dr. Muralidhar Joshi. As already told by Dr. Ram sir, Dr. Muralidhar Joshi sir is a president of the Indian Society of Pain, Study of Pain, and also director of Pain Management Center, Citizens Hospital. Welcome, sir.
Morning everyone. I know you had 2 lectures and all. It's not that easy in the morning, like such a pleasant morning, going through some hard stuff. Probably, most of the anesthesia postgrads, like I also started my innings like you. We're used to seeing chest X-ray or something maximum, but not the spine X-ray. A lot of things are being shared and all. It might be tough for you, but I'll try to keep it as simple as possible. My topic is about lumbar canal stenosis. So you can see the picture there, probably what exactly I wanted to convey. You just see the canal over here, right? Right here. You can see here, it gets narrowed and again opens up, right? That's what exactly what we're talking, spinal canal. Spinal canal, like many of us, we get the X-ray done for, I should say, for the sake of, what should I say, if you're doing the knee replacement or spine fixation and all. But how often you have seen that, you're in the spinal, but like you were there in the space, but no spinal fluid came. How many times it has happened with you? Anybody who has experienced? I experienced. How many of you experienced? The needle was in the space, the fluid did not come. If somebody did not raise, that means they are not in a spinal. You should failing sometimes, at least so that you become more successful in life. So always you should fail once at least. Yeah, that's good. What I'm trying to say is, it happens because the canal becomes narrow there. And that's what, because you see, for example, you ask for chest X-ray, but you're going to use subarachnoid block, spinal anesthesia. How many of you ask for X-ray spine? Including me? X-ray spine for all spinal? That's what I'm trying to say is, let's try to understand where exactly the problem. Without wasting much time, because we're running late, I just want to move to the next slide. Disclaimer, of course, I don't have any conflict of interest. I don't have conflict with anybody also, not even my wife also. I have surrendered myself, so no issues about that one. Today I'll keep it very brief and not to get it attacked and all. I'll define about what is lumbar canal stenosis and anatomy, pathophysiology, clinical features, management, investigations, and some of the treatment options and all. Lumbar canal stenosis basically is nothing but, I told you, I showed the first picture, basically canal narrowing. Normally the diameter of that particular is about anywhere between 10 to 12 millimeters, spinal canal normally. And it so happens as the become senior in age. It's quite common in elderly people. They say it's almost about 21% in asymptomatic individuals, 21%. In one of the studies, I was just checking in the Cochrane review, and they said 95% of people have lumbar canal stenosis. They may be asymptomatic, they may not be manifesting, but they might have mild symptoms. So there are two differences. One thing is acute canal compression causes definitely major disability. A gradual compression, you get adopted to that one. It's very important like that. So that's what we have to understand. It's also called as cauda equina syndrome. You know about that one. Yeah, this is the most, I think probably this is the third lecture you're seeing this picture, I think probably. But I have to tell you about this one, because once I tell you about this picture, my lecture will be much faster than what exactly I'm speaking right now. This is the classical axial section, what you might be seeing for the spine as such. When you get the spinal subarachnoid block, I know most of the people are from anesthesia department. You go from here, supraspinous ligament, interspinous ligament, then ligamentum flame, and you reach the fluid here, and you tap the fluid, right? But look at the boundaries, what here. This is the diameter of about 10 to 12 millimeters normally we say. And if you just look at it, where all this canal can get squeezed, that's a spinal canal, right? Just imagine you are probably the road in front of this medical college, Gandhi Medical College, right? Just imagine, before we had the metro, the road was much wider. Then we had the median, road became smaller. Then we have the side shops, road has become much more smaller. Then we have vehicles parking next to the road. So that's actually a classical example of Gandhi canal stenosis. Yeah, that's better. Sometimes you should smile also. Other life becomes very tough. So basically here what I'm trying to say is the disc can come down to compress the canal, or ligamentum flame can get hypertrophied to compress the canal. This is a spinal cord, what you doubt are nerve filaments. Or the facet joints can get hypertrophied. If the superior article process gets hypertrophied, it causes lateral canal stenosis, where root goes out. And if inferior article process gets hypertrophied, it causes central canal stenosis. Just you have to know, this can come down, this can go up, these two can come inside. That's canal stenosis. So what is the best treatment for canal stenosis is, what's the best treatment for the road in front of Gandhi? Right? Widening? Road widening? Yes or no? That's it. That's what you're supposed to do. That the lecture is over. Right? So moving on to this one, let's on the pathophysiology, what you might see. Just look at the canal, like in the previous slide, just see. This was, I told you, about 10 to 12 millimeters. Right? And just look at this one. This is spinal canal. Can you see here? Now what is here? Just see the canal diameter here and here. Up to say now 10 to 12 millimeter, we say up to 7 millimeter, you can still be managing. But anything beyond 7 millimeters, you definitely become symptomatic. You definitely become symptomatic. And people say up to 5 millimeter they take, but anything less than 7, it's a bit tough. We should be ready for that one. So basically, what are the back pain conditions? I think Sridevi has spoken, and Dr. Ram also spoken. I don't want to talk about anything else, all these things. I just lumbar canal stenosis, 2 to 12%, they say. But I'm telling you, it's almost 21% canal stenosis, symptomatic for back pain. People might be having canal stenosis, they may not be symptomatic, or even if they're symptomatic, there is a correction from the nature. There is a correction from nature. I'll come to that one. So these are some of the conditions, reasons for the, should say, lumbar canal stenosis. For change, I would like to start with acquired rather than congenital. Acquired osteoarthritis is part of the aging process, bulging disc, thickened ligaments. I explained to you with the picture, spinal fractures, injuries, spinal cyst, tumors. Anything compressing canal is called lumbar canal stenosis. Congenital, you might see achondroplasia under like a short-statured people, spinal dystrophism and congenital short pedicles, osteopetrosis. Not that common, but quite common is acquired one, what you see. And pathogenesis, they say basically, of course, it's quite a busy slide. If you can read, you read. Others I'll tell you. Because of osteoarthritis or some injury or some trauma, or because 50 years you are there, living on this earth and all, and naturally you're using your spine, you're bending forward, picking something from the floor, you did cooking, or you did driving, or you did jumping. All those things lead to some amount of wear and tear, body has to compensate. It forms the, whatever the, I would like to say, it can form the spurs, it can form the adhesions. All these things literally narrow that particular area over course of time. Probably what was, if you look at the Gandhi Medical College picture maybe about 40 years back versus what you see now, you can see the road, what exactly it was. That is lumbar canal stenosis for you. So basically what I'm trying to say, it's part of the wear and tear, don't look at it like a disease. Now, is it something what we're seeing now? No, it was there from age-old time. I'll show you some pictures also. So how will it present? How should I pick up? It can present gradual onset of pain and paresthesia. You may not realize that I'm having. Probably anybody above 50 years who's sitting here, that includes me also, we might be having it. Probably as of now, we may not be symptomatic. We might become symptomatic. For some people, it progresses. For some people, it doesn't progress. We don't know what exactly the reason. So that is one thing we have to understand. So how will it present? Patient might have radiating pain into thighs and legs. Can also tingling numbness on walking, which gets reduced by sitting. Symptoms, claudication can be either constant or intermittent, or sometimes they might be having, may not be having. It has to be differentiated from vascular insufficiency because that also causes significant symptoms. That's what Dr. Ram was mentioning about checking the dorsal spinatus and posterior tibial. These symptom complexes are called as Cauda-Equina syndrome definition. Of course, this is central spinal stenosis. I told the lateral one is one thing. That lateral is canal sideways. Central is what central you get in the midline. Diffuse thigh numbness, pain and heaviness. Patient walk with a stoop forward gait. Right? Because you are from the village, if you have seen anybody village, or maybe you might be getting patient, so walking stick. Right? This opens up the canal because the spinal cord has little flexibility to raise up little bit. From the canal diameter, this one, it moves up. That's where people tend to walk like this. So that was the correction, nature correction, which is there, which you might be seeing in villages. We did that spine surgeries earlier, but they were also living. Now also they are living. How are they living then? Right? So for everything, there is a correction from the nature. So that's how it is exactly. Question. So question loss of lumbar lordosis is quite often seen. Motor, sensory and reflex changes depend on the degree of compression, how many roots are compressed, what is not compressed. This can present 21% of patient, I told you already. Sometimes radicular pain, especially it might simulate a disc pressure and all because there is a facet hypertrophy because the root gets pinched on the lateral canal. Okay, now who is this person? Yes? That's your medical college, right? He is a classical case of lumbar canal stenosis. Right? That's your medical college. What I'm trying to say, like this stick serves multiple purpose. One is, it opens up the canal. When he holds hands like this, it opens up the canal. Because spinal cord has little bit movement. It's not fixed. Roots cannot slide little bit. So that opens up. So he is comfortable. But only thing is, they will not be able to walk for long distance with that. If you just, I don't know how many of you are from village and all, I don't know, but I am from a village. So usually the elderly people who are about 65, 70 or something holding stick and all, they walk from home, walk for about 100 meters, stop, take a look at the world, and again they walk and take a look. Maybe another 100 meters, they'll get that, I don't know what you call, Panchayat Katti we used to, and what do you call that particular, what do you? Chopal. So they'll go and sit there, other elders will join there, they chat for some time, again probably for lunch time, again they'll walk back. That's the ritual, that's the schedule. But this is what I'm trying to, this is your medical college, right? This is what I'm trying to say. Second thing is that stick also helps you to have control. When you're walking in the house also, it helps you to control because suddenly you might fall down. You want to hold something. But this stick holds you stable there. You can stand in the middle of the hall, middle of the road. And also it wards off the dogs and cats if at all there on the road. And also because of sound, people know that somebody is coming. It has multiple purpose. Don't look at a stick like that. No, it has multiple purpose. It's something like your mobile phone. So many things you can do on phone. You can call, you can do banking business, you can send SMS, you can see, watch YouTube and all. The stick has a lot of things. But when the grandfather is sitting at home with the stick, if he's not using it, the grandchild will use it like a horse. And how many of you did that one? I did that one. For me, it was a horse actually. So I used to run around the entire house with a stick. So it's multiple purpose. Without wasting much time, the investigations and all, quite commonly we use X-rays or maybe MRI, and again you can just see that one, because why I prefer MRI, of course X-rays are very important, first line only, MRI you can just see it here, it's a facet hypertrophy, what you can see it over here. So it's very important that because advantage of MRI is, it can talk about soft tissue also, disc also, it can talk facet also, adjoining muscles, nerves and all those things it can talk. This is the X-ray actually, you can just see it over here. The listhesis, can you see here? This is the whole spine here. The listhesis, you can see the air in the disc. Of course, that's physiological, that's nitrogen, don't think it is infection. So this is where the listhesis happens and this goes and presses into the canal. So these are all pictures, some of the pictures of lumbar canal stenosis. It can be from anywhere, encroachment can be from anywhere. And this is a picture I was trying to say about, like diameter, if you just look at it, they measure the diameter and all. somewhere and come here, it becomes almost about maybe somewhere here. You can just see it's less than 7 millimeters. They become symptomatic. They become symptomatic. So that's where we have to look at it, how to reduce this. Up to 7 millimeters, definitely you can do certain treatments and all, which we'll be discussing. This again some of the picture. Just look at the spine. It's quite a busy spine, right? Just see 1, 2, 3. What are you going to do apart from decompression? So it's pretty important for us to understand this is a facet joint effusion, what you're seeing, the fluid over here. It takes some time for you to understand this MRA and all, because I know your background is anesthesia, like you do post-graduation. You may not be knowing many of these things, but as you read, but just listen, lumbar canal stenosis is nothing but traffic jam in the spinal canal. Am I right? That's the only thing you have. Your option is road widening. Whether you do it with like some injections or some surgery, it's your call. Again, same thing here. Malignancy, secondary deposits. You can see it over compression here. So basically, it's all compression. What you are seeing it here, basically you have to do road widening or whatever you have to do it over there. So treatment, consider treatment, not much of this thing. Actually, they don't. Many of them, they may not seek for help at all. Maybe in the city, some people who are active, they might be feeling, but especially in the villages and all, they don't come for any of the treatment. And especially what happens is beyond a limit when they cannot walk, when they have bladder bowel, the incontinence and all. I don't know how many if you really observe. If you just observe and you go to the village next time, they'll sit on the floor. They start crawling to the washrooms. I don't know how many of you really see in these things. If you're just observing life every day, you will know what exactly is happening. Either they are not aware of these things, even if such surgery, they don't want to come to city, and many things, maybe some help might be there and all might be done. But question here is, there is a time, but if you, probably next time when you do any of the surgical treatment, you see in your operating room, spinal decompression, if you just see, when they do the surgery, spinal decompression, laminectomy and all those things, you can just see, especially lumbar canal stenosis, they're doing decompression, you can see the spinal cord thinned out, or rather squeezed. You can say the higher side is about 8 millimeter, 12 millimeter. This year it will be 4 millimeter. You can see, if it's acute one, you can witness on the table expansion of the spinal cord. You can see it on the table. But if it's a long-standing one, long-standing compression, unlikely it's going to expand, but it will prevent further damage. So we should be always careful about that one. And of course, coming to rehabilitation with respect to, you have to do whatever the heat therapy, cold therapy, what you want to use, exercise, yes, fine. Physiotherapy and all, yes, all those things are quite useful, but question here is, if it's a mechanical compression, try to understand, we have to do decompression. Pharmacological options are there, you can give oral medications and other things and all, but that provides a pain relief. And it will not that every patient with lumbar canal should require surgery. Some people do well with medications, or some people might do well with some epidural injections and all. Some might require some surgery. The biggest problem why we are worried about lumbar canal, so more than the canal, the problem, I think Principal Dr. Ramesh Reddy sir is here. Sir, welcome, sir. Namaste. So the biggest problem with lumbar canal stenosis with all the numbness and other things is, what I see now, my biggest fear is more than the bowel bladder issue, it's the numbness. It's the numbness which creates a problem, because the person might fall. That leads secondary injury. So they might end up with fractured femur or something like that. So that's the biggest problem we should not forget. Bowel bladder dysfunction, because mechanical compression, again, cauda syndrome, the roots are getting compressed, he can go into bowel bladder dysfunction. Sexual dysfunction, of course, it may or may not relevant, but partial total paralysis, I have not seen that much of this thing. I have not seen these days anybody going because of this one. But biggest problem happens with their mobility gets restricted, and second thing what I've seen, they live for longer time, you get numbness and bowel bladder dysfunction, that's one thing. Bowel also will come more like a constipation, not as incontinent. And the bladder, of course, you can still manage the Foley's or something like that, but bubble is a bit difficult. So epidural steroid injections can be done like up to 7 millimeter, 6 millimeter, you can try epidural injection, definitely it helps you. But subsequently we have to look at that one, what exactly it helps or what it doesn't help and all. I'm again telling you, slowly developing stenosis is fine, patient might accommodate, but cannot accommodate, but something acute disc pressing on that one, it leads to definitely a major problem. This is of course, Dr. Sridevi spoke about the caudal injection and all, but only thing is you should be careful is, if I'm talking of this lumbar canal stenosis, when see normally even the cadaveric also, if you just look at the volume in the sacral canal, after taking out all the tissues inside the soft tissue in the sacral canal, it can accommodate somewhere between 25 to 40 ml. In lumbar canal stenosis, please don't try to inject more than 15 ml. or 10 to 15 ml is more than enough, because already that it's narrowed. In 10 15 ml also it goes pretty high. So please never try to inject more than 10 to 15 ml. Don't inject some 20, 25, 30 ml. No, it's not appropriate. Surgically, like standard what is being operated from the age-old days is laminectomy, because decompression basically. But subsequently, a lot of other things have come, like laminotomy, like laminoplasty, foraminoplasty, interspinous process spacers, and spinal fusion. Of course, I just going through Cochrane review and all. They say like compression to the what was standard technique of laminate compared to that one. Only spacer thing has some amount of improvement, but other things have not proven. But of course, doesn't mean that research should not go on, work should not go on. Work is good, research should be good, nothing wrong about it. But they say compared to even standard laminectomy, basically decompression, compared to that, only spacer has little bit slight advantage. Rest of things by and large, they are the same, that's what they say. The prognosis depends on location, how severe it is, how severe compression. It depends on overall health of the individual also. But only thing is, this is the penalty you have to pay for the verticality. Don't ask me, the dogs also get lumbar stenosis. I have not checked it. With these few words, I would like to say, to conclude, I would like to say, if you can't help the patient, please don't do any harm. That's always my dictum. Follow a protocol, don't be a trendsetter. Weigh the risks and benefits, select the patients, let patient on the intervention. But of course, update yourself all the time. That's what you are doing it. Once again, thanks to Dr. Ram and Dr. Sridevi and Ramesh Reddy sir and everybody for patient listening. Thank you very much. Once again, long live. I think we can take questions during the break time, I think, probably. Yeah, thank you.
Thank you, sir. Thank you for delivering such a lively and engaging lecture. Now, we'll have an inaugural ceremony now, just in 5 minutes. Sorry for the delay. Now, I welcome upon dignitaries onto the stage. Firstly, I welcome Dr. Ramesh Reddy, sir, Principal, Gandhi Medical College, onto the stage for the inaugural ceremony. Next, I invite Dr. Kameshwar Rao, sir, founder, father of pain management in Andhra Pradesh and first pain clinic at Rangaraya Medical College. Next up onto the stage, Dr. Prakash Rao, sir, Professor Neurosurgery. Sir is the first person because of whom we have actually started pain clinic at Gandhi Medical College in his own OP. Next, Dr. Lingaya, sir. He's the founder of Alumni Gandhi Medical College, also the President Alumni Medical Educational Society. Next, I welcome upon to the stage Dr. Murlidhar Joshi, sir, President of Indian Society for Pain Study of Pain and Director Pain Medicine of Anesthesia at Citizen Specialty Hospital. Next, I welcome upon to the stage Dr. Pradmaja ma'am, who is a professor of anesthesia at Nizam's Institute of Medical Sciences. Next, I welcome onto the stage Ram sir, Ram Possibility sir, who is a course director and president of Kentucky Society of Interventional Pain Physicians and director of Center of Pain for Management in Bowling Green, USA. Yes, sir. Next, I welcome onto the stage our dynamic professor, Dr. Sridevi ma'am. So now let's start the inaugural ceremony with a prayer song by our PG, Subha.
Good morning, professors, and good morning, sirs and ma'ams. My name is Shubha, and I'm going to sing a prayer song. Om Ganita Fani Gana Mani Gana Kiranairarunita Nijatanu Ravita Tavadana Tata Tata Lutadali Kula Kalavinadu Ganapati Rabhimata Mihadishadituna Lambodharavara Kunjavastita Kunkuma Varnadharam Shveta Srungam Pina Suhastam Pritita Safala Falam Nagatrayayuta Nagavibhushana Nanaganapatitam Tattam Nanaganapatitam Tattam Nanaganapatitam Tattam Nanaganapatitam. Thank you.
That was really amazing. So now, lamp lightning by all our dignitaries. I welcome Dr. Murli sir, Professor Anesthesia, Gandhi Medical College, and Dr. Nagarjuna Chakravarti sir, Professor Anesthesia, Gandhi Medical College, for the lamp lighting ceremony.
Madam, I request Dr. Sridevi ma'am to present memento to Principal Ramesh Reddy sir.
Next to Dr. Kameshwar Rao, sir. I request Dr. Sudha ma'am to present memento to Dr. Prakash, sir. I request Dr. Padmavati ma'am to present memento to Dr. Lingaya, sir. I request Dr. Chandravati ma'am to present memento to Dr. Muralidhar Joshi, sir. I request Dr. Sirisha to present memento to Dr. Padmaja Durga ma'am. I request Dr. Soumya to present memento to Ram, sir. I request Dr. Saraya sir to present memento to Dr. Sridevi ma'am, our organizing secretary. Now I request Dr. Ramesh Reddy sir, our principal, Gandhi Medical College, to speak a few words.
Good morning to you all, the dignitaries on the dais, the organizing secretary, Dr. Sridevi Garu, Dr. Ram Pasupuleti Garu, Dr. Lingaya Garu, Dr. Kameshwar Rao Garu, Dr. Prakash Rao Garu, Dr. Padmaja Garu, Dr. Joshi Garu, and all the senior faculty members in the audience, Ayashekar Garu. I'm really glad that the pain management, which is not really has taken up like what it has happened in the Western world, it is now slowly picking up in India, and especially with the NMC bringing it into the curriculum of the medical education, it is definitely going to pick up in the days to come. And I congratulate the organizers for organizing this third interventional pain management course. And the importance of this, only the person who experiences that pain will realize. Because the main topics what they are taken today, especially the back pain and the knee joint pains, which are very nagging and crippling, and which will totally alter the quality of life of that particular individual. And everyone at that particular age, especially some of them are seen in the older age groups, may not be fit for any surgical intervention, and they need some, I say that some palliative care wherein they will get relief from their symptoms and they will be able to lead a normal life. I'm glad that Dr. Sridevi took the initiative and started a pain clinic here. And I think definitely it should be taken still forward, and we need, the other day when they came, I was just discussing with them, we should explore the possibilities of instituting fellowships also, because a degree which you get should have credibility. These type of programs will definitely give an insight and practical training to all our colleagues, but at the same time, to build up that field, we need to have qualified people who can go around and spread it, and so that more number of centers can be established in various medical colleges and in the institutions also. I know that many of the private corporate institutions already have these centers, but it's not really taken up in the government institutions, which I think is the need, because the maximum number of patient load, especially with these type of symptoms, they come to the government sector, and that need to be taken care of. And I'm glad it has already started in Gandhi way back. It's not just new. It is how many years, madam, now? 17. It has started way back, and I'm sure this will be the trendsetter and will be a guiding force for similar centers to be adopted and started in other medical colleges, because we have 26 government medical colleges as on today, and there are a lot of private colleges. Nearly totally it comes to 56 medical colleges. If all of them start a pain clinic, because they have the faculty also, I think it goes a long way. So I congratulate the organizers for this initiative, and I am sure for the next 2 days, with the amount of clinical material which is available in Gandhi Hospital, a lot of live programs can be conducted, and any time in future for this type of programs, the Gandhi Medical College will be in the forefront to extend a helping hand. Thank you all.
Now I request Dr. Kameshwar Rao sir to speak a few words.
Very good morning, everyone. First of all, let me profusely thank the organizing secretary, Sridev Garu, and Sriram Garu for personally inviting me for this program. Actually, I have come on a family visit to this place incidentally, and fortunately, this happened on these days. I said I will definitely attend for some of the sections, and Ram Pasupuleti is closely associated to me from 2007 onwards. He conducted a beautiful workshop in Apollo Hospitals, Kakinada. At that time, the government setups were not that competent to have all the equipments and all these things. So he conducted in a private setup. That was the big corporate setup available. So he demonstrated all the epidural administration of injections, lumbar and cervical, and given a lot of inspiration to all the people. Actually, the Pain Society started in combined Andhra Pradesh in the year 2004 by me as an inception president. And in 2009, we have conducted a major event of National Conference of ISSP. Dr. Muralidhar Joshi was the organizing secretary and myself was the chairman. And a very good number attended, and in the same Gandhi we conducted a very major event, and it was a very successful national pain conference. And this pain is a very evolving branch, and it is a multidisciplinary. Every specialist is involved in pain management, not only anesthesiologists, physicians, surgeons, orthopedicians, radiologists, psychiatrists. Everyone is involved in pain management. It is multidisciplinary. And you know well, particularly the postgraduates, you should know the difference between an acute pain and a chronic pain. Acute pain is a purposeful, meaningful pain. You see in a post-operative pain, labor pains, trauma pain, it lives short-lived, 2 to 3 days. You give good amount of opioids or other NSAIDs, and relieve the patient's suffering. Whereas in chronic pain, it erodes deep into the patient's psyche, destroys both physically and mentally. It is particularly herpetic in post-herpetic neuralgia, trigeminal neuralgia. They are intractable pains. They ruin the patient life. So for these things, pain clinics are very essential. And we, after failing all the conservative methods, you can go for interventional procedures, which are very well advanced nowadays. And we have got spinal cord stimulators, though they are expensive. And also all modalities, even intrathecal pump administration of narcotic drugs in very low doses. So the pain management is very much advanced nowadays. And I am glad that most of the postgraduates are showing interest in getting the training in this pain field. And our principal sir said fellowship is a very good the move that is raised by him. And by fellowship of 1 year, you can learn a lot because of your constant exposure to the pain management. With these few words, I wish this conference and workshop a grand success. Thank you all.
Thank you, sir. Now I request Dr. Prakash Rao, sir, Professor Neurosurgery Department, the man behind our support system, for organizing this and also starting the pain clinic at Gandhi Medical College.
Good morning to everybody. It's a pleasure to be associated with pain. Pain is one thing I was interested, probably 20 years back I just started, but I did not continue for a long time. Basically, I'm not much into the interest into the benign pain management. I always used to look at the palliative care, particularly the malignant pains, refractory pains, as more interested. And I wish probably in Gandhi, maybe we should start that, particularly the terminally ill malignant patients, the pain is really painful. So I think if we can give something for them. Anyhow, that needs neurosurgical contribution also. Probably if the pain team here starts, maybe I can give some sort of support from the surgical point of view. And I wish the pain team at Gandhi will try to do that. Thank you for giving this opportunity. Thank you very much.
Thank you so much, sir. Now I welcome Dr. Lingaya, sir, founder of Alumni, to speak a few words.
డాక్టర్ రమేష్ రెడ్డి గారు, ప్రిన్సిపాల్ గాంధీ మెడికల్ కాలేజ్ గారు, వేదిక మీద ఉన్న పెద్దలందరికీ, మా ఆలమ్ని కొలీగ్ రవీంద్ర సురకంటి గారికి, ప్రతాప్ రెడ్డి గారికి, లింగమూర్తి గారికి, రాజశేఖర్ గారికి, ఆర్గనైజర్స్ అందరికీ, పెయిన్ మేనేజ్మెంట్ కోర్స్ అరేంజ్ చేసిన ఆర్గనైజర్స్ అందరికీ, ఆహ్వానితులందరికీ నా హృదయపూర్వక నమస్కారాలు. ఈ అలమ్ని మెడికల్ ఎడ్యుకేషనల్ సెంటర్లో ఈ ప్రోగ్రామ్ కండక్ట్ చేస్తున్నందుకు కూడా మీకు ధన్యవాదాలు. మా పర్పస్ ఆఫ్ కన్స్ట్రక్టింగ్ ది ఎడ్యుకేషన్ సెంటర్ ఈజ్ ఫర్ ది ఎడ్యుకేషనల్ ప్రోగ్రామ్స్. ఇది కూడా ఒక ఎడ్యుకేషనల్ ప్రోగ్రామ్. దీన్ని మీరు ఇక్కడ కండక్ట్ చేస్తున్నారు. మా అలమ్ని తరఫున అందరి నుంచి కూడా ధన్యవాదాలు. ఈ ప్రోగ్రామ్, ఈ థర్డ్ ఇంటర్వెన్షనల్ పెయిన్ మేనేజ్మెంట్ కోర్సుకు మా శుభాభివందనాలు తెలియజేస్తున్నాను. ధన్యవాదాలు.
Thank you, sir. Now I request Dr. Mulidhar Joshi, sir, to speak a few words.
Dignitaries on the dais and off the dais. I think already here in the lecture, nothing special I would like to say. I got sweet memories of coming to Gandhi Medical College because I must have conducted not less than 15 live workshops here, sir. Both live and cadaveric and forced. Dr. Ram was here when we did a national conference here. So it's almost quite frequently I keep coming here and all that. But this hall also is quite affectionate for us because it's a beautiful laid out hall, a 200-seater from the alumni team with all the, probably about 6 rooms upstairs, am I right, sir? 6 rooms upstairs, and we have got a canteen area also in the -1, good parking area. And I think we should utilize it more frequently is the word I would like to say. We should use it more frequently. And Principal Sir, as he rightly pointed out, starting fellowship, that will be very much welcome at this point of time. It will be very useful also. But in case you want to start also, like already we have started DM in pain medicine in our AIMS institutions, sir, for your reference only, because in the meetings and all. And also like FNB pain medicine also has been started. And also PDCC pain medicine is still going on in BHU and then SCPJ Lucknow. Now they're coming with, I think probably you must be aware, PDAC, that's 2-year course, other than DA. In fact, I don't know why exactly it's being done or is it true. They're trying to cut down the DM courses, I think. That's what I was hearing from the NMC meetings and all. So this is a 2-year course, PDAC, a postdoctoral advanced course. Maybe something like that we can start, probably we can take initiative in that one. That will be good, because that once it starts, then automatically the students, they start working on all those things. Probably you'll be supplying you become supplier to all the suppliers. So what I'm trying to say, it will be a great initiative, sir. It will be a great help for the society and all. If not for you, who else was going to do? Because you have been with me almost for so many years. We have been working together, but it will be a great opportunity for us, sir, if we can start either fellowship or PDSC, whichever you think is appropriate. With these few my words and wishes, I once again congratulate the organizers for conducting a fantastic program. Our supports are always with the college, sir, always with the college. Thank you once again. Long live.
Thank you, sir. Now I request Dr. Padmaja Durga ma'am, very talented and dynamic professor of Nizam's Institute of Medical Sciences, to speak up.
Good morning to everyone and greetings to all the members on the dais. I think I should congratulate Dr. Sridevi for taking this initiative of starting and also encouraging the education in pain. In one way, I think Dr. Sridevi is very fortunate. She has got the support of the neurosurgeons, which is very essential, and also a dynamic principal in Dr. Ramesh Reddy, who is going to encourage her. And I think there's a big pain society behind her, and Ram, who is supporting her all the time. I think, but you know, all of us have support, but not everyone takes that initiative to go forward, and I congratulate you for taking that initiative forward. It's wonderful to see all the youngsters here willing to train themselves in pain management, which is very essential, and probably in future that's going to be one of our career options. And if there is an opportunity for you to pursue your career further in terms of fellowships or postdoctoral diplomas, I think all of you should think in those terms, because interventional pain management is one of the future careers, and you should actively pursue it. And I hope this workshop will take you forward in that direction. Thank you.
Thank you so much, ma'am. With this, we conclude the inauguration ceremony, and I thank all the dignitaries for gracing the inauguration ceremony.
Thank you so much, sir. Dr. Ramesh Reddy, sir, he was a constant support in starting pain management. He was a DME at that time. When I went to tell him that we are going to start, he was very supportive. Whatever help you want, directly you can ask me. Because as Padmaja ma'am told, maybe I am really fortunate to have Ramesh Reddy sir at that time, and the superintendent at that time, Dr. Shravan Kumar. When I went and asked him to start in pain clinic, he said, okay, very good, you can go and start, but first go and look a place where you wanted to start. I didn't have a place in the OP. So when I'm thinking, it is Dr. Prakash Rao sir, a neurosurgeon, head of the department at that time, professor neurosurgery. He said, why don't you sit in our OP where we don't have OP for 2 days? So those 2 days, you please go and sit in our OP. So in that way, he has given a room for the pain clinic. So behind the starting of the pain clinic, it is Dr. Superintendent sir, at that time Dr. Shravan Kumar sir, and Prakash Rao sir, HOD neurosurgery, and Ramesh Reddy sir. And Dr. Murlidhar Joshi, he is my teacher, and because of him only, I already told in the morning, I had an inclination to the pain management. I am very much impressed by seeing his techniques, his teaching, patience. So that is the first time I was introduced to the pain. After I finished my MD here, immediately I joined him. At that time, we don't know that separate thing is there for pain in this, before maybe 18 years back, I joined him. At that time only, he used to do everything what are all doing now, endoscopy, everything he used to do at that time, 18 years back, 20 years back he used to do. So I got inspiration from him, and after coming to the Gandhi, then I thought, why don't we start a thing here? So like that it started, and behind this, first of all, inspiration is Dr. Murli sir, and next is Dr. Ramesh Reddy sir and Dr. Shravan Kumar sir and Prakash Rao sir. And then Dr. Ram sir has incidentally find my name from Dr. NVN Reddy sir, because he is his classmate. He wanted to start a pain clinic in Gandhi. Then already we have just started 4 months or 5 months, and we are struggling how to go forward. I was always calling Dr. Murli sir, what to do, this patient came, what to do, how to proceed and all. So it's Dr. Ram Pasupuleti who said, I am behind you, you go forward, I'll support you in all the ways. Then he donated a RF machine to the Department of Pain, like to the Department of Anesthesia only, to move on for the pain works what we are doing. So he is always supporting the department for doing the work, always constantly calling me and giving me the inputs and pushing me. If really he'll push me to do all these works. As Dr. Padmaja ma'am told, it's really, I'm fortunate to have all these people behind me to start this program. Thank you very much, sir. Thank you very much, madam, to coming here. Dr. Padmaja madam is a real inspiration as a lady anesthesiologist, head of the department at Nizam's Hospital. She has started a pain clinic there, and madam is constantly working towards making this as a separate branch or getting the fellowship there. So as Dr. Ramesh Reddy sir told, getting a fellowship is not, we wanted to get it, sir, but as we want training also for our people for that. So thank you for that, sir. Thank you. Thank you. This is a very big responsibility against on my hand. Thank you very much, sir. Thanks for coming here. I would like to call Dr. Ram, sir, to speak a few words.
Now it's break time. Probably everyone is wanting a break, right? So I'm not going to take much time. The next coming up is a very important topic. It's Advaita Vedanta, and I would like you to be there for that. And I think we'll take a break after that or something like that. It's a unique topic. It's the first time in the world that this is being done. So you're making history while you're being here. So nobody has talked about Advaita Vedanta and pain management in the same, in the same thing. So it's a very important topic, at least for me, and I'll tell you why I'm going to do this. But before that, I want to thank everyone here who's there on the stage. With every single one has been so important for us to get started. Dr. Prakash Rao Garu, as Sridevi madam said, and Kamesh Rao Garu was an inspiration. He was the first one to start pain clinic in Andhra Pradesh. So we have everyone, I have learned so much from them. And that's what inspired me to do this. Sir, I will take your word for the fellowship, sir. So you have promised it, so you're going to give the fellowship to us. So, yeah. So we're going to work. The next thing that I'm hoping to do is the fellowship in Gandhi Medical College, and Dr. Ramesh Reddy said it very right. You can have 1,000 certificate courses, but nothing like having a university given fellowship. So nothing like it. There are plenty of certificate courses going around, but my goal is to get a very proper, appropriate academic fellowship, and which is what he has promised us, and he has never failed us. So give him a big hand one more time, please. And thank you, everyone, and thank you everyone here who's here, and all of you guys for coming. And we'll get started with the next lecture. Thanks, sir. Thank you.
Good morning, everyone. The next lecture is by Dr. Ram Pasupuleti, our course director, on Dr. Prithviraj Memorial Lecture, Advaita Vedanta, Consciousness and Pain Management.
All right, guys, so pay attention, close attention. So, like I said, this is history being made. So, even if I say it. How many of you know what Advaita Vedanta is? Show of hands. You should know. Moksha? Moksha was my student, so yeah, she should know. Seriously, guys, anyone? Advaita Vedanta? Anyone? Anyone? Not anyone? Dr. Rajshekhar knows. Yeah, Aham Brahmasmi, okay. So, and this is, I'm instituting the Prithviraj Memorial Lecture. So, and I'll tell you why there is no, I mean, I'm not going to go through the disclaimer again, but I have to tell you that I used information from Dr. Manchikanti. I borrowed a lot from Dr. Manchikanti, and then from Ramakrishna Puligandla's textbook of Indian philosophy, and then Swami Sarvapriyananda's lectures. So, start off with Endaro Mahanubhavulu Andariki Vandanamulu. My favorite Vagyayakara, Tyagaraja. So, and Andariki Peru Perna, Vandanalu. I think Lingamurti garu, did they leave? So, I wanted to thank them. So, every single one here. So, I'm doing this for a reason. Dr. Prithviraj was my guru, my teacher, right? So, I trained under him. How many of you know Dr. Prithviraj, of his name? So he's the single biggest name in pain management in the world. So, and he was my guru. I was fortunate, privileged to be his student. That's Dr. Prithviraj himself. Fulchand Prithviraj Borondia, fondly known as Raj, right? So he's a pioneer and world leader in regional anesthesia and interventional pain management. International leader in pioneering interventional pain management with the development of multiple training programs. He was the first one to start pain fellowship programs in the United States. So he started it all, and you see my passion, where I get it from him. So he's the one who started fellowships and stuff like that, and that's what I want to do. I want to start fellowships in India as well. So, and he did that 40, 50 years ago. And he's published a lot of articles, numerous publications. And if you know pain management as a distinct specialty today, we owe it to Dr. Raj. Dr. Raj has made pain management a specialty, not a part of anesthesia. It is a specialty because of Dr. Raj. And he was the founder of the American Society of Regional Anesthesia, Texas Pain Society, World Institute of Pain, and he instituted the FIP examination. Some of you may have taken that examination, the FIPP examination given by the WIP was instituted by him. And he founded so many journals, Pain Practice, Pain Digest, and that was his first textbook of pain, practical management of pain. He was a prolific writer, published hundreds of peer-reviewed manuscripts, book chapters in 13 books, and that was another book. Both these books I have donated myself to Gandhi. So you will find them here in Gandhi. Because, and I was fortunate enough to proofread that textbook. I was his fellow when he was publishing that textbook, the second one. One of the chapters he gave to me to proofread, so I was so fortunate to do that. So he was born in a small village near Jaipur. He went to school in Bangalore and then graduated from Mysore Medical College, moved to England. He did orthopedic surgery, surprisingly. Actually, he wanted to be an orthopedic surgeon. But fortunately for us, for all of us, he switched to anesthesia when he moved to United States. And then he finished his residency in Norway. He did 2 years of residency in US and then one in Norway, which is what I followed the same path. I did 2 or 3 years of residency in the United States and 1 year in England. So I did almost the same way that he did. So he won several awards. I mean, it's countless. I can't count how many awards he got. That's the Gaston Labat Award that he's holding right there. And of course, yours truly next to Dr. Prithviraj, right? So that was at my place, my home in Lubbock, Texas. I invited him, and he's sitting next to me. I was so privileged to have Raj sitting with me. My association with Raj was when he was my guru, my teacher at Texas Tech University with Dr. Rats. And Dr. Rats also is another big name. So I was one of the last fellows that Dr. Raj trained. I was one of the last fellows. And these are the three big names that you see now. Dr. Rats on the left, Dr. Manchikanti, whose namesake you're sitting here. The auditorium is named after Dr. Manchikanti, Lakshmaya Manchikanti. He donated this. If you are standing today, that's because of Dr. Manchikanti. He's my guru as well. I work very closely with him. He's the president of the American Society of Interventional Pain Physicians, and I'm the president of the Kentucky State Chapter. You can see with Rats, Dr. Raj himself, and that's me getting an award from Dr. Manchikanti for Distinguished Service Award. And then, of course, Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma Tasmai Sri, Gurave Namaha. My respects to my teachers. So that's why I instituted this lecture, and it's going to be a continuous thing. Every year we will do this lecture. I'm doing the first lecture, and I'm hoping we can get speakers of national and international repute for this lecture starting next year. Objective of this talk, to discuss, compare, and contrast the concepts of consciousness as described in the ancient Indian knowledge system Advaita Vedanta with its modern-day scientific understanding and interpretation, to explore and apply future possibilities in the field of consciousness studies to the field of pain management, to understand and treat pain as a part of universal awareness, right? Does everyone understand consciousness? Yes? You're all anesthesiologists, right? You better understand what consciousness is, right? Because you're knocking people down every day, right? You're making them unconscious, right? So you better understand what consciousness is. So we're going to talk about what Advaita Vedanta is, what consciousness is, what the hard problem of consciousness is. Has anybody heard about the hard problem of consciousness? I guess not. So we'll talk about it. Pain and pain management, how we can combine Advaita Vedanta and pain management and the consciousness studies and the way forward. This is how we're going to talk about it, right? So Advaita Vedanta. Surprisingly, lack of knowledge, I think, here. I've seen barely one or two hands go up. And that's another reason why I'm doing this. Because if we do not know our knowledge systems, who is going to talk about it? Right? If we don't talk about it, are Westerners going to talk about this? No. No, we need to talk about this, right? So, and it is our responsibility to talk about this. And I see quizzical faces. What's this Advaita Vedanta? No, it's nothing to do with religion. Absolutely nothing to do with religion, right? This is a knowledge system. It's a knowledge system, right? So we are talking about a knowledge system. So Advaita Vedanta is one of the most important philosophical and knowledge systems of India that have been an integral part of the ancient tradition and culture of India. Vedanta is one of the Shad Darshanas. Has anyone heard about the Shad Darshanas, the 6 philosophical systems? No? Okay, a few here. So, which may be paired, according to some scholars, pair them, right? Yoga, Sankhya, Nyaya, Vaisheshika, Mimamsa, and Vedanta. Who has heard about yoga? Come on, guys. Everyone? Right? Yoga, everyone knows yoga is, right? What is yoga? Twisting yourself into knots? No. Yoga is an ancient knowledge system. It's not just twisting your body into knots. The Ashtanga Yoga, it's called Ashtanga Yoga. They have 8 parts to the yoga. And only the asanas are only one part of yoga, right? Everything else is a philosophical system. So, and Nyaya, Vaisheshika, Mimamsa, and Vedanta, these are all the Shad Darshanas, the 6 orthodox systems in India. The Indian knowledge philosophical systems encompass the full spectrum of metaphysics, ontology, epistemology, psychology, ethics, and they form the building blocks of scientific inquiry. So if you are talking about science today, right? If you are talking about any kind of science, these are the building blocks. Metaphysics. Metaphysics is the original, how did things start, right? That is metaphysics, right? Ontology, the original state of being. Epistemology, the theory of knowledge. If you don't know this, you cannot do science. What are we doing here today? Doing science, right? We're all, what? Scientists, right? So, but if you don't have the basis of this, you can't do science, right? So that's where we borrow our knowledge from. Vedanta is the theoretical part of the Mimamsa Vedanta pair of the philosophical knowledge systems. You see the pairs there, right? the Yoga Sankhya. Sankhya is the theoretical part, Yoga is the practical part. Vaisheshika is the theoretical part and Nyaya is the practical part, and so on and so forth. Vedanta is the theoretical part and Mimamsa is the practical part. Everyone knows about theory and practical, right? Every subject you have, it has a theory and practical. So do they. We learnt our systems from there. If we are doing theory and practicals, that's because of that, right? So, Vedanta Nama Upanishad Pramana. So what does that mean? Vedanta is derived from the Upanishads. How many of you have heard about Upanishads? Yes? Which are a part of the Vedas and also the highest teaching. Veda Anta. Anta is not end in the sense here, it is the highest learning of the Vedas. Right? Vedantam. Vedantam antam kada. Vedantam ante the highest learning of Vedas is the Upanishads. Advaita Vedanta is one of the schools of Vedanta which gives us the non-dual interpretation of the Upanishads and the Brahma Sutras, right? What is Advaita? Dvaita. What does Dvaita mean? Two. Advaita means not two. It's different, slightly different, right? You can say one, but it is not two. There is a reason why they say it's not two, right? They can say one, right? But no, it's not two. And I'll tell you why. Because what do you see as reality here, right? So you see two realities. You see what you see in front of you is one reality, right? And then consciousness is one reality. So that becomes Dvaita, right? So, but Advaita is only one, not two. So we'll get that here. So Advaita is non-dual, not two. One ultimate reality, right? One ultimate reality in the world. So when you go back to the metaphysics or the ontology part, go back all the way. How did all this start? And there's only one reality in this universe. And that's called Brahman, right? You can substitute the word consciousness for Brahman. Consciousness for Brahman. So as scientists, what do you call reality? What do you call reality, right? What you see is reality, right? Right? Fair? So, but what do scientists consider real? Space, time, matter? These are the real things that we talk about, space, time, and matter, right? So, but more fundamental than that is consciousness. Brahman is the sole reality, imperishable, unchanging reality underlying every sector and facet of the world of change. The one reality that is omnipresent, eternal, unchanging is consciousness. That is called Chaitanyam or Samvit or Chit. Right? So, again, guys, there is no religion to this. It is not a talk on religion. This is plain and simple science. Right? So, I'm talking about consciousness. The ultimate reality is Sat, that is pure existence. Chit is pure consciousness. And Ananda is bliss. Satchidananda, have you heard of the term? Satchidananda, Sat, Chit and Ananda. Sat is pure existence, Chit is pure consciousness, and Ananda is bliss. That is the nature of a human being. That is the nature of a human being, Sat, Chit, Ananda, right? The world of our senses and intellect is merely a world of names and forms having no reality apart from Brahman. So what you see around us is name and form, right? You see a chair there, it's a name. It has a form, right? The world of names and forms have no reality except for one ultimate reality, that is consciousness. Just think about this, guys. If you don't have consciousness, do you have anything? Anything. Minus consciousness, do you have anything in the world? Do you? Really? You don't, right? So that's where the fundamental reality goes back to consciousness. So there are Mahavakyas in the Vedas. Some of these you know. Prajnanam Brahma is pure consciousness is Brahman. It is from the Rig Veda, Aitreya Upanishad. Ayamatma Brahma is this self is Brahman. Mandukya Upanishad. Tattvamasi. Right? This is from the Chandogya Upanishad and Samaveda. And Aham Brahmasmi. Some of you may have heard the term, right? Aham Brahmasmi. I am Brahman, right? So here, wherever you see the word Brahman, substitute it with consciousness, right? So Pure consciousness is Brahman. So this self is Brahman. This self, what you call yourself, the self is Brahman. That thou art, that you are, is consciousness. So, bottom line, all these statements, the Mahavakyas taken from each Veda, they all make the message very clear. Consciousness, awareness is a fundamental or ultimate reality. That's what all of them proclaim loud and clear. Consciousness is the fundamental or ultimate reality. Now, let's talk about consciousness, right? So, we all are anesthesiologists and we deal with consciousness every day. It has been a very elusive concept to define, and there is wide disagreement as to what it is and how to explain it, right? All of us know what consciousness is, but it is very difficult to explain it. The etymology for consciousness comes from the Latin term con, is together. Seo is to know what means, that means knowledge shared with others, right? But we don't use the definition of consciousness in those terms now, right? So it is not knowledge shared with others. The origin of the modern concept of consciousness is attributed to John Locke in 1690, Essay Concerning Human Understanding. Locke defined consciousness as the perception of what passes in a man's own mind, right? That's fair, right? So what is consciousness? What passes in our mind, that is consciousness. The two neurologists, Plum and Posner, in 1972, described consciousness having two components, right? Content of consciousness and level of consciousness, which is what anesthesiologists deal with every day. You classify awareness as two, right? So anesthesiologists say arousal and awareness, right? Arousal and awareness. Arousal is wakefulness, how alert a patient is of an individual to respond to stimuli. Awareness is the content, right? The content of the experience. Awareness of self and environment. How is he reacting to the environment, right? So, being conscious of something. That is the awareness. So, all of you agree so far? Yes? Anesthesiologists? Can I hear a yes? Okay. Usually Vedanta puts people to sleep. So, I hope... Hopefully you are awake. So the content of an individual's subjective experience is comprised of their sensations, thoughts, emotions, memory, imagination, and other psychological processes, right? So the modern scientific interpretation of consciousness, as we know, is an epiphenomenon, right? It's an epiphenomenon, meaning what? It is a byproduct of the physical and physiological processes of the brain, or what we say as the brain produces consciousness. Fair enough? Yes, as anesthesiologists, what do you say? The brain is producing consciousness, right? Wrong. So the brain does not produce consciousness. The consciousness produces brain. That's the whole point of Advaita. So we consider consciousness as an epiphenomenon, as the brain producing consciousness, right? That is what we are told, that is what we are drilled, that is what we grow up with, right? So science can explain most neurological processes like our modes of sensory perception, including pain, motor activity, being awake, discrimination, by the physiology of neurons firing. So we explain all of that, right? Neurons are firing there, neuronal pathways are there, neurotransmitters, receptors, physical biochemical processes. All those are easy problems to solve, right? They are easy problems because we explain everything, right? We explain how the pain goes from a periphery. There's a pathway that it takes it to the brain, nice and everything. There are neurotransmitters, acetylcholine, GABA, whatever you want to call, right? We can explain all that. Those are the easy problems. Now here comes the hard problem of consciousness, right? Hard problem of consciousness was devised, the word was devised by David Chalmers. He's a philosopher, and he's at the NYU, New York University. He heads the Mind, Consciousness, and Brain Unit. He's one of the most advanced or the best philosophers in the world that I know of personally. And he said, he coined the word hard problem of consciousness. So you may be thinking, what is the hard problem of consciousness, right? What is consciousness? So why is it hard to understand? David Chalmers, in fact, cites the example of the experience of pain. In fact, he cites pain as an example for the hard problem of consciousness. So you're walking around, right? You're walking around and stub your toe. You yell in pain. right? That's a common thing. You stub your toe, you yell in pain. The easy problems are explaining the mechanistic explanations, right? Such as the propagation of nerve signals. You can explain it. You have read it in the textbook. So there is a pathway that takes from the injury to the nice pathway to the spinal cord to the brain, and you have explained it nicely. So, but that is the easy problem, right? That is the easy problem to explain. So, but how you, okay, the signal is processed in the brain, and then it gives the order for the motor brain to yell. So you've explained that. Very nice. But that's the easy problem. But what is the hard problem? Is the question of why these mechanisms are accompanied by the feeling of pain. Why do you feel pain? Right? Why do you feel pain? That is the hard problem. And why these feelings of pain feel the particular way that they do. The rich inner feeling of subjective experience, something it is like to be me, right? Something it is like to be me. After the famous thought experiment by Thomas Nagel, what is it like to be a bat? In 1975, he wrote the paper, what is it like to be a bat? So what is it like to be you? That's what we are talking about. That's the hard problem of consciousness, right? One of the most familiar facts for us is the subjective experience of qualia, but it is also one of the most mysterious. That is the hard problem of consciousness, right? So physiological processes explain at most structure and function, which is not sufficient to explain consciousness, right? So all of you know fMRIs, right? fMRIs, functional magnetic resonance imaging. So what do? They map the brain, right? When there is pain, one area of the brain lights up, right? What have you explained there? That is correlation. That's not causation. You don't know why it's lighting up, but you can say it's lighting up. So that's correlation, it's not causation, right? So correlation cannot be causation. Modern science takes a reductionist approach and reduces consciousness to a brain process. Like I said, we think that the brain is producing the consciousness, right? So Advaita Vedanta begs to differ. It begs to differ. What is the definition of consciousness? It's very difficult in modern terms to define it, but Advaita Vedanta had a very clear definition several thousand years ago. It defines as anidam chaitanyam. What is anidam? Anidam. Idam is this. An is not. Not this is consciousness. What an elegant definition. What a superb definition for consciousness. Not this is consciousness. So this room, this table, this computer, this person is not consciousness. These are objects in consciousness. Anything that you can say, this is not consciousness. So that's the definition of consciousness in Advaita Vedanta. Prajnanam Brahma, pure consciousness is Brahman, Aitareya Upanishad, right? Brahman is, or consciousness, just substitute the word consciousness, guys. Whenever I say Brahman, substitute it with consciousness. Is that which is not comprehended by the mind, but by which the mind comprehends, right? So Brahman is that which is not comprehended by the mind, but by which the mind comprehends. Consciousness and awareness is the fundamental ultimate reality. Once again, I ask you, what do we do in modern science? Modern science considers space, time, and matter as fundamental concepts. Everyone agrees to that? Space, time, from Newton to Einstein. Everyone, space, time, and matter, right? These are the three things that we consider as fundamental. But I want you to all think of this in this way. So consider space. What is space? Space is here, space is there, right? Space. So it is in your consciousness, right? Take consciousness out. Do you have the concept of space? Do you? Right? Here and there, both are in your consciousness, right? So if there is no consciousness, there is no space. So space is within consciousness, right? Consciousness is not in space. What about time? The concept of time. Yesterday, today, tomorrow. All of that is in your consciousness, right? If there is no consciousness, there is no time. There is no yesterday. There is no today. There is no tomorrow. If there is no consciousness. So science considers time and space as fundamental realities, right? But there is a more fundamental reality than these two, which is consciousness, right? So that's what the whole point of this is. What is matter? What do you see around you? Everything is matter, right? But even that matter is in your consciousness. Take consciousness out, you don't have. Matter disappears like that, right? Matter disappears like that if you don't have consciousness. Poof, gone. Matter is gone. So when you say matter is a fundamental concept, then if there is no consciousness, there is no matter. So matter is in consciousness, consciousness is not in matter. So that's the whole point of what Advaita makes, right? So how do we talk about pain and pain management, right? I'm not going to talk about all these theories. Most of you know this. We started with the specificity theory, which René Descartes gave us in 1600 something. Everyone must know René Descartes. René Descartes was a philosopher. He gave us the famous dictum, cogito ergo sum, I think, therefore I am. He was the last Western guy, philosopher, who made any sense. I think, therefore I am. He was talking about consciousness. I think, therefore I am. So he was the one who gave us the specificity theory. You know the specificity theory, right? There is injury. Injury causes damage. Damage causes the receptors to fire. And there's a pathway that takes the signal from the area of the injury to the spinal cord, and then it takes to the brain. That is a specific pathway. That is a specificity theory. So what did we do with the specificity theory? We blocked nerves, right? We blocked that pathway. And we cut pathways at that time. Chordotomies were done, right? Chordotomies were done because there is a single pathway, nice, we know there's a pathway, so let's cut the pathway. Na rahegi baas, na bajegi baasri, right? So very simple logic. We use that. So there's a pathway, why don't we cut it? And that's it, done. So as simple as that, we thought, and chordotomies were done in 1950s. And then came the pattern theories, right? They're refinements of the specificity theory. Then we got the gate control theory. How many of you know of the gate control theory? Right? Yeah, so Melzack, and he gave us the gate control theory, and that made us think a little differently. Gate control theory, the brain came into play at the first time. There was a gating mechanism in the spinal cord, and then there is a descending control from the brain. That's what Melzack said at that time. So then we started doing what? Spinal cord stimulation, TENS units. Acupuncture was accepted as a modality of therapy only because of this, because we started thinking about other things, right? So, and then Melzack gave us the dimensions of pain. Then we talked about phantom limbs. And finally, Melzack gave us the neuromatrix theory in 1989, right? And that's when we started using mirror therapy for phantom limbs. Till then, psychological things were all were thrown away. Say there is no role of that, but there is a role in that. So slowly, we've changed some from the evolution of the specificity to the neuromatrix theory. We have changed some in our science. Our understanding of pain mechanisms evolved gradually from the simple concept of pain as a sensation produced by injury, according to the specificity theory, to the concept of pain as a multidimensional experience produced by multiple influences, according to the neuromatrix theory. Modern studies, including neurobiology and molecular biology, delineate the role of nociceptors, peripheral and central sensitization, inflammatory mediators, transductions, ligand-gated ion channels, neurotransmitters, the role of microglia. I can go on and on and on about pain mechanisms, right? This is what we learn every day. Neuroanatomical studies are taking us deeper into the study of excitatory and inhibitory interneurons, plasticity of spinal nociceptive pathways. And neuroimaging studies are showing us the multiple regions of brain that are activated, that are lit up during pain and CNS mechanisms of pain perception and modulation. So we are doing neurobiology, molecular biology, neuroanatomical studies, neuroimaging studies. They're all taking us in one direction. Yes, there's a progress being made. But even if the evolution of our knowledge has been important in recent decades, patients are still suffering, right? Patients are still suffering with pain, even today. From chronic pain conditions that are not responding to available treatments. Two patients with apparently similar pain conditions will not respond to the same treatments, right? You have seen this. You have seen this. They both have facet arthropathy. You do facet block, it works on one person, it doesn't work on the other person, right? So we can only conclude that our understanding of the complexity of pain is still incomplete, and that we need more translational research from fundamental studies to clinical applications and vice versa. Right? So we need more research in doing fundamental and clinical aspects of this. So more and more in-depth studies into neuroanatomy, physiology, molecular biology are providing us with some understanding, but at times leave us with more questions than answers. So we are going deeper into neuroanatomy, neurophysiology, but sometimes we end up with more questions than answers. Sometimes taking the 30,000-foot view. So pull yourself back and take the 30,000-foot view, taking the big picture into consideration may provide us with both better understanding and answers. for what we are looking for. Consciousness studies is a developing field which is very promising and may explain our very basic sense of perception or the sense of being and feeling, right? What we feel every day, the sense of being and feeling. We can talk about that more in consciousness studies, right? Consciousness studies in the way forward, I'm trying to wind this up. The knowledge and philosophical systems of India from ancient times have given us tremendous insights into consciousness. So they have talked about consciousness 5,000 to 6,000 years ago or even more. Advaita Vedanta is not, a few years old. It is so old. And they have talked about consciousness as a fundamental reality at that time, right? From the ancient Sankhya epistemology to the modern day Advaita of Vivekananda, consciousness is described and considered as a fundamental reality. So even in India, we consider consciousness as a fundamental reality, right? Modern day philosophers and neuroscientists are reviving the concept of consciousness in the form of hard problem of consciousness. That's what David Chalmers brought up. He said that is the hard problem of consciousness, which we have talked about several thousand years ago. Now, who won the Nobel Prize in 2022? These three guys, right? Aspect, Zellinger, and Clauser. What did they win the Nobel Prize for, right? It's a very strange phenomenon called the entanglement. So that proved the profoundly strange quantum nature of reality by way of establishing the existence of a bizarre quantum phenomenon known as entanglement, right? I'm not going to go into that. It's a very complex thing. So basically, there are two particles, right? There are two particles, and you don't know the spin or the momentum of one particle unless you know the spin or momentum of the other particle. That's why they're called entangled particles. So I'm not going to go very deep into that, but what my point is that they proved that quantum physics pushes the observer consciousness into the center of reality. So without an observer, we don't know what these particles are doing. Only when someone observes this particle, then you can know the spin and momentum of this particle. And automatically, the spin and momentum of the other particle changes to the opposite side because you have observed this particle. If you didn't observe it, you don't know what the nature of these particles are, which is the same experiment that Schrödinger. Have you heard of Schrödinger? Schrödinger's equation, right? Schrödinger's cat. So that's what he did. So what did he do? He put a cat in a box, and he put a vial of poison in there, and that vial may break, and he closed the lid. So from outside, what do you know about the cat? Is the cat dead or alive? Can be dead, can be alive, right? So that's the superposition. Only when you open the box, when you observe, you know the nature of that. And that's Schrödinger's cat, right? So further studies into consciousness as a fundamental reality may provide us with a deeper understanding of the inner workings of awareness and perception, leading to a more fundamental understanding of pain as a part of universal awareness, right? So among physicians and scientists, anesthesiologists, everyone sitting in this room have a particularly close relationship to consciousness, right? Why do we have a close relationship? Because you are knocking people down to sleep. You're putting them to sleep, right? With a temporary state of unawareness during surgery by putting patients to sleep. What do we consider anesthesia as? Absence of? Right? Absence of consciousness. Let's think about it a little differently. Do a paradigm shift in thinking. Consciousness of absence. Right? So that's the paradigm shift that we need to make in our thinking. Instead of saying absence of consciousness, it's consciousness of absence of anything to light up. Consciousness is still there, but it is not lighting up any objects. When you're aware and awake, consciousness is lighting up the objects in front of you, you are seeing them, right? But when you are in deep sleep, there is nothing to light up. So consciousness is still there. And that's what we as anesthesiologists we have to kind of do a paradigm shift in thinking. And that paradigm shift is coming from our own knowledge systems. It's not a Western knowledge system. This is our own knowledge system that tells us that there is a paradigm shift, right? We as anesthesiologists, and more importantly as Indians, with our background knowledge and understanding of consciousness from our ancient knowledge systems and professional expertise, can do further research to provide a more fundamental understanding of pain and pain mechanisms and provide newer solutions and options in the treatment of pain. That's what I want you to think about, all of you to think about for a second, about what consciousness is and how we think about it. I know you have been ingrained to think of anesthesia or deep sleep as absence of consciousness, right? But, turn your brain around and switch it and say it's consciousness of absence. With that, I'll leave you guys. I hope I got through some of it at least. I think I'll take questions later as we are. Yeah.
Thank you, sir. That was very interesting lecture. Now we will take short break of 15 minutes.
Yeah, you can ask the question in the break, guys.
At the outset, I would like to thank Dr. Sridevi and Dr. Ram for inviting me over here. I think my disclaimer is that I'm not an exclusive pain physician, but then, yeah, I have an interest in pain like all of you. So that's where probably that makes me stand here. I think if you are a physician, how many of you have heard or have had personal experience with some backache which you think is sciatica, or some patients coming to you with saying that they have a sciatica? All of us? I think even if you just put your name as Dr. so-and-so and travel in a train, I'm sure the person who is sitting next to you or around you will come and say, I have a backache. So I think that's as common as that. So one thing is, if you're looking at it in an entrepreneurship point of view, that means you have a lot of clientele. So that's something that probably this is the bread and butter of pain management for most of us. So to start with, I'll just start with a small case. So there's a 50-year-old female with a history of osteoporosis, osteoarthritis, diabetes type 2, who presents to the clinic with a 2-week-old history with a sudden persistent low backache. And she describes the pain as burning, stinging, radiating down the posterior part of the thigh bilaterally. So she was okay 2 weeks ago when the pain started suddenly after that. And she denies any history of trauma or illness, numbness or tingling or bladder ball incontinence. Now on physical examination, there's no tenderness on the lower spine. Hip flexion, knee extension, plantar flexion, dorsiflexion are good, 5 on 5. The lower extremity sensation is diminished along the medial part of the thigh bilaterally. The deep tendon reflexes for L4 are 3/4 on the left and 2/4 on the right. And S1, it is 2/4 bilaterally. SLR that we do elicits pain on the left side, and Faber test is negative bilaterally. Hypertonicity for the paraspinal muscles is not appreciated. So what is the diagnosis for this patient? Yes, one of you? What do you think is the diagnosis? Yeah, please tell me. Obviously, I'm talking about radiculopathy, so the diagnosis of this patient will be radiculopathy, isn't it? So I think I'll be asking a lot of questions, and I expect all of you to answer, okay? So what is the diagnosis for this patient? Radiculopathy. So what I'll be talking about is definition of the radicular pain and evaluation of the pain and treatment. I'm going to focus a little on the evaluation because probably sometimes that is where we as anesthetists are not really trained to evaluate pain, and we probably falter there. You are very enthusiastic to learn about the procedures, but when it comes to evaluation and diagnosis, maybe you don't really pay attention, so that is the reason why we are a little weak in that. So I am trying to focus more on the evaluation and treatment options of this. So at the end of this, I expect that you would be able to understand the etiology of the pain, understand the evaluation of the radicular pain, and also have some outline of the treatment management options that are available for this. So most of the time, as I said, people will come to you saying that I have a sciatica or I have a radiculopathy. So they think that that is probably a disease, but basically it is just a symptom like fever. So we need to evaluate that and understand what it is. So by definition, lumbar radiculopathy is a diffuse disease, a process that affects one or more underlying nerve roots and causing pain, loss of sensation, or loss of motor function, depending on the severity of the compression. So here, I mean, by definition, there is some compression on the nerve root, and this compression is going to cause an injury to the nerve root that results in inflammation and some discharges from this nerve root or from the dorsal root ganglion. And in addition to this, because the nerve doesn't travel alone, it also travels with a vascular bundle. So you have an artery and a vein that travels along with this nerve. So if it is compressing on the nerve, it is also going to compress on the vascular structures. And the most easily compressible is the vein. So once the vein is compressed, there's going to be some edema proximally, isn't it? So that is also one of the presentation or one of the pathophysiology for the pain. There's going to be some edema along with the irritation, and maybe if the obstruction or the compression is very severe, it is also going to cause ischemia of the nerve. So that is the reason for the damage to the nerve. So you have an inflamed nerve that is caused by compression, and then there is irritation. So lumbosacral, you know that there are 5 lumbar nerves and sacral nerves. So whenever this lumbar nerve is compressed, it is going to cause a pain along the root of the distribution. So there is a pain that will, obviously, the lumbar supplies the lower limb, so there is going to be a pain that radiates into the lower limb. Now, depending on the degree of compression, there can be weakness, or maybe if it is like in the sacral, you can have disturbance in the bladder bowel. So just a little bit of the neuroanatomy. So tell me, what is this? What am I pointing to? So you have the body of the vertebra, and then between the 2 bodies is the, little louder, intervertebral disc. So can someone tell me the components of the intervertebral disc? Yeah? Pulposus. Fibrosis. So there is some protection that it has, and it has a cushioning effect. And then, okay, tell me what are the structures that I'm pointing to? This one? Spine. This? Lamina. Okay, this? Transverse process. This? Facet. This? The pedicle. So, and then between this 2 pedicles is the neural foramen. And then you have the spinal cord that is surrounded by the layers. So now the compression can happen because of any of these structures that are around this neural foramen. So most often it is at the neural foramen that the nerve gets compressed, or sometimes it can get compressed at the level of the roots also. So you have a dorsal root and a ventral root and the dorsal root ganglion, and then these 2 join together to form the nerve. So the compression can happen anywhere from the root to the nerve level. So when we talk about the supply of the nerve, we talk in terms of the myotomes and the dermatomes that are supplied by each of these roots. So in general, like the anterior part of the thigh is supplied by L2 and 3. The medial part of the calf is supplied by L4. The dorsum of the foot is supplied by L5, and the sole is supplied by S1. So each nerve root and its dermatome and myotome form the autonomous zones. So what are the causes for this compression or the onto the nerve root? The commonest cause obviously is the herniated disc, and we have a whole lot of one full lecture on that, so I'm not going to go much into the details, but the common cause is the herniated disc. Next is the spondylosis that you commonly see, and then other causes can be either trauma or sometimes the degenerated area entirely, like it can be the disc or the bones, or there may be a bony spur or a spinal stenosis that is causing the compression. So in addition to all these, you also have to pay attention to the other factors that might be causative or that might be actually aggravating the underlying compression. One is diabetes. The most common thing is, I can see most of you are also sitting abnormally. So that is the biomechanics of sitting. So improper carrying of weights or improper sitting, unhealthy lifestyle, being sedentary, and that too sedentary in a wrong pose, can all lead to aggravation of this underlying disease process. So, and I think today's lifestyle is like prolonged sitting, and most of the chairs are not as comfortable, or probably the biomechanics are not properly designed, they are not ergometric. So there is a high probability that a lot of the youngsters would be suffering from these backaches. So in addition to that, poor diet, alcohol abuse, sometimes even pregnancy may be an instigating factor. So I just have a small movie here. So you can see that the herniation of the disc, actually it can be either because of the injury, or the herniation can happen because of the other degenerative disc processes. So what happens when so there is a degeneration that is going to destroy the protective annular fibrosis, which would result in the disc protruding. So this disc protrusion can be either central or lateral, and this would compress on the nerve root, causing irritation. So sometimes because of the degeneration, there would also be compression of these discs, and that will result in the change in the alignment of the vertebra as such. So this is going to cause compression. So this disc herniation can cause the pain because of the compression on the nerve roots, and it can also cause pain because of the compression on the dural matter or other vessels around the nerve. Okay. Now, what do we mean by spondylosis? I think that's the most commonly used and commonly abused term. So when we talk about spondylosis, it is basically the narrowing of the spinal canal and the neural phenomenon, or even the lateral process. So there can be several etiologies for the spinal canal narrowing. Dr. Joshi has given you details about it, but I'll just briefly go through it. So the etiology for this narrowing may be inflammation, infection, trauma, vascular disease, or even neoplasm. And the reason why it is important for us to know is we should know what we are actually dealing with. Most important thing is every patient comes to us with pain, but then unless you understand the etiology, you would not know whether the patient is someone where you can do an interventional pain management, or it is someone who you have to refer to the neurosurgeon. So therefore it is important that you have to understand what are the other etiologies that can result in this. So because of this spondylosis, again there can be a nerve root compression, and it can also cause underlying ischemia or inflammation or edema. So what happens when there is a degenerative spine? So there can be a disc compression that is going to cause the change in the alignment, and that can cause compression, or sometimes there are degenerative changes in all the, so most commonly affected are the joints. So there can be an intervertebral joint or a zygapophyseal joint involvement, and there can be some osteophyte formation that can result in irritation of these nerves, compression of these nerves, resulting in pain. So why is it important for us to understand the etiology? So not just about when you have to refer, again the presentation can differ based on the etiology. Like everything is pain, as I said, but then like if you have a pathological fracture of the vertebra, so when it comes to localization, suppose someone says there is a pain along the L5 nerve. So the etiology or the damage may not, or the pathology may not be exactly at L5. It is the L5 root that is involved, but then the etiology or the cause may be somewhere else. So if you understand how these causes vary in terms of presentation or pressing on these nerves, it is easy for us. So if you have a pathological fracture of the vertebra, then the nerve root at the lower level is going to get compressed. And then when you have injury to the spine, probably it is more of the canal involvement, so it is at that level. So it depends on like, so this would probably involve the nerve root ganglion or at the foramen. So now how do we localize where the pain is? So can someone tell me if it is L1 to where does the pain start? What is the distribution of pain? anterior part of the thigh. Okay, so I will just again summarize what are the symptoms. So basically patient will present with a lower back ache that travels down the length of the leg depending on the route, and then this pain may be described as sharp or excruciating, or sometimes just a mild pain, or sometimes it is as severe as an electrical shooting type of pain. And this pain is aggravated by anything that is going to increase the compression, like cough or sneezing or when it is sitting. And depending on the degree of compression, there can be burning or numbness, tingling, pins and needle like sensation, sometimes muscle weakness if it is lasting, and occasionally there can be a loss of the bladder and bowel function. Now, if the patient complains of loss of bladder and bowel function, it is like an emergency, and that has to be immediately referred to the surgeon for further management. So L5 is the commonest to be involved, and then just a little bit on epidemiology. So about 70% will experience paresthesia along the nerves, 35% will experience pain that is radiating, and 27% will experience numbness, but motor weakness is present in lesser number of patients, that is 37. There can be loss of reflexes in about 40%. So what we have to understand is most of the time this lumbar radiculopathy can be a self-limited thing, but and it can present with radiating pain. Now, why is the muscle strength not involved most often, or why is there no weakness? Like even in the patient that I have started with, there was no motor weakness, isn't it? So why is it that there is less motor weakness in the presentation? So muscle is usually supplied by multiple nerves. So that is the reason why there can be a preservation of the motor power. But that doesn't mean that the motor nerve root is not involved in this compression. So all of you will have to start with the history first. So that is the most important thing that will probably guide you towards the etiology. So depending on the duration of the symptoms, whether there was any previous treatment, what was the results of the previous treatment, so all this needs to be taken in the history. And in the physical examination, you have to see for the limitation of the movement, whether the patient has any balance problems, pain, reflexes, examine the reflexes in the extremities, evaluate the muscle weakness, evaluate the loss of sensation, and also look for other signs of neurological injury like bladder and bowel involvement. And then decide whether any radiological imaging is required or not. That we will deal with in a detail in the next thing. So this is what you have to do when the patient first comes to you. Now, I was just asking you about localization. Can someone tell me, if it is L1, where does the pain start? And where does, so someone said? Anterior part of the thigh, okay. So L1 is upper part of the abdomen or the upper part of the leg. L2 is anterior part of the leg, thigh. L3 is, so you can see this. L4 is lateral part of the thigh going into the medial part of the leg. L5 is lateral part of the leg. And S1 is going to be the foot, posterior part of the thigh and the sole. So examine for the roots involved. Usually there can be a multiple root involvement. And then you also have to look at the disability that the patient has. So this will tell you how aggressively you will have to manage this patient. So motor weakness, you can ask about getting up from the chair or a history of knee buckling. So you also have to focus on whether there is anything else other than the radiculopathy that is also causing the pain. Like there can be a hip joint involvement or an SI joint involvement that are mimickers for the radiculopathy. So take the history properly and then look for weakness of the iliopsoas, quadriceps or tibialis anterior when the patient is walking, and examine the deep tendon reflexes and do an SLR. So see whether it is a radicular or a non-radicular type of pain, so that, and also look for the paraspinal muscles, and this is going to tell you whether when there is a non-radicular pain that is contributing to the pain. So how many of you have done an SLR? Can someone describe how to do an SLR? Okay, okay, you tell me. Yeah, there are 4 people sitting. One of you get up and tell me how do you do an SLR. Miriam. Okay, I think if Sridevi is not there, we'll incentivize. Now we'll give you a prize for telling me how SLR is done. No one wants a prize? It's written there, so simple. Huh? You just have to read what is already there. So you make the patient lay supine, and then you'll have to keep the leg in extension and then ask them raise, or you will flex at the quadriceps. So now how do you bring about the pain? So by dorsiflexing the foot, you can see whether there is an increase in the pain or not. So that is called the Lassac sign. And then you can look at whether so this is all to bring about the pain. So you see what is relieving the pain, and that is the Bostring sign. So you can localize the pain and then see which side is more affected, and also localize the root which is causing the pain. So, but there are certain caveats for this SLR test. What are they? So not every positive SLR means that there is a lumbar radiculopathy. There can be other reasons why the SLR is also positive. So that makes it more sensitive, but it is not specific for lumbar radiculopathy. So you have to do both the affected leg and the unaffected leg, and also see whether there is pain that can be. So you would do what is known as a 4 test, isn't it, to see whether you can look for other causes of pain. So whether there is a hip or a SI joint that is causing the pain. So the other thing is the hamstring reflex, or by tapping on the semimembranous and tendinosus tension at the popliteal fossa, you can elicit the reflex and see whether there is any radiculopathy. So I'll just detail about history and physical examination for these bundles of roots. So for L2, 3, we will bundle them together because usually the innervation is similar. So it is in the anterior thigh. So here the patient experiences a radiating back pain that is radiating into the anterior aspect of the thigh. And then it may progress into the knees or probably into the medial aspect of the lower leg. So here when you are examining, you will examine for the weakness of the knee extension, hip abduction and hip flexion, and look for loss of sensation over the anterior part of the thigh or along the area of the pain. And look for the patellar reflex, so which will show that L4 is the root value for the patellar reflex, isn't it? And then look for activities that are going to make the pain worse, like coughing, leg straightening or sneezing. And for L5, the patient will complain of a backache that radiates down the lateral part of the leg into the foot. And when you are examining, look for the muscle strength of the big toe. So that will be the extensor hallucis. And also for the inversion and eversion of the foot. So sometimes the extensor brevis may be involved, or you can see an atrophy, and that is one of the signs that says that it is L5 radiculopathy. And you can look at leg abduction by looking, so this will be an indication for the gluteus muscles. So if it is severe, the supply to the gluteus may also be involved, causing difficulty in the leg abduction. So for S1, there is a sacral pain or pain in the buttocks that goes into the foot or the perineum, and there can be a weakness in the plantar flexion and loss of sensation along the posterior part of the leg going on to the foot, and ankle reflex here is involved. So now we'll go back to the history of the patient that I've started with. So where do you want to localize the pain for this patient? So there is a pain that is radiating down the posterior thigh bilaterally, and hip flexion, knee extension are all normal. Affected part is deep tendon reflex of the knee. So where do you want to localize the pain? Which nerve root? L4. Yeah, right. So now, as I said earlier, like L4 is the root that is involved, but that doesn't mean that the lesion is at L4. Like for example, if you have a central disc that is protruding, then see where does the cord end? Anesthetic. So if there is a central disc protrusion, even at L2 or 3 also you can have the roots come down from there, isn't it? So you can have a root involvement there. And if it is a lateral disc of protrusion, obviously it will be at the level of L4-5 that the lesion is there. So depending on this, the root doesn't really necessarily mean that the particular segment in the spine is a problem, okay? So what are the caveats in the examination? One is, it is challenging to perform a thorough neurological examination. One is because we don't know how to do it, and two, you don't have enough time to do it. And then most often there is an overlapping innervation. So it is very difficult to localize to which part the patient has pain. So not everyone comes like a textbook description with a red line on it. No, so they will say, ikkadundi, 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 ekkadanna untundi. So there is a lot of diffuseness in the pain. So they would not probably localize it like how you have it in the picture. So it is difficult to identify where the pain is. And then there will be some pathology in the paraspinal muscles also. So that would also add to the pain. So you may not, it will be difficult for you to examine. So because of the pain, the patient may not really cooperate. And then most often, as I said, the muscle strength is preserved, even in radiculopathies, and deep tendon reflexes may be lost earlier. So you cannot think that there is no motor weakness, so there is no motor involvement. So if you have a loss of tendon reflexes, identify that there is a motor reflex lost. So these are some of the mimickers for the conditions. So differential diagnosis for the cause will be herniated disc, lumbar canal stenosis. Sometimes it is not exactly a structural problem, but it can be a physiological, the pathology, like in diabetes amyotrophy. There can be a vascular loss because of the microvascular damage that happens to the nerve. So the pain can be because of that. So there need not be anything that is pressing on the nerve, but it is the ischemia of the nerve that is causing the problem. Then there can be a lot of non-radicular bone pains, or sometimes it may be a fracture. And sometimes if you need to pay attention to the history, because if the patient comes with a fever, then it may be a discitis or an epidural abscess. Or if the patient comes with a history of fever, loss of weight, then think of malignancy. And in India, it can be tuberculosis that is causing these problems. Now, if there are caveats in the examination and history, next thing that you would want to have a diagnosis would be an imaging, isn't it? Now, look at this patient. Like, you have asked her to, given her conservative management, but even after 6-7 weeks, she's still complaining of pain. So now, what is the investigation that you want to do for this patient? This patient has a creatinine of 1, a CT myelogram of the lumbar spine, MRI of the lumbar spine without contrast, CT lumbar spine with contrast, or repeat a lumbar spine X-ray. What do you want to do? MRI. MRI without contrast. Very good. So can someone tell me why MRI? So how good is X-ray or how helpful is X-ray for you? So do we need to do an X-ray for all patients? No. So not all patients require an imaging, because most often imaging is not really helpful first, and then you may see something on the imaging, but that may not be the causative factor for the pain. So about 24% of the MRIs will have some sort of disc pathology. So not necessary that everyone who has a disc on the MRI has a pain, or the pain is related to the disc that you are seeing on the MRI. And again, the X-rays are not very useful because they don't tell you where the compression is. So you will need an imaging if the patient has a persisting pain or is not responding to conservative therapies, or if the pain is so severe that it would require an intervention or a surgical management. So then you really need to know where the problem is, so you get an imaging done. So So imaging, if there is severe acute radiculopathy, or if there is a worsening of the neurological status, or if the symptoms suggest that there is an abscess or a neoplasm or a cauda equina syndrome. So MRI will give you a visualization of the nerve root, where it is compressed and what is compressing it. Like as commonly we have a disc herniation, so you will know what type of disc herniation and where it is compressing. Again, as compared to CT scan, MRI is more sensitive and specific for identifying the radiculopathy. So now there are some patients where there is a contraindication for MRI, isn't it? So now, like what are the contraindications for MRI? A little louder, I have a mic, you don't have, so you have to use your voice only. Yeah, you are answering right. What is the contraindication for MRI? So there can be patients with pacemaker or an implant there that is not MRI compatible. So in these patients, you might require a CT myelogram. So this again can be a useful investigation or a substitute, or sometimes even if you have an MRI, especially patients with implants where it is difficult to get an imaging, proper imaging, a myelogram would be useful. So there are some other advanced tests which are not required in all patients, but EMG may again be helpful if you have an undifferentiated pain. It will tell you whether which radical is involved, and especially patients who have had a fixation and are still complaining of pain, maybe you can think of doing an EMG. So you can combine it with MRI for a better information. Then CSF analysis, if you think in terms of infection or a malignancy. SSCPs are not really superior to EMGs, but can be used. Discography, again in very limited conditions, this can be a useful test. So now we have had that patient whose history you have heard. Now what would be the next best step to do? Ask them to take a bed rest for 1 week and then come back to the OP, or get an urgent MRI done, or go send them to physiotherapy and ask them to come up after 2 weeks, or conservative management with acetaminophen or other NSAIDs. What would you want them to do? Yes, you tell me, what do you want the patient to do, the previous patient? Bed rest. Okay, anyone with any other alternatives, suggestions? Physiotherapy, okay. Anyone? So we will start with, like say, first thing is you need to know whether the patient has a mild, moderate or severe radiculopathy. So given the previous history, where do you put it, mild, moderate or severe? So if there is sensory loss or pain without motor deficits, it's mild. With mild motor deficits, it is moderate, and with severe marked motor deficits, it is going to be severe. So this patient had a loss of tendon reflex, but there is no motor activity. So you would grade it as moderate, isn't it? So for mild to moderate, you can have a conservative management. So there are various quackeries that are involved. No? So cold therapy, hot therapy, acupuncture, which may or may not work. Now you said bed rest. So we'll start with that. So is there evidence to say that bed rest is going to improve the outcome of these patients? So what one has found is that between bed rest and physical therapy, there is no significant difference. And between no bed rest or bed rest has not really found to be improving the outcomes in patients with lumbar radiculopathy. So which means that you can ask the patient to modify his lifestyle, but still continue with his activity while you relieve the pain symptoms. So asking them to lie down for 6 weeks is not the done thing these days. So next you said was, physiotherapy, isn't it? Again, like, should we start physiotherapy immediately when the patient complains of pain? So most of the pains actually are self-limiting, will come down within 6 weeks. So if the patient pain does not come down within 6 weeks, you can start the physical therapy. Again, in acute pain, when the patient has an acute pain, initiating physiotherapy may actually be counterproductive, because that will increase the inflammation and the pain. So don't start physiotherapy during the acute phase. You can wait until about 4 weeks to start the physiotherapy. So next is the pain management. So what do you want to manage the pain with? So simple analgesics are usually sufficient. You can start with acetaminophen or other NSAIDs with activity modification, and that is important. So most of the patients are obese like me, so you should ask them to cut down on the weight. So that is one of the good things to start with. And if they are smokers, ask them to stop smoking or stop alcohol. So studies have found that acetaminophen is good. So as compared to placebo, acetaminophen is better, but when compared to opioids, probably opioids are better. But then for every patient who comes with a lumbar pain, you don't want them to start on opioids. Unless the patient is having a very severe pain, maybe then you can consider opioids. Otherwise, NSAIDs are sufficient to release. The other things that are commonly used are, again, muscle relaxants. So should we be using muscle relaxants or benzodiazepines for patients with lumbar radiculopathy? Yes or no? So there is a paraspinal muscle spasm or something else. Do you want to use a muscle relaxant? Baclofen with ibuprofen. There are a lot of combinations available over the counter, no? How many of you would say yes? No? Okay. So all of you are equivocal, huh? Yes or no? Ni mood pattistava. So there is a no for muscle relaxants or benzodiazepines because they are not efficacious when there is a nerve root compression. Now steroids, how many of you yes and how many of you no? Yes. Any other yeses? You must have treated at least 10 backaches at home. So how many of you would suggest that you want to give a steroid? So now oral steroids, systemic, probably they will definitely produce a pain relief in radiculopathy, but then it is not desirable to give glucocorticoids because they are usually associated with other adverse effects. This is one study that has shown that as compared to other NSAIDs, glucocorticoids are similar. So there is no advantages giving glucocorticoids over NSAIDs. But if you think that the patient is severe pain and you want to give a glucocorticoids, again a caution is about the GI bleeding. If you are giving NSAIDs and glucocorticoids, you might have problems. Then epidural steroids. So we've had a full lecture on epidural steroid injections. So when do you want to give the patient or suggest an epidural steroid for this patient? So you need to give them about 3 months time or at least minimum of 6 weeks to decide whether you want to go for a epidural steroid injection or not, because there can be a self-limiting pain and where you don't want to intervene because Dr. Sridevi has already illustrated the number of adverse effects that this can have. So if there is no improvement in 6 weeks with conservative management, then think of epidural glucocorticoid injections. So when is surgery an option? Or should every patient with a lumbar radiculopathy undergo surgery? Depends on where he goes, isn't it? If he goes to a surgeon, he will go for surgery. If he goes to interventional pain management, he will have an epidural steroid. So what does this literature say? So surgery basically maybe an immediate pain relief, but when you look at a long-term outcome at 2 years, there is no difference between those patients who have undergone surgery versus those patients who have not undergone surgery. So surgery is not an option for everyone who has a lumbar radiculopathy or a persistent lumbar radiculopathy. So there are certain indications like unrelenting pain or a compression that is causing a significant neurological dysfunction when surgery should be considered. So if there is a significant spinal stenosis, then as Dr. Muralidhar Joshi said, the only option is to open it up and that would be surgical. So any patient who presents with cauda equina again is a candidate for surgery. Now, interventional pain management. This is what we are all interested in. What are the 3 routes of interventional pain management? You have a interlaminar, transforaminal and a caudal route. So I think Dr. Sridevi has already shown, but then I've taken some effort to find this video on net, so I'll show it. So what do we do here when we give an interlaminar approach? You are going to deposit the steroid in the epidural space and you expect that the inflammation or the edema that is produced because of the compression is going to come down with that epidural steroid. So that's the needle going into the interlaminar space. And then you inject some contrast to check if you are in position or not. And then once you are in position, you will deposit the epidural steroid. And this is the transforaminal. Again, I'm going to show it because I've taken effort to show this. So you first mark it in the AP view and then go to an oblique view to identify your pedicle, and then you can advance the needle either in the AP view or in the oblique view to see where your needle is going. So what is the position where you want to put your needle in? That Dr. Sridevi has already said, under the pedicle. And then once you are in position, you inject the contrast and see whether you are in position or not. And then once the needle is in place, you can deposit the steroid there. So the other, so again, like, I'll just come to this a little later. So now what is the other option that we have? So I'll just come to the literature on this. And so, see, this Manchikanti is Dr. Manchikanti Lakshmaya, on whose name this hall is. And there are several papers and several meta-analysis that are done by this group. And I'm very happy to say that I think Dr. Ram's friends like Mahender and Srinivas are also a part of some of the meta-analysis that are published recently. So this is a meta-analysis that has compared the epidural injections for radiculopathy. So they've seen the three kinds of injections, that is the interlaminar, transforaminal and the caudal approaches with steroids and with local anesthetic alone. And they found a level 1 evidence that was for local anesthetic and steroid together. And for local anesthetic alone, there was a level 2 evidence for all the three approaches. And then this is another meta-analysis that was published recently in 22 by the same group, or Manchikanti et al., where they have seen, there were more literature coming up. So this, they have looked at the RCTs that was published for the chronic low backache and sciatica. So they had looked, so the evidence says a level 1 evidence for steroids and local anesthetics, and they have also looked at the long-term outcome in this meta-analysis. But the evidence for supporting the epidural steroids at 6 months and 12 months was not as great as the earlier outcomes. So again here, this is one of the control study that the same group has done to look at the efficacy of the three groups with steroid and without steroid or local anesthetic alone. So if you look at the early outcomes at 12 months, the difference was good. Like there was 77% improvement at 12 months, but for steroids alone or interlaminar approach, the difference was persisting at 24 months. But then for the transforaminal approach with local anesthetic and steroid at 24 months, again, the difference was not very great. So if you think that the evidence for transforaminal injections is, or there are certain limitations, isn't it? So not everyone who's undergoing a steroid injection will have a radical improvement. So this was one study that is ongoing to look at what are the patients that are going to benefit from the epidural steroid injections, and the results of this are yet to be published. So there are a large group of patients where they have randomized to, or they have followed up and done a meta-analysis to see what are the predicting factors for having an improvement. Now, if everyone doesn't improve with epidural steroid, what is the next option or interventional option that we have? What we have is the spinal cord stimulation. So here, what do they do in the spinal cord stimulation? So you locate the site and then pass a electrode into the spinal cord, and then by stimulating this electrode, you can have pain relief. So as it was said earlier, the spinal cord stimulation may be expensive, but then it is a beautiful option for pain relief when other methods of pain relief fail. So in addition to steroids, other drugs have also been tried. Like this is etanercept, which is one of the drugs that is a TNF-alpha inhibitor that is used in rheumatoid arthritis. So the same drug has been used both systemically and as an epidural injection. But then this is very expensive, but fortunately for us, there's no significant improvement with this drug. So as compared to placebo or as compared to steroids. So the evidence for use of this newer drug is not very great as of now. Now the other surgical options are microdiscectomy, again which can be done through a very non-invasive small opening, and then the so this guide wire is passed and then the disc can be aspirated through that. Oh, wait. I think Hyderabad has become very popular for these microdiscectomy surgeries. Again, if you look at the evidence for microdiscectomy, it's same as surgery. I mean, it is probably not necessary for everyone. If you look at those who have undergone the procedure versus those who have not undergone the procedure, the long-term outcomes are not very different. Same thing for surgery, but surgery has some definitive indications. So if there is a significant lumbar lag neuropathy with neurological deficit, cauda equina, or significant spinal canal stenosis, then the surgery is indicated. Again, there is no guarantee that surgery is going to cause a dramatic or relief like this. So it may not be the first choice, but then in some patients it will be necessary. Now there are a lot of why do we need to intervene in this lumbar radiculopathy? So one is because it is painful and it can limit the activity. In addition, like there can be other complications like cauda equina syndrome or progressing radiculopathy. So there can be a motor weakness. So that is the reason why you want to intervene in these patients. So sometimes if you just leave it like that, this radiculopathy may progress into motor weakness or motor atrophy, or sometimes because the patient is not walking, there can be deconditioning. So that is the reason why you need to provide pain relief for these patients and make sure that they are physically up. So when you're following up these patients, follow them up for at least 2 weeks to monitor for the progression of the nerve damage. And then if the radicular symptoms persist, then you should refer them to or see if you require an imaging to see if there is anything else that would require a surgical intervention in these patients. So for mild to moderate, you can follow them up and then they might subside on their own. So for the patient that I have described earlier, so what will be your suggestions for treatment options? How would you follow that patient up? You want me to put the history back again, or you still remember? So that was a patient who was coming with an L4 radiculopathy with a moderate pain. So what will be your suggestion to them? NSAIDs, good. A little louder. Yeah? Posture correction, good. So lifestyle modification. So look for other risk factors like weight gain, alcohol or smoking that delay the healing. Yes? Yeah? IFT, there's no great evidence for that. So follow them up first, and if there is a worsening of the symptoms or if they are progressing into anything that is suggestive of a cauda equina, then get an imaging done and refer to the surgeon. Otherwise, you can allow them to. So again, bed rest, not really required. Physiotherapy after about 3 weeks, and so see if they require a surgical correction if it is persisting for a longer time or if it is progressing gradually. And most important thing is take a proper history, do a proper evaluation to see whether there is an etiology, because if you are not getting an imaging, you have to think that there is a benign etiology that is causing the compression. So focus on the pain relief, and that should do. So key takeaways would be, most of them, they are self-limited. Most of the pain should be limited by about 6 weeks. But if it is excruciating, then you need to evaluate them, do lifestyle modifications, and then if the pain is severe or if they are persisting, then think about epidural corticosteroid injections, and if it is more severe, think whether they require a surgical intervention. Thank you.
Thank you, madam. That was a wonderful lecture. Next lecture is on lumbar disc pathophysiology, diagnosis and treatment by Dr. Lavakumar Reddy. He's a consultant anesthetist and pain physician from Asian Spine Hospital.
Good morning, everyone. I am Dr. Lavakumar Reddy, consultant anesthesia and pain physician at Asian Spine Hospital. First of all, I thank Dr. Sridevi Madam and Dr. Ram Pasupuleti sir for giving the opportunity to present a topic in this CME program. So, coming to our topic is lumbar disc pathophysiology, diagnosis and treatment. So, back pain is mostly almost like fourth leading cause of the disability in the world, and among these almost 40 to 50% of the cases are because of the disc degeneration. So which mostly affects L4, L5 disc followed by the L5S1. So this intervertebral disc is composed of not only nucleus pulposus and annular fibrosis, so cartilaginous end plates are also part of the disc, because main blood supply and nutrition comes from the cartilaginous end plates by the process of diffusion. So this nucleus pulposus is a gel-like round structure which is a remnant of notochord and surrounded by the mesenchymal cells which develops into the annular fibrosis. This annular fibrosis has distinct configuration of the lamellar configuration arranged in a radial ply configuration, which gives more resistance to the nucleus pulposus. So, and these cartilaginous end plates supply the blood supply and nutrients to the nucleus pulposus and annular fibrosis by the process of diffusion. So, as most of the disc nucleus pulposus and annular fibrosis are relatively avascular, so this blood supply and nutrients comes from the cartilaginous end plate. So this blood supply, so nucleus pulposus is completely avascular throughout the life. In the beginning of the life, so only annular fibrosis in outer or middle 1/3 of annular fibrosis vascular. As the life they will reduce the blood supply, and blood supply is confined to the outer 1/3 of the annular fibrosis. So, and any ingrowth, so any inflammation or any disc pathology, any degenerative changes will cause the proliferation of inflammatory cytokines and growth factors, leading to the neovascularization and neoinnervation. So any vascularization found in the inner 1/3, inner 2/3 of the annular fibrosis or in the nucleus pulposus so is pathological. So this innervation of the disc is mostly by the meningeal branch of spinal nerve, which exists from the spinal dorsal root ganglion, and it enters into the foramen. And this innervation is also only outer 1/3 of the annulus fibrosis. So molecular composition, coming to the molecular composition, nucleus pulposus is 80% of the water. It's primarily by the proteoglycans known as agricon. So it's primarily act as a sac absorber, diffusing the compressive stress, highly organized circumferential strain during the bending, and this card of diffusion, which are lifting heavy weights and sedentary lifestyle, are predisposes to disc degeneration. So what happens in the disc degeneration? So disc degeneration, initially, like there will be a diminished blood supply from the cartilaginous end plates, leading to the decreased nutrient supply to the annulus fibrosis. And also water content of the nucleus fibrosis is decreased content of the water fibrosis. What happens if the water content of the nucleus pulposus is decreased? So theoretically, if any mechanical forces come onto the water gel-like structures, all the forces will get radiates and distributed equally to the all parts of the body. But if any force compresses the solid-like structures, all the forces, it will directly get transmitted to the lower vertebral body. So during degeneration, as the water content of the nucleus pulposus is decreased, so all mechanical forces directly get transmitted to the lower vertebral bodies, and these will give rise prone to more injury, more fractures, and more degenerative changes. So loss of impaired nutrition and diffusion from the cartilaginous end plates, and this enzymatic activation. So any injury, mechanical injury causes in annular fibrosis causes some states and fissures, which initiates the enzymatic activation leading to production of inflammatory cytokines and growth factors. So finally leading to the neovascularization and neoinnervations. So and these inflammatory mediators and so sensitizes the disc material for pain. So because of that, patient will get pain, and not only the mechanical strain, mechanical forces directly transmitted to the vertebral bodies, and also the sensitization of the disc material for pain causes the leads to the pain. So enzymatic activation and impaired nutrition, followed by the loss of fragmentation of aggrecan, which are the primary holding factors for the water content of the nucleus pulposus, and deposition of keratin sulfate and collagen distribution, change in the collagen type. So leads to the extracellular membrane degradation, membrane structure degradation, and loss of hydration of the disc material, which finally leads to the loss of structure and function of the disc material. So this normal disc, because and the risk factors, with the associated risk factors, these biochemical and inflammatory and mechanical factors leads to the degenerative changes. During early degeneration, patients will have delamination of the annular fibrosis and some tears, some fissures and cracks. So in advanced stages, because of dehydration and proteoglycan aggrecan losses and catabolic anabolic imbalance, these patients have some bulging and herniation or instability of the disc. So this, what are the four stages? Coming to the 4 stages, disc degeneration is mainly its water content of the disc material is very less. So disc is not protruded into the annulus fibrosis. Only water content of the disc material is decreased. So known as a black disc on X-ray or MRI features. So this is disc degeneration, first stage. So then the disc material, nucleus pulposus, so annular fibrosis will get some, because of an inflammatory response, annular fibrosis will have some tears, but outer fibers are intact annulus fibrosis. So because of fissures, this nucleus pulposus will get prolapsed into the annulus fibrosis, this disc prolapse. So in 3rd stage, annular fibrosis, even outer fibers of the annular fibrosis have broken, so and the disc material get extruded into the foraminal spaces. In the final stages, this extruded fragment separates from the body of nucleus pulposus, and this separated disc material may be migrated inferiorly or superiorly. So this is sequestration, disc sequestration. So and these modic classifications are mainly in vertebral end plate changes on MRI appearances. So how the vertebral end plate will appear? So main process of disc degeneration starts with the impaired blood supply from the cartilaginous end plates. So how these vertebral end plates will be appeared on MRI during degeneration? So in modic type 0 means like normal healthy disc and normal cartilaginous end plates. So in type 1, so these end plates have some bony edema and inflammation within the cartilaginous end plates. In type 2, see, this edema is replaced by the fatty tissues. So fatty replacement of cartilaginous end plates. And in type 3, so fatty sclerosis of the vertebral bone end plates will be seen on MRI appearance. So these changes are most of the times it will be compared to this significant of lower back pain, but still some studies how much significant are these changes with relation to the lower back pain are going on. So these modic changes in type 1 and T1 and T2 weight images, it will look like in modic type 1 images like edema and inflammation. So in T1 weight image, like it will be like hypointense, and T2 hyperintense. In modic type 2 like fatty replacement. So in T1 and T2 wide image, there will be a hyperintense zone. So in modic type 3, in T1 wide image and T2 wide image, they will have hypointense areas. So these are the, so not only disc degeneration, it doesn't mean if the patient has black disc on MRI or X-ray, we should name them as they are having the pain because of degenerative disc disease. So even healthy individuals also, like even in elderly people also, you can see the black disc on X-ray and MRI. So what makes the difference? So in degenerative changes, like there will be inflammatory response which will sensitize the disc material to the pain, giving rise to the pain. So in asymptomatic individuals which are having the black disc on radiology are not, they won't come under the degenerative disc disease. So this healthy means like no modic changes will be there. So in aging persons. So in modic changes with degenerative changes. So in type 4, end plate defects are less than 25%, less than 25%. In type 5, end plate defects are up to 50%. And here extensive damage in type 6, extensive damage of end plates followed by the decrease in the disc height. So not all the patients having the black disc are not symptomatic. So how will we diagnose, like by clinical features and diagnosis? So mainly disc pain. Disc pain is only axial pain. It's like centralization of pain. So only patients will complain of in the center of the back they have pain most of the times. Only patient, if disc material is herniated out of the disc material and it is sequestered or material is migrated, they will have some radicular pain. Otherwise, hallmark of this discogenic pain is axial pain without radicular pain. So, and this no radicular pain. But some patients may have the referred pain, which is sclerotomal distribution. So, on this referred pain, it's maybe dull ache pain. It's a dull ache pain and not like a radicular pain, like shooting, not like a shooting pain. And in referred pain also, straight leg test, SLR test, most of the times it will be negative in discogenic pains. And the exacerbation increase in the pain during the sitting position and during the flexion of the trunk. So on examination, so difficulty in changing, so because in sitting position all the mechanical forces load falls onto the vertebral disc material. So this will give rise to the pain. So these patients will have difficulty in changing from sitting position to standing position. And the centralization of the pain because of the axial nature, only disc material, only discogenic pain is purely centralized and there is no radiculopathy. And poor response, sometimes we may confuse the pain as some patients will the paramidline pain. It is central pain, disc pain. Some patients will tell vague symptoms like paramidline pain. So we may confuse it as a facet pain or SI joint pain. Sorry. So after injections, these patients will have poor response to the facet and SI joint injections. And on MRI, you will see the modic changes and hyperintensity zones. We will come to that topic later. And Firman scale more than 32, more than 2. Okay. Thank you. So this is referred pain. So axial pain, discogenic pain is referred pain. It's not like radicular pain. Here the back pain is more worse. Disc material is near to the anterior epidural space. So back pain is worse than the leg pain, and it is poorly localized with dull and and most of the times SLR test might be negative, and it pain always mostly above the knee only. This radicular pain, it will be leg pain is more, and positive SLR test and below the knee fan. So key diagnostic factors: axial pain with no radiculopathy, and there will be activity related symptoms like more pain and bending or flexion of the trunk, and associated risk factors. So what are the primary investigations to order? So first investigation, like we will do some erect lumbar spine X-ray. In this we can find out the decrease in the disc height. So and black disc we can see, and is there any osteophytes we can notice on X-ray findings. On MRI already mentioned like modic changes or hyperintensity zones we can find out. So other investigations like CT spine And if there is any instability of the joint, to look for like flexion extension spine X-ray, is there any spondylolisthesis is there, and CT myelogram if the patient has any like bowel and bladder symptoms were there. Other emerging tests are genetic testing and functional spinal imaging. So, and provocative discography. So, as the disc, so here the main culprit is the disc material. So, you can do provocative discography. So, we can inject some contrast material into the disc space, and this reproduces the pain and reproduces the symptoms of the pain. So, this is provocative discography. So, advantage is provocative discography is highly specific and sensitive. So, if any patient having positive symptoms with means reproduction of the pain and provocative discography, so it's like patient is suffering from the discogenic pain. However, this procedure involves the risk of accelerated disc degeneration, and it is too invasive procedure. So, because of this procedure is very limited to the selected patients which are willing to go for surgery in the next phases. So, we can specifically diagnose which disc is causing the pain, and we can treat the corresponding disc. So, this on X-ray you can see the normal disc appears like, so white structures will be there. So, this normal disc will be look like this, and degenerated disc it's completely black. So, it's not that all the patients having the black disc comes under the degenerative disc diseases. So, these patients like in some studies shows even athletes have more black disc, but these athletes have very less pain compared to the degenerative disc. So, and disc herniation, you can see that it's hyperintensity zone. So, disc herniation because of loss of water content, these hyperintensity zones will appear on the MRI. So, this provocative discography. So, this catheter is introduced into the disc material. So, this outer thick short needle and this inner fine needle will be introduced into the disc nucleus pulposus, and the contrast material is injected. So, if any fissures or tears are there in the annular fibrosis, contrast material will flow the path of least resistance. So, needle placement. So, if you see here, so here this disc is central, after injection of the contrast material it is confined to the central area only. So, and here in this space this disc material is coming out of coming into the nucleus pulposus, and here so entire disc space is occupied by the contrast material. So, this provocative discography. So, these patients, so provocative discography shows like this patient, this disc diseases is there. Both patient has two abnormality in two level disc problem. And after the discography, CT discography has to be done to grade the disease. So, this axial CT discography pattern as pattern and grading. So, grade 0 it's normal nucleus pulposus, and grade 1 only inner 1/3 of the annulus fibrosis, and grade 2 middle 1/3 of the annular fibrosis. In grade 3 entire annulus fibrosis with less than 30 degrees circumference, and grade 4 is entire annular fibrosis more than 30 degrees of disc circumference. Sorry. Coming to the management. So, differential diagnosis. So, this discogenic pain should be differentiated from the vertebrogenic pains like bone pain. So, vertebral bone fractures, osteoporotic fractures, other facet pain and SI joint pain. So, all this should be differentiated from the vertebrogenic pains. Coming to the management, so mainly its primary treatment mode of treatment is conservative treatments like oral non-narcotic analgesics and anti-inflammatory drugs, antidepressants. Like some patients will have some psychogenic factor also. So, we have to evaluate during the history and examination also whether these patients have psychogenic factor also. For these patients, antidepressants like duloxetine will be more helpful, and cognitive behavioral therapy for these patients will be helpful. And muscle relaxants are only just for adjuvants like to decrease any paraspinal muscle spasms and everything. So physiotherapy and psychotherapy, acupuncture techniques are main first line of treatment. So this, and physiotherapy, McKenzie method of physiotherapy, so has limited evidence, but it's useful. The McKenzie method of physiotherapy techniques are useful, conservative. So, and coming to the interventional pain treatments, epidural steroid injections. Epidural steroid injections have potential benefit. And some patients, in some patients, these procedures will give more benefit than the surgeries. So epidural injections can be done through the Camin's approach, subpedicular approach, or regular normal interlaminar approach. So just we will discuss about the Camin's approaches. Camin's approach is retroneural approach, which is laminated. So triangle, Camin's triangle is superiorly by the exiting nerve root, and medially by the transversing nerve root, and inferiorly by the lower vertebral end plate. So in Camin's approach, how to perform the Camin's approach? So Camin's approach, first identify the disc space, which space we want to inject the drug. So in this, so AP view, this one is AP view, we are taking this AP view. In this, all spinous process should be in the midline, and all pedicles should be at the equidistance from the midline. So then you take the interdiscal line, you keep the needle on the interdiscal line and mark the lower border of the needle in AP view, okay? And then come to the lateral view. Coming to the lateral view, same joint, same disc space. So here also mark the interdiscal line and mark the lower border of the needle, okay? And the entry of the needle point is from the lateral line in the longitudinal plane. So from the back to center to the lateral line, and the lateral line 9 to 11 centimeters. If the patient is obese, like you can take 9 centimeters. Obese patients, like you have to go deep enough. So little bit closer to the midline, 9 centimeters. If the patient is thin, so 10 or 11 centimeters will be fine. How to proceed with the procedure? So entry point from the lateral line and targeting towards the center of the disc. So finally, needle position should be at the, in AP view, at the pedicle of the eye. This is pedicle of the eye. So mid pedicular line, it should not cross the mid pedicular line in AP view, and in lateral, forget about this image. This one is previous image is coming, only see this image, okay? So this one, in AP view, this should be at the mid pedicular line, and in lateral view, it's just near the anterior epidural space. It's like just touching the disc material. So what's the advantage with the Camin's triangle, Camin's approach? So like you can directly inject, disc material is present in the disc material is here only. So it's anterior, near to the anterior epidural space. So you can inject the drug directly near to the anterior epidural space. So, but whereas in subpedicular approach, drug may diffuse into the anterior epidural space, but we are injecting from the posterior side. So this one is, some article says Camin's approach will give more efficacy, more superior than the subpedicular approach, and it is safer than safer triangle approach. So you can give the dye and see the spread of the dye in the anterior epidural space. There are two scenarios. So here if you see, only this first image you have to concentrate, okay? Here if you see, in AP view, our needle is, so here needle is touching the like bone, vertebral bone here now, okay? Vertebral bone. But in AP view if you see, it's near to the mid pedicular line. We may think we are at the near to the foramen. But in lateral view, it's already crossed the like anterior epidural space, anterior epidural line. So means like you are touching the, like you are going to the deep, So withdraw the needle and reduce the angle, make it superficial. So that in AP view, needle at the mid pedicular line, and in lateral view, it's at the anterior epidural, near to the epidural space. In one more scenario, here if you see, so this needle is facet joint, near to the facet joint, it's not in the foramen. So means like it's superficial. So if you see image in AP view, it's in the near to the mid pedicular line, but it is far away in lateral view, it's far away from the anterior epidural space. So withdraw the needle, increase the angle, make it deep, so proceed further. So that in AP view it's at the mid pedicular line, in later view it's at the anterior epidural line. So this is how the like it's not crossing the mid pedicular line in AP view, and here needle tip is at the near to the anterior epidural space. So you are injecting the contrast. If you see contrast spreading to the anterior epidural space where the disc material is present. So this will give better relief. Some articles, most of articles says this Cammins approach, injection of drug to the Cammins approach will give better relief. But even subpedicular approach also patients will get very good relief because of the diffusion of the drug. And if you learn this technique, it will be like helpful, like in future you may do some disc procedures and or endoscopic procedures. Other interventional pain managements are intradiscal electrodermal annuloplasty. So thermocoagulation across the posterior aspect of the disc at the nuclear and annular junction as well. So it ablates the nociceptors and promotes the remodeling and decreasing the inflammatory response. So like intradiscal electrodermal therapy is done like this. So needle is the posterolateral surface of annular fibrosis and the introducer needle. So this one catheter tip circumferentially travels, and where the like fissure is present, tip position so that where the annular fissure is present. So and then we ablate with 90 degrees at, approximately for 4 to 5 minutes. And intradiscal methylene blue. So it showed reduction in pain severity and improvement disability. And these intradiscal therapies, even though they give some benefit to the patient, but there will be a risk of accelerated disc degeneration. So nowadays they are not doing that procedures, intradiscal therapies. In selected patients only they are doing. So in percutaneous disc decompression, so aim to remove the excess material to reduce the intradiscal pressure to relieve the internal disc nociceptors and spinal nerve roots. So few more studies has to be conducted on this disc decompression. So basivertebral nerve ablation. So is the nerve supply is the dorsal root ganglion, which is sinovertebral nerve. So sinovertebral nerve ablation, radiofrequency ablation might be helpful for pain relief. And intervertebral disc repair or implant biomaterials. So developed for annulus closures and nucleus pulposus replacement, especially after discectomy. So after discectomy, maybe and again so next time the patient also gets the same disc problem. So we can opt for annulus closure devices or nucleus pulposus replacement. So because of even these procedures have risk of reherniation and adjacent tissue damage, adjacent healthy tissue may get damaged. And dorsal root ganglion stimulation or spinal cord stimulator. So there is only few studies are there on this technique. So need to be conducted more studies. So on surgical intervention, coming to surgical interventions, spinal fusions, it may be open or minimally invasive total lumbar interbody fusions or endoscopic lumbar interbody fusions. So comparing to the non-surgical treatment for non-radicular pain, if non-radicular pain means like only discogenic pain with degenerative disc disease, lumbar interbody fusions are probably not effective because of restriction of motion. Because of the fusion, there will be a restriction of spinal mobility which causes to the adjacent disc disease. These patients will have risk of adjacent disc disease in future. Or total disc arthroplasty. So this comparatively fusion techniques, total disc arthroplasty has less adjacent disc degeneration. Coming to the regenerative techniques, so main pathogenesis is impairment of nutrition and loss of water content of the nucleus. So this objective of this main regenerative medicine is mainly to restore the cellularity and minimize the inflammatory response. So stem cell therapy, including mesenchymal stem cells or platelet-rich plasma and chondrocytes. Few more studies has to be going on with these techniques, whether these are beneficial in long-term pain relief or not. So main limitation for this regenerative medicine is disc material is relatively avascular. So after injecting here, the stem cells will survive, like, because there will be like no diffusion, as already there will be endoplate impairment, there will be pain nutrition. So this, for how long this regenerated material will get survived in the disc, way after injection is questionable. So thank you.
Thank you for such a wonderful lecture, sir. I request Dr. Sridevi ma'am to present memento to Lavakumar Reddy, sir. Madam. Now we will take a break for lunch and we'll meet at 2 p.m. and we'll continue the event.
The diagnosis and treatment of knee pain.
Yes, sir. We are putting a timer.
Good afternoon, everyone. It's a proud moment for me today to come back to my alma mater and deliver a lecture on pathophysiology, diagnosis, and treatment of knee pain. I bring warm greetings from AIIMS BB Nagar. So in this lecture, I would like to talk about the following things: functional anatomy of the knee, a rational approach to knee pain, where I'll be trying to explain to you the importance of history taking, physical examination, and imaging, as they were helpful. Common painful conditions of the knee, the pain generators or the sources of pain, like we like to call it. And I would like to summarize all of this with an algorithmic approach to knee pain. There is a lecture by Dr. Rajneesh on the anatomy of the knee, so I will not take a lot of time with this. But I'll be brief with the functional anatomy. So as we all know, it is the largest joint in the body in terms of articular surface and joint volume. So the knee is capable of amazingly complex movements that encompass highly coordinated flexion and extension. Even the simplest movements of the knee involve an elegantly coordinated rolling and gliding movement of the femur on the tibia. So for our ease, I would like to divide the knee joint into two: a femoral tibial joint and a femoropatellar joint. So the femoral tibial joint is made up of articulation of the femur and tibia, as you can see in the picture. Interposed between the two bones are two fibrocartilaginous structures known as the medial and lateral menisci. The menisci serve to transmit the forces placed on the femur across the joint onto the tibia. They possess a property of plasticity in that they are able to change their shape in response to the variable forces that are placed on the joint. The medial and lateral menisci are relatively avascular but receive bulk of their nourishment from the synovial fluid, which means that little potential for healing exists when these important structures are traumatized. So this is the sagittal view. You can see the femoropatellar. Can I have a pointer? Yes. So this is the femoropatellar joint. Patella is basically a large sesamoid bone embedded in the quadriceps tendon here. To improve the mechanical advantage of the quadriceps muscle, the medial and lateral articular surfaces of the sesamoid interface with the articular groove on the femur here. In extension, only the superior pole of the patella is in contact with the articular surface of the femur, leaving the inferior pole free. As the knee flexes, the patella is drawn superiorly into the trochlear groove of the femur. Then now coming to the ligaments. So the main ligaments of the knee are the anterior and posterior cruciate ligaments. Here, which provide much of the anteroposterior stability to the knee joint, and the medial and lateral collateral ligaments, which provide much of the varus and the valgus stability. All these ligaments also help prevent excessive rotation of the tibia in either direction. A number of secondary ligaments also add further stability to this inherently unstable joint. So what is a rational approach to knee pain? It is the starting point, when a patient comes to the clinic with knee pain, the starting point for any clinician is to obtain a targeted history and perform a targeted physical examination of the affected knee or knees. So these are the order in which, or these are the type of questions I would like to ask my patient. Where is the pain? How did it begin? What were you doing at the time? Did you experience any grinding or locking or catching or giving away of the knee? Are there any positions which make your knee more or less comfortable? What is the quality of your pain? Sharp, shooting, dull, etc. Have you tried anything to help with the pain? And any other important questions are, have you ever had surgery on the knee? Any hip or ankle pain, a joint above and a joint below? So this, why I am asking this history is, pain at the joint line can tell me about any collateral ligament or meniscal problem. Pain at the tibial tuberosity in a young patient, this is a specific diagnostic point for Osgood-Schindler's syndrome. Anterior knee pain could be patellofemoral disorder. Pain over the medial tibial plateau approximately 2 inches below the joint line is a pes anserine bursitis. I will show you in images. Pain and swelling in the posterior knee is a classic Baker's cyst. So when did the pain begin? Ligamentum injury, a ligament injury is a mechanism, is a twisting of the knee or a deceleration injury. Immediate symptoms are swelling and pain. Patient tell you that they hear a pop at the time of the injury. Meniscal injuries are same with twisting or deceleration. There is no swelling immediately. Immediately swelling may not be there and there is no popping sensation. Older patient may not even recall an inciting traumatic event. Chronic onset are our classic osteoarthritis, a disease of degeneration, patellofemoral syndrome, Osgood-Schindler's, and fractures will obviously have a history of trauma. So the grinding is with respect to osteoarthritis. Giving away is generally with ligamentous injuries. Locking and catching is with meniscal injuries. So targeting any positions which make the knee comfortable or not is to target the diagnosis of patellofemoral syndrome. Classically, patients report pain with prolonged knee flexion and pain relief with knee extension. So this is the movie theater sign. To relieve the pain, the patient will report extending the leg into the aisle while sitting in a flight. So the other things I would like to ask a patient in a history is whether the issue is acute or chronic, age of the patient, history of any trauma, any fever associated with knee joint, pain in any other joints, polyarthralgia, any rash, this is rare but important, and any other constitutional symptoms which could give a diagnosis of a malignancy. So the acute onset of knee pain in the absence of trauma is a cause of concern for the pain physician. Acute knee pain and fever should be considered a dangerous combination. Although some acute febrile illnesses such as streptococcal pharyngitis may have a large joint arthralgia as a part of constellation of symptoms, we must rule out the septic knee joint, collagen vascular diseases, and Lyme disease before assuming that the fever and pain are unrelated. So this is why I said age of the patient is important, because certain things come only during childhood, like a juvenile chronic arthritis. There is most commonly the meniscus are torn in adolescent age group. Adulthood we get inflammatory arthropathies, and older age is the classic osteoarthritis. These are the intra-articular causes. Same for periarticular and referred pains. So this is the rash I was talking to you about. Although uncommon, Lyme disease after a tick bite can cause significant knee pain. This condition is usually associated with a specific rash known as erythema migrans, which is a result of infection with Borrelia burgdorferi. Failure to accurately diagnose and treat this uncommon condition of knee pain can result in permanent knee damage. So examination, once my history is over, I come to examination. I first inspect the patient in sitting and standing. I try to make him walk so that I see his gait, whether it is any antalgic gait, a component is present or not. There is something called a Q angle, usually measured by orthopedicians. It is a quadriceps angle around 15 to 30 degrees. And see for any obvious swelling or scar of previous surgery on the knee. Palpating usually starts from local rise of temperature, tenderness, this is common, and patellar tracking, any crepitus. Patellar tap and ballotment is done for effusions of the joint. This is how a ballotment is done, where from the quadriceps tendon, the muscle is squeezed, brought to the knee, and then checked for movement of fluid. The fluid moves from one bursa to the other. So next step is to test the integrity of ligaments and the meniscus. So there are 4 or 5 tests here. Each ligament may have multiple tests. I will not go into details. We are not orthopedicians, but I'll try to tell at least one for each. So valgus stress test is performed to test the integrity of medial collateral ligament. The examiner will force the lower leg away from the midline while observing for widening of the medial joint compartment and pain. Next is a varus stress test, where he does the opposite. He pulls the leg towards the midline. This is for the lateral collateral ligament. It is not usually common. Medial collateral ligament injuries are more common. Then this is the most common test done for anterior cruciate ligament integrity, anterior draw test. Another one, Latchman test, is also done, but this is the first thing we do. The patient is lying supine with knee flexed to around 35-40 degrees. The examiner then grasps the affected leg below the knee with both hands and pulls the leg forward while stabilizing the foot. The test is considered positive if more than 5 mm of anterior motion is seen. Similar test where we push the foot back for this is called a posterior draw test, test the integrity of the posterior cruciate ligament. So this test is again considered positive if more than 5 mm of posterior motion is seen. So this is a McMurray's test for the diagnosis of a torn meniscus. It can provide the clinician with useful information as to whether a torn medial or lateral meniscus is responsible for the patient's pain. It is considered positive or a meniscus is torn if the examiner appreciates a palpable or auditory click while rotating or extending the knee. Rotating and extending the knee, I'm sorry. So why we focus on history and examination is because a professor in this very hospital once taught me that 81% of our diagnosis comes from history, 9% comes from examination, 9% from investigations. So this is 99. The rest 1%, don't tell anyone outside this room, is by luck. So the common painful conditions of the knee, why we need to know this is because we need to know the sources of pain. What are the things which can generate pain in a knee? So your bones, ligaments, bursae are usually the common things. So the initial physical examination of the knee guides the clinician in narrowing his or her differential diagnosis and helps to suggest which specialized physical examination maneuvers and laboratory and radiographic testing will aid in confirmation of the cause of the patient's knee pain. For the clinician to make best use of the initial information gleaned from the physical examination, a grouping of the common causes is exceedingly helpful. Although this list is not exclusive, frequent overlapping and multifactorial nature is present, but still it is by no means comprehensive, but it still aids the physician in diagnosing and narrowing down the potential sources of pathology. So if the pain arises from the bone or a joint space pathology, these are the causes it could be, the causes which could happen. There could be a fracture, a primary bone tumor, a synovial tissue tumor, any localized arthritis, osteophytes, hemarthrosis after a minor trauma or repeated trauma, any intra-articular foreign body, like I said, Osgood-Schindler's disease in the children, and patellofemoral pain syndrome. So if there is knee pain from periarticular pathology, then it could be bursitis, inflammation or infection of the bursa, tendinitis. Adhesive capsulitis is usually seen in the shoulder, but sometimes, yes, even in the knee. Muscle strains and sprains after minor sports injuries. And coming from systemic diseases, our causes are rheumatoid arthritis, collagen vascular diseases, gout, any other crystal arthropathies, and Charcot's neuropathic arthritis. Coming from there can be knee pain which is sympathetically mediated as well. So this is from reflex sympathetic dystrophy or causalgia. From any other body areas, like I said, always examine a joint above and a joint below. So there could be referred pain from the lumbar spine. So any radiculopathy, spondylosis, fibromyalgia, or retroperitoneal tumors. So these are the causes, these are all the things which could cause knee pain when you have a patient with a painful knee in the OPD. So coming to the most common, I will not go into too much detail, but coming to the most common knee pathology which we see in our practice, osteoarthritis knee. So I will directly jump to the X-ray findings. The hallmark is a joint space narrowing, usually asymmetric, but could be more predominance to the medial component. Less than 3 mm narrowing on weight-bearing knee radiographs is considered a finding of absolute joint space narrowing, with a normal joint space generally is more than 5 mm. Weight-bearing radiographs will demonstrate more joint space narrowing than non-weight-bearing, that is obvious. The other X-ray findings are subchondral sclerosis, marginal osteophytes, subchondral cysts, and altered shape of femoral condyles and tibial plateau. So the MRI findings on the same ONE will be effusions and synovial thickening or synovitis, subchondral bone marrow edema, cartilaginous defects, bursitis or iliotibial band syndrome. So the grading for ONE is from 0 to 4, 0 being definite absence of X-ray changes, 1 being doubtful joint space narrowing, 2 with osteophytes and possible joint space narrowing, moderate with multiple osteophytes, definite joint narrowing and some sclerosis, and severe is almost bone on bone with large osteophytes, marked narrowing of joint spaces. So this is the range of the X-ray. So this is the joint space, minimally narrowed here, and this is almost bone on bone, so this is grade 4. Next, coming to the bursitis, all the different types of bursa which are present around the knee. So the first we start with suprapatellar bursitis. There are around 4 or 5 important bursa around the knee. So suprapatellar bursitis is present above the, extends superiorly from beneath the patella, underneath the quadriceps femoris muscle. So this is your patella, this is your femur, and this is the suprapatellar bursa with a collection of fluid in this patient. The patient with suprapatellar bursitis frequently has pain in the anterior knee above the patella, which can radiate superiorly into the distal anterior thigh. Often the patient is unable to kneel or walk down the stairs. So this is the location, and that is how an injection is given. Patient is lying supine with knee slightly flexed with a pillow below the knee. The superior margin of the medial patella is identified. Just above the point, the needle is inserted horizontally to slide just beneath the quadriceps tendon here. Then there is a prepatellar bursitis. Prepatellar is superficial present. This is the patella, this is a collection just above the patella. It is vulnerable to injury from both acute trauma and repeated microtrauma. A prepatellar bursa lies between the subcutaneous tissues and the patella here. And it results from jobs that require crawling on the knees, such as laying carpets and scrubbing floors. Hence, the other name for it is a housemaid's knee. So, we see here, above the patella, we have a prepatellar bursa. The center of the patella is identified at the midpoint. Just above this point, a needle is inserted horizontally, and a local anesthetic or with steroid can be injected there. If the needle strikes the patella, it is withdrawn slightly and redirected superficially. Next, there are 2 infrapatellar bursas. One is superficial and deep. This one is superficial. It lies between the subcutaneous tissue and the upper part of ligamentum patellae. The patient with superficial infrapatellar bursitis frequently has pain and swelling in the anterior knee over the patella that can radiate superiorly and inferiorly in the area surrounding the knee. So above this is the superficial infrapatellar. Below the patella, so infrapatellar. Above this, so superficial. When it is below it, it is called deep infrapatellar. So same, the center of the lower pole is, so this is the fluid collection. The center of the lower pole of the patella is identified somewhere here. This is the patella. This is the lower pole of the patella. Just below this point, a needle is inserted at 45 degrees angle to slide subcutaneously into the superficial infrapatellar bursa. So this was the pes anserine bursa I was talking about. This lies beneath the pes anserine tendon, which is the insertional tendon of the three muscles, sartorius, gracilis, and semitendinous. I'm confident I did not know this name when I was doing anatomy here. And this is present in the medial side of the tibia. The pain of pes anserine bursitis is constant and characterized as aching pain. So care should be taken to not injure the medial collateral ligament while treating the pes anserine bursitis. The point distal to the medial joint space at which the pes anserine tendon attaches to the tibia is the location of the bursa, is usually identified with point tenderness at that spot. This is what I was talking about in the examination part. Same, the needle is inserted at a 45-degree angle through the skin and the subcutaneous tissues. Next is the last one, the deep infrapatellar bursa. It lies between the ligamentum patellae and the tibia. Patient with this has pain in the anterior knee below the patella that can radiate inferiorly into the area surrounding the knee. Coming to the cyst in the posterior part of the knee in the popliteal fossa, patients with Baker's cyst have a feeling of fullness behind the knee. Often they notice a lump behind the knee that becomes more apparent when they flex the knee. This cyst may continue to enlarge. It can disrupt, and the fluid containing sac can be dispersed into the surrounding tissues. Occasionally, the dissection may be so significant as to cause a lower extremity compartment syndrome. Patients with rheumatoid arthritis are prone to this phenomenon. The pain associated with dissection into the calf may be confused with thrombophlebitis and inappropriately treated with anticoagulants as well. Care should be taken while injecting into the bursa because there are vessels here, popliteal or artery and vein, and our sciatic nerve, already branched by this point. Next, coming to a rare cause of knee pain, quadriceps expansion syndrome. It is uncommon cause. It is characterized by pain at the superior pole of the patella. So it is usually result of overuse or misuse of the knee joint, usually in athletes, in running marathons. This is an MRI image where the top two are partial tears. This is the point where the quadriceps is torn, if you can appreciate. And the C and D, the bottom two, are complete tears. This is the part where it is torn completely. This is on ultrasound. This is the patella. This is the tendon, quadriceps tendon, which is torn, and there is a blood-filled cavity formed between the tear. Now, I will try to accumulate all of this in a algorithm. So again, starting with history and mechanism of injury, physical examination, whether there is a swelling or a traumatic injury. If there is a swelling, come back here. So swelling, whether it is intra-articular or extra-articular, is the swelling extra-articular? It could be bursitis or Baker's cyst. If it is intra-articular, it could be effusion or no. Intra-articular could be arthrosis, any crystals, any infection like septic arthritis or non-infectious. If it is not, then it could be effusions, moderate to large or small, both treated with arthrocentesis. Coming to traumatic, if there is a swelling, come here. So if there is no swelling, are the Ottawa rules satisfied? Ottawa rules are nothing but whether patient is able to walk 4 steps, 2 steps on each leg, and a few other things. So if those rules are satisfied, patient is able to walk, then we get an X-ray done. If it is positive, you know whether there is a fracture of femur, tibia, or patella. Remember, this was traumatic injury. So if the rules are not satisfied, patient is unable to walk, then you try to find the location of the pain, whether it is in the anterior component, like I said, Latchman test for ACL here, medial component, valgus test, lateral component, posterior component. So if there is no swelling, and then you check for any rheumatology history in the family or in the patient, or then you check whether OA clinical criteria for osteoarthritis are met. If there is rheumatology positive, then you send for labs, you get a diagnosis. Basically, you have to know where the location of the pain is, and the tests are accordingly. So this is an algorithmic approach. Thank you for your attention.
Thank you for the informative lecture, sir. I request Dr. Padmavati Madam to present the memento to Anish Wagre, sir. Next, we have a lecture on lumbar facet joint pathophysiology, diagnosis and treatment by Dr. Ram Paspaliti, sir.
And 1 minute, 25 minutes. All right, guys, so are you all ready? Yes or no? Yes? Do I hear yes? Are you guys sleeping? All right, so the mission, if I choose to accept, is lumbar facet joint pathophysiology, right? Diagnosis and treatment. My disclaimer has not changed since morning, so I'm not going to go through all that. This is the teaching mantra, Om Sahana Bhavatu, Sahana Bhunaktu, Sahaviryam Karavavahe, Tejasvinavaditamastuma Vidvishavahai, Om Shanti, Shanti, Shanti. That means may God protect the teacher and the student. May he nourish us together. May we work together with great energy. May our studies be enlightening. May there be no hate among us, right? So that's the teaching mantra from the Taittiriya Upanishad and Krishna Yajurveda. So objective is to provide an overview of lumbar facet joint pathophysiology, diagnosis and treatment. I'm going to structure it this way: lumbar facet joint pathophysiology, anatomy, applied anatomy diagnosis, treatment, and lumbar medial branch blocks and radiofrequency thermocoagulation procedure. So that's how this is going to go. I'm going to go fast, so you can stop me if you want to, but because of the time. So pathophysiology, facet joints are well-recognized source of low back and referred pain in the lower extremities in patients with chronic low back pain. Facet joints are innervated by the medial branches of the primary dorsal rami of the spinal nerves. We know that, right? So neuroanatomic, neurophysiologic, and biomechanical studies have demonstrated free and encapsulated nerve endings in lumbar facet joints, as well as nerves containing substance P and CGRP, right? So arthrosis. Here are some definitions, guys. So we hear these terms so often, sometimes it can be confusing. So arthrosis is chronic degenerative disorder of a joint. Arthropathy is any disease that affects a joint, and arthritis denotes joint inflammation, right? So it depends on which radiologist is reading your MRI. You see all these terms: arthrosis, arthropathy, arthritis. So osteoarthritis is arthritis characterized by erosions of articular cartilage, which mainly affects weight-bearing joints, right? So classic radiographic hallmarks of facet joint arthritis involve both degenerative and proliferative. Those are the things that you're looking for, both degenerative and proliferative. Features including narrowing of the facet joint space, subarticular bone erosions, subchondral cysts, osteophyte formation, and hypertrophy of the articular processes. So conditions affecting the facet joint. So what causes pain in the facet joints? First is facet arthropathy, right? And then rheumatoid arthritis, spondyloarthropathies like ankylosing spondylitis, facet joint cysts, trauma. The terminology that we use are all of this. Like I said, depending on which radiologist is reading your report, you see every single one of these, right? Anybody disagree? Have you seen all these terms? Yes? Spondylosis, facet arthrosis, facet arthropathy, facet arthritis, facet osteoarthritis, lumbar facet hypertrophy, degeneration of lumbar facet joints, lumbar facet syndrome. So these are all the things that you would see come across in an MRI report. Anatomy, the zygapophyseal joint, right? Zygos is yolk, physis is outgrowth. They are paired joints composed of superior articular process of the vertebra below and the inferior articular process of the vertebra above, right? That's very simple. I'm not going to go through all these figures here. They're pretty self-explanatory. You can see the joint space there. Facet joint is a true synovial joint containing a hyaline cartilage surface and synovial lining encompassed by posterior fibrous capsule, which is absent anteromedially, which is an important point to remember. The capsule is more posterior, anteromedially the capsule is absent. Capsule has collagenous fibers which function to resist flexion, right? So what is the innovation of the joints? The capsules of the facet joints are richly innervated with encapsulated, we said, right, and unencapsulated nerve endings coming from the medial branches of the dorsal rami of spinal nerves. Each lumbar facet joint has dual innervation being supplied by two medial branches. So the mantra to remember is, each joint is supplied by two nerves. Each nerve supplies, come on guys, two joints, okay. The medial branches are clinically most important and relevant because they provide sensory innervation to the facet joints. The medial branches of the L1 to 4 dorsal rami assume a constant and similar course. The L5 assumes a different, slightly different course, right? So if you can see, each nerve emerges from its intervertebral foramen and enters the posterior compartment of the back by coursing around the neck of the superior articular process, right? So foramen, and it comes out this way. And this is a better thing, it's just a model, but it comes out from the foramen, right? This is the L4 nerve root, medial branch. Then it splits, it supplies this joint, right, and this joint. That's how each medial branch supplies the joint above and the joint below, right? One medial branch supplies two joints. Then hugging the neck of the superior articular process, the medial branch passes caudally and slightly dorsally, covered by the memelo-accessory ligament, hooking medially around the caudal aspect of the root of the superior articular process to enter the multifidus muscle. A mouthful to say, but I'm sure you understood what I was meaning there. So intermediate and lateral branches arise from the dorsal ramus at the same point as the medial branch and supply mostly the skin. So we are not worried about the intermediate and lateral branches because they supply the skin. We are worried about the medial branch because it supplies the joint. Finally, the medial branch crosses the vertebral lamina where it divides into multiple branches that supply the multifidus muscle, the interspinous muscle and ligament, skin, and the two facet joints like we saw. So we talked about it. L1 to L4 follow the same path, and L5 is slightly different, right? The medial branch of the L5 dorsal ramus has a different course and distribution. Instead of crossing a transverse process, the L5 dorsal ramus crosses the ala of the sacrum, right? There is no transverse process here, so that's the ala of the sacrum right there. It crosses that. This one crosses the transverse process, superior articular process, but this one crosses the sacral ala and comes back posteriorly. From the L5S1 intervertebral foramen, the medial branch of the L5 dorsal ramus runs along the groove formed at the junction of the ala and the root of the superior articular process of the sacrum before hooking medially around the base of the lumbosacral facet joint. So it hooks around that joint right there. It hooks around this joint right here. So, and radiographically, you're looking for this V here, right? That V is what your target, your needle tip has to go right there. That is your target right there. That's where the nerve comes. So applied anatomy and diagnosis. To block this sensory innervation to a lumbar facet joint, it is necessary to block the two medial branch nerves which supply the joint. To block one joint, remember, again, block the medial branch at the transverse process at the same level as the joint and block the medial branch at the level below the joint. So if you have to block the L3-4 facet joint, block the L2 medial branch at the transverse process of L3 and L3 medial branch at the transverse process of L4. Clear? I don't think so, but that's okay. You'll get it. The more you do, you'll get it. That's all right. So, and then to block the L5S1 facet joint, block the L4 medial branch at the L5 transverse process and the L5 dorsal ramus at the sacral ala. So all you have to remember is, if you have to block one joint, you have to block. As long as you remember that, then you're okay. Each facet joint is supplied by two nerves, and each nerve supplies two joints. All right. You guys are getting it. Good. So I'm not going to go through all this. It's more confusing than anything else. As long as you can remember those things, I'm just barely getting it, so you should be able to get it as well. So L1-2, if you want to block the L1-2 joint, that's the medial branches that you block. L2-3, so and so. So the good thing, if you remember, is the joint level and the levels at the transverse process are the same, right? L1-2, L1-2. Right? At least if you remember that, you'll be fine. So how do you diagnose facet pain? Conventional clinical features are unreliable for diagnosing facet joint pain. So Referred pain secondary to facet joints and radicular pain secondary to disc pathology are difficult to distinguish. Sometimes they come to you saying that I have pain running down the back of my thigh, which is not radicular. So the point we are trying to make is it should not be radicular. It should not be in the distribution of a nerve root. As long as it's not in the distribution of nerve root, that is coming from the facet, right? That is the primary area of pain in the facet joint, from facet joints, but they can have pain up to here, sometimes even up to here. So that doesn't mean it is radicular. So make sure that they don't have any radicular signs or symptoms. That's referred pain. So this is done, I think this study was done by Manchikanti again, and he mapped the areas of pain, primary areas and secondary areas. So history, mostly it is pain on extension, right? Standing in one place and lying flat on back. So you ask the patient, are you able to lie flat on the back at night? If you're not able to lie flat on the back, then this is one of the, you suspect this. And or pain on extension, when they are bending backwards, they have pain. Standing in one place. Where I come from, they say, I can't stand and wash dishes. That's what they say, I can't wash dishes. So that's the thing. So Kemp's test, we talked about it before. Extension and lateral rotation of the affected side loads the facet joints, and if positive, may be indicative. So you ask the patient to stand up straight, and then extend and rotate to the affected side. So what are you doing? You're loading the facet joint on that side. So if they have pain on that side, then you have a positive Kemp's sign, right? Treatment part. So facet-mediated pain can be treated with a lot of different ways. Conservative measures, rest, heat, massage, physical therapy, chiropractic manipulations, ultrasound, TENS, muscle stim. And in terms of medications, you can use topical patches. They work reasonably well because the facet joints, the medication does get to the facet joint. So yeah, this is one place where you can use lidocaine patches. Topical NSAIDs like diclofenac, even I think, Dr. Sridevi, do we have diclofenac patches here? It's available here. Okay, so it is in the market, so so you can get a patch, right? So that's a very good thing to use. Capsaicin, is capsaicin available? No? Okay. And oral NSAIDs, ibuprofen, naproxen, so on and so forth, and prescription NSAIDs, meloxicam, diclofenac. Be careful, you all know what NSAIDs do, so be careful on a short-term basis. So opioids for patients who have failed initial and conservative therapies and are not interested in interventions, then you can talk about opioids. A trial of opioids may be reasonable. Tramadol, codeine, the lower-end kind of opioids, not the big guns, on a trial basis. Is codeine available? Codeine is available? No, it's not. Tramadol, I'm sure, I know it's available. Tapentadol is available here, so then interventions, you have, which is what we're going to talk about. We have diagnostic interventions and therapeutic interventions, right? You can do spinal cord stimulation, but that's very, very rarely done for this indication. And sometimes we do what is called as the field stimulation as well. Lumbar facet joint interventions can be divided into basically diagnostic and therapeutic. What are the diagnostic interventions? Lumbar facet medial branch blocks, right? You're going to see it tomorrow. Medial branch blocks, lumbar facet intra-articular injections, right? You can put the steroid straight into the joint as well. We are not doing that as much. We used to do them before, but we are not doing them as much, and I would not encourage you to do it. I think the medial branch blocks are much easier to do, much simpler to do as well. And you don't violate the joint capsule, right? If you're doing an intra-articular injection, you're violating the joint capsule, so you have to be very careful with it. So indications are somatic or non-radicular low back and lower extremity pain of at least 3 months duration. Therapeutic or lumbar facet medial branch blocks can be therapeutic as well, right? So they may get anywhere from 6 days to sometimes 6 months of pain relief. So that can be therapeutic as well. Intra-articular injections also can be therapeutic. Radiofrequency thermocoagulation is a very good way of doing this, and they get about 6 months of pain relief. And the indications for this are, when do you do a therapeutic intervention? Only after you have confirmed diagnostically that it is in fact the pain mediated by the medial facets, then and only then you do the therapeutic intervention, right? You just don't do a therapeutic intervention if you're not sure where the pain is coming from. So it behooves you to make sure that the pain is coming from the facet joint. So how do we do that? We can do controlled diagnostic blocks, either with placebo or comparative local anesthetics. In the US, we do comparative local anesthetics, right? We do lidocaine and we do marcaine and see the duration of relief and make sure that, in fact, they are getting good relief. And 80% of relief is what is expected. Once you get 80% relief, then you can proceed with the radiofrequency. Procedure, position the patient. We've talked about, Dr. Sridevi, I think, talked about position. Position is very important. So you have to position it appropriately. May make the difference between success and failure. So basically, prone position with a pillow under the abdomen. Practitioner's position with the table at a comfortable height. There are two techniques, prone position oblique and prone position anterior-posterior. You can see that here. Oblique. All you do is just oblique your C-arm, right? That's oblique. And if you do it in an AP view, that's anterior-posterior. The bottom line is you're getting the needle tip at the same place, right? It doesn't matter. It doesn't matter which way you look at it. It's just a question of at a different angle of looking at it, right? So, but your needle tip is always the same place, right? So L1 to 4. So start with an AP view of the lumbar spine. There you go. Identify and count the levels of the vertebral bodies. Do you want to say that's L4? Anybody? Any objections to it? L5 maybe? Yeah? So identify the transverse process and the superior radicular process, right? So transverse, superior radicular process, you can see that very nicely here. The pedicle is in black, the superior radicular process is in red, and this is in blue. Visualize the target, and squaring the plates is helpful, not necessary, but helpful. You understand what squaring the plates is, right? That plate is squared right there. So Scotty dog, right? Scotty dog. This seems to be a very favorite term of everybody, and like I said, when I went into my fellowship, I never saw a Scotty dog before. So I was like, what in the world are they talking about? So this is a this is a Scottish Terrier, right? The Scotty dog comes from, it's a Scottish Terrier. So if you can identify this dog, then you can identify the dog in the back. So these are also, that's the pedicle, that's the eye of the dog. That's the transverse process, the snout, right? So that's the dog that you see right there, right? See that? Ear, snout, front leg, back leg. This is even better. Ear, snout, front leg, back leg, and little tail there. So that's the Scotty dog. So angle the C-arm, we are talking about the prone position oblique, right? So angle the C-arm to the side to be blocked. So if you want to block the left side of the joint, you angle it to the left. And the facet joints are visible, and the Scotty dog view is obtained approximately 25 to 30 degrees of angle. So see that Scotty dog? See how nice it is? That's the Scotty dog view, oblique view. Ear is the superior radicular process. The eye is the pedicle. Nose is the transverse process, and so on and so forth. Foreleg is the inferior radicular process, and the body is the lamina and the spinous process right there. A skin entry point is chosen at the angle junction of the transverse process and the superior radicular process. So skin entry point is chosen at the junction of the superior radicular process and the transverse process. Skin infiltration is performed by local anesthetic, 22 to 25 gauge to the infiltrated skin. The needle is directed down the beam or gun barrel, right? This is very important, gun barrel, meaning that the needle has to be in the direction of the C-arm, right? So that is gun barreling down. And guided towards the eye of the dog, dorsal aspect of the root of the transverse process to ensure safe needle depth away from the ventral ramus till bony contact is made. Remember, guys, the foramen is not very far. The foramen, you'll be knocking on the foramen, so that's why you have to be very careful. Using the 3D technique, this is a very famous technique invented by my teacher, guru, and boss, Dr. Ratz. So it's called the 3D technique, right? Direction, depth, and direction. So the first shot you get is an AP view. What does that give you? That gives you where the direction of the needle, right? It will tell you whether the needle is going medial or lateral, superior or inferior. It will not tell you what? It will not tell you how deep the needle is, right? So then you have to get a lateral view to get the depth of the needle. So that's why it's called direction, depth, and direction, 3D, which is three-dimensional also in a way. So, so the final position of the needle should be behind the foramen, as you know, right? You cannot be in the foramen because then it will become a transforaminal. And at the level of the facet joint and on the lateral view. So you can see the picture there, right there. So that's the foramen, nice, and it is below the foramen at the level of the facet joint. On AP imaging, the tip of the needle should be at least in line with the lateral margin of the silhouette of the SAP, which is the superior radical process, and if possible, a little medial to this margin. So you aspirate and then inject just very little, half ml of contrast. Spread should be posterior without intravascular, epidural, or intrathecal spread. See the spread? Nice, thick blotches of dye. That's your friend, a big blotch of dye, right? Nothing running away, nothing streaky, so that's what you need to see. After contrast confirmation, the local anesthetic steroid is injected. The bevel opening should be medial and inferior. Why? Why should it be medial and inferior? Because if it is lateral, it will go into the foramen, right? So it has to be medial and inferior. The drug spread will be below the foramen and behind the foramen. For diagnostic blocks, no more than half cc of local anesthetic is needed. That's it. That was the prone oblique. This is the prone anterior-posterior. The same thing, not much different. Don't oblique your C-arm in this. Just put it in an AP view, right? That's the AP view. And square the plates. Skin entry point can be chosen laterally, much laterally, and then head towards that point. Head towards that point. Once again, the tip of the needle is again at the same point, whether you do AP or oblique. Not a gun barrel technique, and that's the bad part of this technique, right? For starters, I will not recommend this technique. For people who are used to doing this, this is a good technique. But for beginners, I would say always go the gun barrel technique. Final position of the tip is confirmed in the lateral view to be behind the foramen, right? So, and then inject your contrast, thick, nice blotches of dye, and you are always behind the foramen, always behind the foramen. And so this was L1 to L4. We said the L5 takes a slightly different route, right? So we have to do it a little differently. Start with an AP view of the lumbar spine to include the upper end of the sacrum. Rotate the fluoroscope approximately 10 to 15 degrees. Oblique to the side to be blocked to view the junction of the sacral ala and the SAP of S1. That's the sacral ala, right? Right there. That V we talked about, that's your target right there. A cephalad tilt usually helps by moving the ilium caudate. So you tilt your C-arm up, it will get your iliac crest out of your way, right? The target point is the notch between the sacral ala and the SAP of S1. That's your target point right there. See that? The V that we talked about? That's your target point. The needle is advanced down the beam in a gun barrel fashion till bony contact is made. The final position of the needle is confirmed in the lateral view to be within the shadow of the posterior elements. So it has to be in the shadow of the posterior elements. Now, coming to the radio frequency, the procedure of radio frequency is identical to what we talked about, except for a small change. The final position of the tip of the needle is a little different. So instead of stopping when the bony contact is made at the dorsal aspect of the root of the transverse process, the needle tip is advanced a few millimeters along the curve of the angle between the superior articular process and transverse process to lay the active tip of the RFTC needle parallel to the nerve. So if this is your superior articular process, this is your transverse process, right? This way, you stop here with the facet block, whereas for the radio frequency, you advance it along the angle there. And to lay the active tip of the needle along the branch, parallel to the branch. That's the only difference. So. Sensory stimulation is performed at 50 hertz to elicit paresthesia in the local paraspinous area. Motor stimulation is 2 hertz. Thumping sensation, twitch in the you can see a twitch in the multifidus muscle, right? So see the difference here, the position of the needle. You can stop here for the medial branch block, but you have to go a little further and lay the tip of the needle along the medial branch, and that is the lesion that is being produced right there, right? So that's a Cosman, more advanced version than what we have. Like Dr. Sridevi said, I donated a radio frequency machine to Gandhi. And it is not this machine, it's a slightly older machine, which is what I use as well. So then once you've done the sensory stimulation, motor stimulation, then just you can put a little bit of anesthetic with or without steroid to reduce the discomfort of the lesion. RFTC lesioning is then performed at 80 degrees centigrade for 90 to 120 seconds. A second lesion can be performed if you want after turning the tip of the needle. You cannot advance the needle, but you can turn the tip of the needle, right? You just turn the tip this way. You cannot advance the needle. Cooled radio frequency can be performed at 55 to 60. deeper, more spherical and larger lesions, pulse radiofrequency ablation can be done at 42 degrees, right? The difference between pulsed and regular is, the temperature is the difference, right? Only 42 degrees. See the difference between the lesions here? This is the cool radiofrequency, much bigger, spherical, and see how the volume of the lesion is much bigger than when you compare it to the regular radiofrequency lesion, right? So pain relief with radiofrequency lesioning is expected to last for around 6 months. Complications, I need not go into every single one. Infection is there. Infection can happen from the skin to all the way to the transverse process. It can get infected, right? Bleeding, hematoma, skin to the facet joints. Trauma, skin to the facet joints. Nerve, spinal cord injury, can it happen? Yes, rare, very rare, because you're not going anywhere near the spinal cord or the nerve root. Sometimes you can inject the nerve root, epidural injection. Intravascular injection, you can have an embolism. Contrast-related complications, adverse reactions, kidney problems, and stuff like that. Medication-related, what medication you've injected. So that, I think, completes my talk. Thank you, guys. In time? On time. Okay, great. So I'm on time, so.
Thank you for enlightening lecture, sir. Next lecture is on lumbar vertebral fractures, pathophysiology, diagnosis and treatment by Dr. Uma Maheshwar Rao.
Good afternoon to all. So my topic is lumbar vertebral fractures, diagnosis and treatment. So can someone tell me what are the causes for lumbar spine fractures? Because we all work in OT, the commonest being osteoporosis, trauma, or it can be malignancy. So let us be a case study here. A 75-year-old woman with a long history of onset of unrelenting and severe mid-back pain after a strong sneeze. She has pain on movements. Her pain was unresponsive to a 6-week course of conservative therapy with non-steroidal anti-inflammatory drugs and opioids. She has been bed-bound since her symptoms started and was referred for consultation to a specialist for treatment. So what could be the diagnosis? So what problems we have here? She is a 74-year woman, geriatric, sudden onset of pain, with small movements, even for a cough and sneeze, she has back pain, she is unresponsive to medications and she is bed-bound. So what are the differential diagnoses we have here? So it could be a vertebral compression fracture or an acute intervertebral disc herniation, muscle spasm of the paravertebral muscles, or a degenerative joint disease or a facet arthropathy. So the closest, because of her signs and symptoms, being an elderly lady, female who is menopausal and who has a pain in the back, the commonest diagnosis we come to is an osteoporosis. The main symptoms are increased axial pressure from the forceful cough, unrelenting pain with small movements, tapping. Whenever there is patient complaints of pain, she'll be holding the site. So we just tap the area above and below, possibility she may jump with pain. In case of disc herniation, there may be radicular pain, or in case of facet arthropathy, it can be central or paramedian. So what is the difference between a simple or a burst fracture? So let us come to, before going to that, let us see what are the causes of fractures of thoracic or lumbar spine. It can be because of spinal fractures, which can be because of osteoporosis or tumors, a motorcycle or a car collision, or fall from a significant height, or it can also be a sports accident. So if you see, the causes are major is osteoporosis, tumor and traumatic injury. The risk factors are women of increased age. It can be 50 years who has just started a menopausal, or it can be post-menopausal who are more than 70 years. Lack of calcium, lack of vitamin D, high intake of cigarettes and coffee and alcohol. The other contributing factors can be hypercalcemia, hyperthyroidism, abnormal renal functions, and use of steroids. So what is the pathogenesis of vertebral compression fracture? If you see, for all, if I am standing, the pressure for my whole body starts from cervical and comes down up to the sacrum. In the cervical, if you see, it is on the vertebral body and as well as on the facet In the thoracic, it is on the vertebral body and the lamina, it's pedicle. In the lumbar area, it is basically concentrated on the vertebral body as well as on the lamina and the pedicle. So this is the normal load which we all face. But when there is any injury, what happens? The actual load leads to biochemical failure of the system, and it causes compression fraction. The center of gravity, if I am injured or anything, osteoporosis happens, I start bending forward. The posterior ligaments prevent it from falling. In case the compression is very high, the vertebral body height is reduced, then the patient starts stooping. That leads to kyphosis. So this is the change in the center of gravity which is there when there is any vertebral fracture, either it could be because of the trauma or osteoporosis or because of the cancer. The center of gravity is shifted from the central to the anterior. So all these fractures are basically a flexion type of fractures. The most common etiology of vertebral compression fracture is osteoporosis. The next is trauma. The third is the cancer. So Dennis in 1983 described the 3-column model for spine, how to classify these vertebral fractures into 3. If you see here, if this is anterior and this is posterior, the anterior column, anterior longitudinal ligament, anterior 2/3 of the vertebral body and anterior 2/3 of the annulus. Any fracture which is confined to this anterior column is called as stable or a simple fracture where the vertebral height is less than 20% reduction. In the middle column, you have the posterior 1/3 of the vertebral body, annulus, as well as the posterior longitudinal ligament. In the posterior column, you have pedicles, facets, lamina, spinous process, and interspinous ligament, as well as supraspinous ligament. In case these two are involved, like the middle column or majority of the posterior column, then there can be a neurological deficits. So why do we require this classification? The purpose of the classification is to determine if the fracture is stable. Stability indicates or dictates how to treat the symptom patient. A stable spinal fracture is one that allows patient to assume activity. A fracture involving one column is stable, whereas the fractures involving 2 or 3 columns is unstable. The major reasons for any spine fracture is flexion, extension, or rotation injuries. So coming to the different type of fractures, that is compression fracture, it is basically excessive flexion of the spine, which usually involves anterior column. If you get an investigation done, the AP X-ray is normal, but in lateral view you can see wedging of the anterior column only. So how do you treat with this? Bed rest, medications. In case the patient is stooping, then we can use an anterior support or called as lightweight brace or a corset, and ask the patient not to lift any weights or bending. The prognosis is very good in case it's only limited to an anterior column. In case of burst fracture, along with the excessive flexion, there is compression of the spine. So this may involve an anterior or a middle column. Approximately 50% of these can have neurological problems. When you see an X-ray in AP view, there is widening of the pedicles. Because of the collapse of the vertebral body, the pedicles are moved away. That is spacing of the pedicles. In the lateral X-ray, you can see wedging of more than 20 degrees. In these cases, the best investigation is CT scan. So how do you treat? To preserve or to improve the neurological function, to maintain the spinal alignment. That is the main goal of this. And the prognosis of this condition depends on the age and the degree of neurological injury. If there is any neurological injury, we have to go over with surgery. The third is the chance fracture. It is along with the excessive flexion, there is distraction force. This is basically motor accident, and all 3 columns are involved. That means the neurological component is also there. Then the patient should take up for immediate surgery and fixation of the spine has to be done. So what do you see in this chance fracture? AP may not show anything, but in the lateral you might see the spinous processes, facet, pedicles, as well as the ligaments are torn out. Prognosis is good in case the surgery is done immediately. There is another term called as fracture dislocation, where the spinous ligament are torn. In any person who is wearing a seat belt and there is an head-on collision, there is high chance that the middle and the posterior columns are distracted. This leads to as well as bone fracture, including the neural damage. So immediately this patient has to be taken for surgery and the stabilization of the spine has to be done. So how is vertebral compression fracture diagnosed? Basically it all goes with history and physical examination. In the physical examination, in case of osteoporosis, you might find a tenderness at the spot. In case of neurological deficit, patient may have paraplegia or any deficits below the umbilicus. The most effective way of diagnosis is to diagnose with the lumbar X-ray, then CT scan, MRI. Why is MRI important? It tells us about the age of the fracture, spinal column, any compromisation is there, or any presence of tumor. So when we get an investigation done in case of X-ray, we have to look for AP view as well as lateral view. Why we require AP view is to find any interpedicular widening or any loss of vertebral body height. In case of lateral view, we have to check for any wedge fractures, loss of anterior body height, posterior elements or any damage like pedicles or facet joints are damaged, or any kyphosis is there in case the fracture is more, any lordosis. When there is kyphosis, the degree of the compression of the vertebral body is more than 30 to 40%. CT scan, we have to look for any spinal canal compromise, competition fractures as well as facet fractures. In MRI, we will usually find about the neural tissue damage, intervertebral disc fractures, ligamental structure fracture or any hematoma is there following the trauma. MRI shows, this MRI if you see, this is the continuity of the spinal canal, but if you see there is a fracture and dislocation. The fracture of the vertebral body as well as dislocation. They both had moved ahead. That is anterior dislocation of the vertebral body. So how to differentiate between an acute fracture or a chronic fracture? Any injury which is very acute, what happens? The vertebral body has fractured, there is hematoma or there is water within the bone. So this we see as an edema within the vertebral body. In case the fracture is more than 4 weeks, then there is no edema within the vertebral body which we can be identifying in the MRI. In case the patient is having any metastasis or a malignancy which has spread to vertebral body or other body structures, the next test which we can do is a PET CT, where it can identify any inflammation or any infection within the body. The PET CT picks up these signals. So what are the treatment of compression fractures? The goal of the treatment is pain management, rest, rehabilitation and restoration of mechanical stability. The treatment as a non-operative therapy is bed rest, which can be of 4 to 6 weeks. If there is long duration of bed rest, which can lead to fatigue, loss of muscle strength and reduction in the bone density. Back braces can be used and rehabilitation to strengthen the bone density along with the core muscle strengthening has to be done. So these are the different varieties of supports and braces. So what are the medications we can use? So these are the routine medications which we use like bisphosphonates, monoclonal antibodies like denosumab, hormone therapy. In case of females we use raloxifene and in case of males we use testosterone. All these treatments goes in favor of osteoporosis or in supplementation of postmenopausal females or an elderly male who is more than 60 or 70 years who has osteoporosis. Along with this, we have to supplement with vitamin D as well as calcium supplements. So these are the different medications which we use as a prophylactic dose as well as treatment doses. So the rest comes to restoration of mechanical stability. If the fracture is less than 3 months, so what do? We do a vertebroplasty or a kyphoplasty. If the chronic fracture is more than 3 months, then we have to go ahead with medial branch block, which has been discussed earlier, and the ramucommunicants can also, injection can be given. In case longer term relief is to be obtained, then radiofrequency lesioning of these medial branch block as well as ramucommunicants can be done. So vertebroplasty is nothing but a percutaneous treatment of painful vertebral collapse secondary to a metastatic lesion, osteoporosis or a multiple myeloma. So vertebroplasty is nothing but injecting the cement into the vertebral body, and kyphoplasty is nothing but if there is a fracture in the anterior vertebral body or anterior 1/3. So we put a cannula, which is similarly we do with the vertebroplasty. After putting the cannula, we pass a balloon and inflate and increase the height of the vertebral body. So later on, after the inflation is there, we create a cavity within the vertebral body. Then we remove the balloon and inject the high viscous cement. So what is the mechanism of pain relief with these vertebroplasty or kyphoplasty, there are three mechanisms. That is mechanical theory, that is filling the gap with the cement. Like what we do for filling the gap in the, as we construct the building, we put the cement in between the two bricks. Similarly, the same principle is used. There is a crevices or a clefts within the vertebral body. So we are filling this gap with the cement. The second is thermal theory. Heat generated by these cement neutralizes or numbs the nerve or coagulates the nerve. The third is because of the compression of the vertebral body, there is an increased intraosseous pressure. Because of the vertebroplasty or kyphoplasty, the pressure within the vertebral body is reduced. So what is the procedure like? This is done usually in a AP view. As sir has told, we do the squaring of the vertebra, identifying the pedicle, and we put a needle through the pedicle, and we land that in the anterior one-third. The needle, the cannula is passed up to the anterior, the posterior one-third. Once this is done, we just pass on the cement. This is called as vertebroplasty. And a similar procedure is repeated, and instead of putting the cement, what we do is, after the needle is placed, we inflate or increase the height of the vertebral body. After inflating, we create an empty space, and this is filled with the cement. So this is how you see bilaterally the both sides the pedicles are entered, and this is called as bipedicular approach of kyphoplasty. So what is the evidence with this? We have 2B+ evidence. In case of the medications which you have, they all have 1A or 1B evidence. The newer methods of vertebral augmentation has come. All these procedures, vertebroplasty or kyphoplasty, they say that the aim of these vertebral fractures is to maintain or stabilize the vertebral body, that is to increase the height. But all those procedures have, after doing the procedure, after 6 months, there is a reduction of 30%. If you have achieved 60% after the procedure, over a period of time, there is a further reduction of 30%. So this can be prevented by these called as vertebral body stents. This is similar to a like coronary angiogram or coronary angioplasty which is done. Similarly to the technique of coronary angiogram, a tubular shaped metal stent is, cannula is put into the pedicle and it is placed in the posterior one-third. After that, the balloon is done. Within this balloon, an device is released similar to the coronary angio stent, and this device is filled with the cement. After the cement is done, the balloon is removed, and this device which is there stays there only. This is called as vertebral body stent. There is one more device called as Kiva implant design. This is similar to what the vertebral body stent is there, but the structure is totally different. It's like a coil which sits within the vertebral body, and this retains the height of the vertebral body, and the pain is reduced. So at the end, what is the treatment of all these vertebral body? It's a multimodal approach. Whether you have to give a physical manual therapy or physical therapy, pharmaceutical therapy has to be given. Any procedures are required, right, in case of vertebroplasty or kyphoplasty or radiofrequency lesion. And psychobehavior therapy also has to be, because all these patients who have vertebral compression fractures may be having social isolation, or they can be depressive, and they might lose job also. So in case all this multimodal approach is required for this sort of a condition. Thank you.
Thank you so much, sir. I request Dr. Sridevi ma'am to present the moment to Dr. Umay Maheshwar, sir. Next, we have lecture on clinical anatomy of the knee joint by Dr. Rajneesh, Assistant Professor of Anatomy, Gandhi Medical College.
Graduates, so I'll be considering all of you as my first year medical grad students only. So I'll be going in a very basic manner. My lecture has more of pictures. So you can enjoy pictures if you don't understand anything. So that is the bare minimum which I can provide for you people. Okay, so let us start off. So this is the anterior view of the knee joint. So I'll be showing basically knee joint in various views. So this is knee joint in anterior view, and this is lateral and posterior views. Okay, so and these are the basic headings under which we discuss the knee joint. I think most of you are going back to your vivid memories of first year. I'll be very happy if you feel that. Okay, so these are the basic headings under which we discuss a knee joint. Knee joint is the largest joint of the body, and it is the most common joint to undergo osteoarthritis because it's the weight-bearing joint, and that's the reason why knee joint most commonly undergoes osteoarthritis. So basic description of knee joint, it's a modified hinge. Now how many of you know what's a hinge? That's a hinge. That's a hinge joint. Movement is possible only in one axis. But it's a modified hinge. Now what do I mean by the word modified hinge? When I'm doing flexion and extension of knee, invariably I'm also doing a bit of medial and lateral rotation as well. Then I'm also telling it's a compound joint and a complex joint. What do I mean by compound? More than 3 bones are taking part in this joint formation. And complex, the joint cavity is divided by meniscus. Most of you, the interest area meniscus. The meniscus divides this joint into compartments. When a joint is divided into compartments, it's called a complex joint. So anatomically speaking, structurally, it's a bicondylar joint. Condyles of tibia and femur articulate, and the joint between femur and patella is a saddle joint. Okay, so this is the saddle joint, and these are the movements possible at saddle joint. Articulating surfaces are the lower end of the femur, the condyles of the femur, the anterior, posterior, and inferior aspects of the condyles. These are the condyles. The anterior, inferior, and posterior aspects of the condyles take part in the joint formation. Similarly, superior surface of, this is the superior surface of the condyles of the tibia. They articulate with femur and take part in the formation of knee joint. The third bone which is taking part in this joint formation is the patella. The posterior surface of the patella, you can see here, that's the posterior surface of the patella, which articulates with the trochlear surface of the femur, and that forms the saddle joint. So this is the basic idea about the bones which are taking part in the joint formation. And now coming to ligaments, a very, very important area of discussion for today. Ligaments, so you have primary ligaments and accessory ligaments. Primary ligaments are the ones which mainly support it. Then we have the primary ligaments, the first ligament of discussion is capsule. Everyone knows capsule completely encloses the joint. So it is attached, generally capsules are attached to the articular margins, but over here you can see I've put a red dotted line. It's not exactly attached on the articular margin, but slightly beyond the articular margins. Slightly beyond the articular margins, and this is the posterior attachment of it. The capsule over the femur is slightly weak. It's slightly weak, slightly deficient because of presence of suprapatellar bursa. Yes, so that's the suprapatellar bursa in sagittal section. But don't worry, it's strengthened by another ligament, by ligamentum patellae. Okay, we'll come to that later on. And then, so you can see there that it is strengthened anteriorly by a ligament known as ligamentum patellae. Then this is a very important point in this picture. Intracapsularly, there is a very important tendon known as the popliteus tendon, and the capsule is deficient for the passage of the tendon. The clinical relevance of this tendon I'll discuss eventually. Okay, so next we have the synovial membrane. The red color lining is the synovial membrane. It lines the inner surface of the joint capsule but doesn't cover the articular cartilage. If it covers the articular cartilage, then there is no purpose of having an articular cartilage. So it doesn't cover the articular cartilage. Okay, the synovial membrane extends above, has communications with different bursa as well. So these are the different attachments of the synovial membrane. I'll be discussing only about the important clinical points. I'll not go into the basic minute points which I generally take in an undergrad class. Okay, so the next ligament which is strengthening the joint anteriorly is ligamentum patellae. It's around 7.5 centimeters, and these are the attachments of that ligament. Apex is attached to the patella while the base is attached to the tibial tuberosity. Yes. And the ligaments which strengthen this joint, on the sides, side-to-side stability of this joint is brought about by the collateral ligaments. The literal name collateral, they are present on the sides of the joint. You can see they are tibial collateral and fibular collateral ligaments. Tibial also known as medial collateral, and fibular also known as lateral collateral ligaments. So if you know the basic anatomy, this is femur, tibia, and fibula. So the attachments are also same. Extending from femur to tibia, tibial collateral. Extending from femur till fibula, head of the fibula is the fibular collateral. I can be a bit more specific, but because of time constraints, I'm not being specific. If you want me to elaborate on anything, so please pause and you can ask. Yes, so this is a live dissection picture of the collateral ligaments. These ligaments get damaged when there is pressure from the sides. We call them as abduction injuries and adduction injuries as well. A blow from the lateral aspect on the knee joint damages the tibial collateral ligament, and a blow on the medial aspect of the knee joint damages the fibular collateral ligament. Okay, so these are the attachments of these ligaments, of these collateral ligaments. Medial collateral, medial epicondyle till the tibia, and this is the lateral epicondyle. Yes, so these are the various sprains and tears of these ligaments. There are different degrees of sprains. First degree, second degree, and third degree. These are encountered when there is a blow on the lateral aspect of the joint. Then we have the cruciate ligaments. They are cruciform, X-shaped. They are responsible for the anteroposterior stability of the joint. Okay, so we have anterior and posterior cruciate ligaments. This is the cadaveric dissection of these ligaments. Okay, they are responsible for anteroposterior stability. There are two of them, anterior and posterior. This is posterior view of the knee joint. So, without stressing on their attachments, I'll tell you what is the purpose of them. First of all, why anterior cruciate is called anterior cruciate? Because it is attached along the anterior aspect of the tibia, and posterior is attached on the posterior aspect of the intercondylar area of the tibia. Now, what's the job of these cruciate ligaments? Cruciate ligaments, anterior cruciate, prevents forward displacement of tibial condyles when we are walking. And posterior cruciate prevents backward displacement of the tibial condyles when we are walking. So what happens if these ligaments get torn? Okay, so if there is anterior cruciate ligament when I'm walking, now suppose if I'm supposed to step on this block, without my knowledge, I'll be putting a step forward. This is what happens. This is known as, this happens when there is anterior cruciate ligament, and the reverse happens when there is posterior cruciate ligament tear. They're responsible for anterior and posterior stability. They prevent displacement of tibial condyles when we walk. Okay, yes. Next. These are the various tests by which we can diagnose anterior cruciate ligament. See, basically, anterior cruciate ligament, medial meniscus, and tibial collateral, these are the three ligaments which get damaged more easily. The mode of injury of anterior cruciate ligament tear is you're standing firmly on ground, and sudden twisting movements of the knee. Sudden twisting movements of the knee, it produces a popping sound and a tearing feeling. The result is anterior cruciate ligament is gone. Okay, so you can test anterior cruciate ligament tear by Latchman test and also by anterior drawer sign. Here you can see the examiner has stabilized both thigh and leg, and they try to move the knee joint forwards and backwards. A movement of more than 5 mm. A movement of more than 5 mm is positive Latchman and positive drawers test. Okay, this is specifically done for anterior cruciate ligament tear. Then we have the all-important menisci. Menisci are those cartilaginous swabs. They are cartilaginous swabs. Basically, if you see the condyles of femur, they are more convex, while the condyles of tibia are more flat. So what do these menisci do? They provide congruence between these articulating surfaces. They make the articulating surfaces more reciprocal. We have two menisci, medial menisci and lateral menisci. Both the menisci have got two horns, two surfaces, and two borders. Okay. Now, medial meniscus is more prone for injury. Now, I told you anterior cruciate ligament on firm standing twisting results in anterior cruciate ligament tear. Semi-flex knee twisting results in medial meniscus tear. Especially this is seen in different kinds of sports persons, football player, basketball, and shuttle players, very common. And medial meniscus degeneration also takes place physiologically. Okay, that's why people also develop osteoarthritis. Now, what's the other important function of these menisci? These menisci provide a potential joint space so that the articular surfaces and the cartilages, they can be flushed with synovial fluid. So when they get flushed with synovial fluid, they get their nutrition and they maintain their integrity. With age, as they degenerate, the menisci degenerate, the space is lost and there is no flushing of the articular surfaces by the synovial fluid. Okay, yes. So another thing about medial meniscus is firmly attached to the tibial collateral ligament and also the joint capsule. Okay, so this is the medial meniscus, which is, are you able to see it is attached to the tibial collateral ligament, and it also blends with the capsule. So, what happens? What happens? Whenever I'm jumping from a particular height, medial meniscus, because it is firmly attached to the tibial collateral ligament and also the capsule, it cannot escape. While lateral meniscus, when I'm jumping from a particular height, it is protected, it escapes because of the pull. The posterior part of the medial meniscus is slightly pulled backwards by popliteus muscle, which prevents the crushing injury of lateral meniscus when a person is jumping from a particular height. Okay, here you can see medial meniscal tear. Medial meniscal tears are more common because it is more firmly attached to the fibrous capsule and the tibial collateral ligament. These are the various kinds of medial meniscal tears. The mode of injury which I described, flexed position, twisting, it results in bucket handle tears of medial meniscus. So, this is how generally we test for medial meniscal tears. In this semi-flexed hip and knee, the examiner is rotating the tibia over the femur. When this rotation, when medial rotation is taking place, if there is pain, then it is medial meniscal tear, and if it is pain on lateral rotation of tibia over femur, then it is lateral meniscal tear. You can see this. That is how he's holding the foot and sole and he's twisting. So there's lateral rotation and there is medial rotation. So when there is pain on medial rotation, then it indicates that it's a medial meniscal tear. This is, so I've discussed three sets of ligaments, menisci, collateral, and cruciate ligaments. All three ligaments getting damaged, that is tibial collateral, medial meniscus, and anterior cruciate ligament is considered as an unhappy triad. Okay, all put together. Then these are accessory ligaments, I'm just gonna name them. Oblique popliteal, arcuate popliteal, and coronary ligaments. The three sets of ligaments which mainly support the knee joint, I've already discussed them. These are just accessories. Okay, so knee being one of the largest joints and performing a lot of movement, weight bearing, a lot of movement taking place, it's provided with a lot of bursa. Okay, so we have bursa on all sides. We have anterior bursa. Please look at the names. There's a suprapatellar bursa just above the patella. In front of the patella, there is a prepatellar bursa just below the skin, that is subcutaneous prepatellar, and there is subcutaneous infrapatellar, and there is deep infrapatellar based on their position. Out of this, subcutaneous prepatellar bursa is affected. If it gets inflamed, it's called housemaid's knee. I'll be discussing about it eventually. And subcutaneous prepatellar bursa gets inflamed, it's known as clergyman's knee. Okay, yes. So we also have posterior bursa between the capsule and the respective heads of gastrocnemius, and we have medial bursa and lateral bursa. So all these bursa they make the movements of the knee joint more smooth. Okay, yes. So relations, why we need to read about the relations of knee joint? They provide stability to knee joint. So just behind the knee joint, posterior relations is a very important neurovascular bundle which includes tibial nerve, popliteal artery and popliteal vein. You can see here posterolateral relations, biceps femoris, plantaris, common peroneal nerve, and gastrocnemius lateral head. Posteromedial relations, gracilis, semimembranosus, semitendinosus, and medial head of gastrocnemius. Basically, if you remember which of them is medial and lateral, you can understand the actions when I'm discussing actions of knee joint. So laterally, we have biceps and lateral head of gastrocnemius, and medially, we have semimembranosus, semitendinosus, and medial head of gastrocnemius as well. These are the anterior relations. It is stabilized anteriorly by the retinacula, lateral and medial patella retinacula. Blood supply. Around the knee, we have an anastomosis known as genicular anastomosis, and the branches of these genicular anastomosis nourish the knee joint. And these are basically branches of femoral and popliteal artery. This anastomosis is there because knee joint generally tends to get flexed, and if it gets flexed, there shouldn't be any hindrance in the blood supply of leg. Yes, nerve supply. It is supplied by femoral, tibial, and common peroneal and also obturator nerves, but the most important point is the root value. Generally, the movements near knee joint are flexion and extension. Flexion, nerve supply, is coming from L3 and L4 spinal nerve roots. Those spinal segments are responsible for movements of extension of the knee joint. And then L5 and S1, they are responsible for producing flexion. Now, why do you ask what is the relevance of this? In any condition of lumbar disc prolapse or lumbar fractures, when these nerve roots are getting compressed, these movements are affected. Okay. Yes. So you can see there, extension at knee is by L3 and L4, and flexion is by L5 and S1. Yes, so movements possible at this joint are flexion and extension. Flexion and extension are the main movements. So, what do I mean by extension? I'm bringing my thigh and leg along the same vertical axis. So, now I have flexed my knee. So, these movements, muscles of the anterior compartment of the thigh, when they contract, there'll be extension. And in the same way, in order to flex, there'll be contraction by muscles of my posterior compartment, and when they pull it backwards, there'll be extension. So you can see here, the muscles which are present on the back, hamstrings, we call them as hamstrings, they're responsible for flexion, and the muscles which are present in the front, they're known as quadriceps, they're called as, quadriceps are responsible for extension. And then we have conjunct movements. I told you it's a modified hinge. So there is some amount of medial rotation and lateral rotation. The muscles which are present along the medial aspect, that is semimembranosus and semitendinosus, are responsible for medial rotation, while biceps femoris is responsible for lateral rotation. So these are the movements which are possible at flexion and extension. The degree of flexion is 120 degrees, and in a semi-flexed hip, it can go to 140 degrees as well. Extension, after attaining vertical, completely falling in a vertical line, still 5 degrees is possible. And what is locking and unlocking? Locking is the most stable position of the knee joint, and unlocking is slightly unstable. So what's locking? The terminal phase of extension I cannot extend my knee further. That is known as locking position, and as I've already told you, extension is brought about by muscles of my anterior compartment of thigh. Unlocking is the first phase of flexion. Locked, and I'm complete extension, I'm just going back into flexion. The initial phase of flexion is known as unlocking. Okay, it's known as unlocking of knee joint. It is brought about by popliteus muscle. Yes. So stability of the knee joint, as I've already told you, it is surrounded by such strong muscles. You can see those muscles both in anterior and posterior view, and collateral ligaments responsible for side-to-side stability, cruciate ligaments responsible for anteroposterior stability, and menisci, they provide a lot of, lubrication. They also provide potential space for the joint for lubrication with synovial fluid as well. So I've already discussed anterior cruciate ligament twisting on firm standing. When you stand firmly on ground and you twist, anterior cruciate ligament comes with a popping sound and a sensation of tearing. And I've already shown you how to test for anterior cruciate ligament tear. And with aging, as the menisci degenerate, the articular cartilages rub against each other, and it results in osteoarthritis. So this is this was the housemate's knee which I was talking. Because of continuous friction, physical trauma to the bursa allows septic contamination. Bacteria can enter, and that can produce housemate's knee. And just below that, here I've shown you this. This is subcutaneous prepatellar bursa, seen as clergyman's knee. Okay. And this is Baker's cyst. This is a fluid collection along the posteromedial aspect of the knee joint, seen in people with osteoarthritis and with meniscal injuries. Fluid collection, sometimes, 50% times it's asymptomatic. In some people, mostly it keeps the knee in locked position. It hinders with the process of unlocking. Okay, yes. So these things you know better than me. Just for the sake of putting it, I've put this is arthroscopy and this is knee replacement. There are much more better people to talk about this. So this finishes my brief emphasis on knee joint. Thank you for your patient listening, and I thank ma'am for giving me this opportunity.
Thank you for a wonderful lecture, sir. Now we will take a short break of 15 minutes. Thank you.
other studies, Schweizler's, he has seen the incidence of the low back pain due to SI joint involvement is around 13 to 33%, 30%. This is almost 1/3. So coming to functional anatomy, so it's a diarthrodial joint which is formed by sacrum as well as ilium. In this joint, on sacral side you have hyaline cartilage, whereas on iliac side you have fibrocartilage. Only, it's not a true synovial joint. Only the anterior 1/3 of the joint is covered by synovial membrane. Rest of the joint is covered by ligaments and muscles. The joint is C-shaped and it has two lever arms, like one is ilium and sacrum. The joint is have multiple ridges and depressions. So because see, if you see the other joints like shoulder, knee, they have very smooth surfaces. The articular surfaces are smooth, but here the articular surfaces are not smooth. They have depressions and ridges. So anyone can tell me the reason behind this? Why this joint, the articular surface is having ridges and depressions? Yeah, because this is for stability. Because see here, the stability is given at the cost of mobility. Because at this joint, the movements are very limited. Whereas the other joints like shoulder and knee, the stability is not that important because the mobility is given importance over there. So the joint, it acts as a shock absorber. So here the vertical forces from the spine are transmitted to the hip and lower extremities through SI joint. The stability, as already discussed, are provided by the ridges in the joint. And see, the joint is covered by a lot of ligaments and which gives more stability, as well as muscles which provide more stability. So any inflammation, infection in these ligaments and muscles will give rise to SI joint pain. So if you see in this picture, so the joint is surrounded by the muscles like gluteus maximus, minimus, medius, then piriformis, and also it is covered posteriorly by long and short posterior sacroiliac ligaments, then sacrospinous, sacrotuberous ligaments. So lot of ligaments and muscles cover the joint and they provide the stability to the joint. So if you see, this is a cut section on the sagittal plane. We see this is a C-shaped joint. Can you appreciate this? So that's the weight bearing area, and posteriorly it's a fibrous joint. So anterior joint has a synovial cartilage. So if you see here, it's a C-shaped joint. It's a weight-bearing joint. So anteriorly, it's having a 1/3 joint is synovial, where posteriorly it is a fibrous joint. So anteriorly also it is covered by numerous ligaments, sacrocoaxial ligaments, sacrospinous ligaments. Then coming to innervation, the innervation of this joint is very complex because the joint is innervated by the dorsal rami of L4, L5 and lateral branches of S1, S2, S3. But sometimes even the supply it gets from S4 as well as from L3. So the innervation is not constant. So due to that, what happens when we do the denervation of the joint, the results are not consistent because we don't know the exact innervation, because sometimes the joint get innervation from L3 as well as from S4. So that thing you have to, because the nerve supply is variable. That's very much important. So if you see over here, so the joints, the SI joint is supplied from the lateral branches of S1, S2, S3 and dorsal rami of L4, L5. And these are the sites where they usually give injections for SI joint pain relief. Now what is the pathology? So pathophysiology of SI pain is mainly, it might be intra-articular or extra-articular etiologies. So intra-articular etiologies like inflammation, then like osteoarthritis or joint capsule disruptions, whereas the extra-articular, because the joint is covered by ligaments and muscles. So extra-articular pathologies like any muscle injuries or ligamentous injuries or inflammation outside the joint. So hypo or hypermobility of the joint. So hypermobility, usually during pregnancy, the females will have hypermobile joint. What might be the reason? Anyone? Delegates? Which is the hormone which produces that, which relaxes the ligaments around the pelvis? Yeah. So usually the relaxin hormone which relaxes the ligaments. Why it relaxes? Because it has to accommodate fetus. Okay. So due to that, but it comes at a cost of SI joint pain, because due to this hypermobility, there is a high prevalence of SI joint pain in females who are pregnant. So patient can develop SI joint pain spontaneously after trauma as well as repetitive shear. So what are the risk factors? So most common risk factor is patients who have a history of lumbar fusion. See what happens, because as already told, the joint acts as a shock absorber which transmits the vertical forces from the spine to the hip and the legs. So what happens during fusion? The fusion, usually the lower fusion like L5 S1 or L4 L5 fusion of the spine, which lead to the immobility at the facet joint. So due to this immobility, the more pressure, more shear has been transferred to the SI joint, and that's why the involvement of SI joint is common in the patients who have a history of lumbar fusions, especially lower lumbar fusions. Next is scoliosis, because of the anatomical change in the anatomy, as well as leg length discrepancies or poliomyelitis, where you will have a pressure on particular opposite joint. Usually there will be involvement of the opposite joint where there are the leg length discrepancies, means shortening of the legs. Sustained athletic activity, pregnancy, and seronegative arthritis like HLA-B27. Then spondyloarthropathies or gait anomalies. The inflammation of the SI joint surrounding structures. See, because the joint is surrounded by muscles, ligaments, so any inflammation or infection surrounding the SI joint can mimic the SI joint pathology, because it will give us same pain as the pain which is produced in SI joint pathology. So how we will evaluate this patient? So first and foremost is the history. So what is the most common presentation of this patient? What is the most common symptom? The most common symptom will be pain. So pain at SI joint area. Usually SI joint is correlated with the posterior superior iliac spine. So usually patient will put a finger at the posterior superior iliac spine, and patient shows that he has a pain over there. So that is called as 14 finger test. Usually the patient will point the site where he is getting pain. So that is a confirmatory sign that there might be a chances that SI joint might be involved in those cases. Then however, the pain might radiate to the low back as well as posterior thigh or calf muscles. Patient often, this pain is aggravated by sitting for longer duration and by rotating or twisting movements. Then what is the quality? Usually the pain is dull ache, stabbing and knife-like pain, and pain distribution, as already told, the pain get referred to the lower back, buttocks as well as calf muscles, and the pain is in the distribution of L5 S1 nerve roots. So, and the patient will tell that, because they describe the pain, it is like a sciatica pain, but actually it's not a pain which comes in sciatica, because sciatica pain goes up to the great toe or below the calf muscles, but here the radiation will be till calf. Then, and the pain is worsened by loading the joint, like the pain is worsened if patient is sitting for longer time or axial movements, standing, walking or twisting movements. Then the chronic SI joint pain can lead to dyspareunia as well as bladder functions. So physical examination, the International Society of Study of Pain have proposed some criteria to evaluate the SI joint pain. They have proposed 3 criteria, and the most of the patients should fulfill these criteria, then only we can diagnose that pain as a SI joint pain. The criteria are the following. The pain must be in the area of SI joint, as I already told you, at the level of posterior superior iliac spine, and should be reproducible by specific provocative tests. Provocative tests are tests where you put the joint at stress, so which will provocate the pain. And third, and pain must be relieved by injection of local anesthetic and steroid in SI joint. So on inspection, usually inspection we show there is a asymmetric height. So usually patient we have altered gait, and the height of the pelvis is asymmetric because of the pain. Palpation, which will lead to the pain at the level of posterior superior iliac spine, and also the pain can be reproduced by palpating the posterior superior iliac spine. If you put a pressure with a finger on posterior superior iliac spine, patient will wince in pain. So you can reproduce the pain. So what are the provocative tests? Usually provocative maneuvers, the use is controversial, because the false positives are more with the provocative test, because provocative test can be positive even though surrounding structures like muscle and ligaments are involved. So the first one, first provocative test is distraction test. In this, the patient lies supine and the examiner put downward pressure on the iliac crests. So if it reproduces the pain, then the side will be the affected SI joint. Coming to the thigh thrust test, in this patient lies supine with his sacrum is stabilized with the examiner's left hand, and he puts a pressure along the length of the femur, and that produces the distraction of SI joint and it reproduces the pain. Because in this, that thigh thrust test is more sensitive, whereas the distraction test is more specific. If these both tests are positive, then there is a high likely chance that patient has diseased SI joint. Okay. Then coming to next test, the compression test. In compression test, patient lies in lateral position and the examiner gives pressure on the iliac crest, ipsilateral iliac crest, and the pressure he puts downwards. If it provocates pain, that means that side of the SI joint is involved. Then sacral thrust test, in this the patient lies prone and examiner puts pressure on the sacrum vertically down, and if produces pain, that means the SI joint is involved. The Jensen's test, in Jensen's test, patient lies supine on the table and the affected limb will be hanging at the edge of the table, whereas the opposite limb is the hip is flexed on the abdomen, and he keeps pressure on the opposite thigh. If it reproduces pain, that indicates that there is involvement of SI joint on that side. This is a Jensen's test. Then this is a Patrick or Faber's test. In this, the patient lies supine with the knee flexion and abduction, and he puts pressure on the knee. If it provokes pain, that means that the ipsilateral side is involved. So in all tests, pain is the typical area at that side, at SI joint area is a suspicion for SI joint lesion. Unfortunately, there are a lot of randomized studies which have proven that these provocative tests are not that reliable. So the differential diagnosis for SI joint pains are hip fractures, hip osteoarthritis, tendinosis, tendonitis, iliotibial band syndrome, lumbar spinal stenosis, spondylosis, spondylolisthesis of lumbar spine, then lumbosacral discogenic pain syndrome, lumbosacral facet syndromes, lumbosacral radiculopathy, pyrofarmus syndrome, superior cluneal nerve entrapments, as well as superior trochanteric bursitis, greater trochanteric bursitis of the hip. So how we should approach this? See, when you see the patient that having a SI joint pain, before you have to exclude the other pathologies, like we have to rule out the pathology, hip pathologies as well as spine pathologies before coming to diagnosis of SI joint pain. So it's a diagnosis of exclusion. So laboratory studies, usually these studies, if the pathology is infective or inflammatory, so we can do the complete blood count, where if the pathology is infective, the total counts will be raised, then erythrocyte sedimentation rate, C-active protein will be more in infection as well as in inflammation. Then antinuclear antibody and human leukocyte antigens are positive when there is any autoimmune pathology and rheumatoid factor as well. So in patients, see, actually the patients who have a chronic sacroiliac pain, usually they might go into depression. So they might go into depression. If there is a component of depression, then we have to diagnose, we have to see for the hypothyroidism as well as cortisol abnormalities, because these are more common in patients who are having depression. As well as if the aged patient is presenting with SI joint pain and with conservative management he is not responding, then we have to see for any malignant pathologies, like most commonly the prostate malignancies, which can metastasize to SI joint. So we have to look for PSA. So imaging modalities, there is a lot of controversy in imaging, because see what happens, so they have found that accidentally there is a SI joint pathology with degeneration of the SI joint as well as the inflammatory findings in the SI joint, but patient doesn't have pain in the SI joint. Whereas they have seen a patients who are coming with SI joint pain and they have seen an image, they have done X-rays as well as CT scans, and they have found out that there are no changes in the joint. So it's very controversial, because due to this there is no correlation between the imaging modalities the images what you are seeing and the symptoms. So that's why it's very controversial. So the imaging modalities usually we use the X-ray in AP, lateral, antero-posterior, oblique. So these X-rays usually we take to rule out the spine pathologies, because it also useful to see the SI joint as well as to rule out the other pathologies. Also we can take a CT. CT is usually used for inflammatory causes, tumors, fractures, or any degenerative changes in SI joint. So MRI is not that helpful. Usually MRI we do to rule out any disc pathologies. So as you have seen, the provocative tests are controversial, whereas the imaging techniques are controversial. Then how will you come to a diagnosis? So as already you have seen the criterias, the 3 criterias for means given by International Society of Study of Pain. So the gold standard thing is the image guided injections. If you do an injection, because usually we put a needle and then we give a dye. So if you dye can provocate a pain because you are increasing the pressure inside the joint. So it can reproduce a pain, that tells that it will become a diagnostic tool, because that confirms the pain generator. And after confirming, if you inject local anesthetic with steroid and if it relieves the pain, what it indicates? That the pain generator is SI joint. So if you do image guided injection, that itself will confirm you the diagnosis, because it works as a diagnostic tool as well as a therapeutic tool. So usually, as we know, the treatment always, if the patient comes in acute pain, always the first modality will be conservative means. So you can give them NSAIDs, you can give them COX-2 inhibitors, as well as physiotherapies, heat and cold applications. And if the muscle strengthening exercise which can support the SI joint. If you know the pathology like rheumatoid arthritis, or if patient is having ankylosing spondylitis, then you have to give them, put them on steroids or disease modifying drugs. And even in inflammatory causes, we can do the intra-articular injections of local anesthetic with steroid. So this is the algorithm which showing the approach. So first, how will you diagnose the patient with SI joint pain? So you can diagnose it with positive history, positive examination, and he has put a question mark for imaging, because imaging is a controversial thing. Then if you have a diagnosis, provisional diagnosis is SI joint pain, then you can go ahead with a injection of steroid with local anesthetic. If you have a relief of more than 50 to 70%, then we give a physiotherapy and NSAIDs. If patient has continued pain, then again we can repeat the injection. If there is no pain, then we can continue the conservative measures. If the second injections provide a relief more than 50 to 70% greater than 3 months, then we can repeat the injections after 6 months or 3 months or so. If the relief is 50 to 70% but it is lasting less than 3 months, then we have to go for definitive approaches. So the definitive treatment plan will be either surgical, or we can do a SI joint radiofrequency ablation. So SI joint injections we can do by fluoroscopy assisted, USG guided and CT guided. So fluoroscopy guided, in this the patient is kept in prone position with a pillow below the abdomen and pelvis to avoid the lumbar lordosis. Then we have to take a AP view to identify the affected sacroiliac joint. Then we have to take a for a transfemoral epidural, which view you have taken. Once you identify the level in AP, what you do, which oblique you will take. So you will take ipsilateral oblique. But here what we have to do, we have to go contralateral, because what happens, the ilium will cover the sacrum. So to open up the joint, the C-arm should be tilted on the opposite side, contralateral oblique. So till you will see a straight line. So you will see a sacroiliac joint as a straight line. Till that point, you have to tilt the C-arm towards contralateral oblique side. Once you see the joint, the preferred position will be lower 1/3. Can you see the needle over here? So in that oblique, so the needle will go from medial to lateral in the in-plane technique. So we go inside the joint and then we inject the non-ionic contrast media dye. So as I told you, this joint is not a smooth joint. It's not a regular joint. The articular surfaces are not smooth. So if you see here the die how it is distributed, it's not a single straight line, okay, because it's not a smooth joint over here. So once you have confirmed the position, then you can inject local anesthetic with steroid inside the joint. So we can do this with ultrasound guided imaging. So how many of you have seen used ultrasound in your regular practice? Are you using it? No. So usually, because it's a deeper structure, for deeper structure, which probe you will use? Linear? It's a deeper structure, so you have to use curvilinear probe, low frequency, because so rays has to penetrate inside. So we use a low frequency curvilinear probe. Usually we put it at the just above the gluteal folds in the midline. Then we will see a dorsal median crest of the sacrum. Then we the probe is slide towards the lateral side. Once you go laterally and lower at the level of S2 foramen, we will see a sacrum and overhanging ilium. So this is the SI joint, and needle always should go from medial to lateral, because if you want to come from lateral side, the ilium will come in your way. So always your needle should go from medial, from this side, medial to lateral. So if you see here, this is which bone? Anyone? This will be ilium, this will be sacrum, and needle is coming from medial to lateral direction. Okay. So with this injection, most of the patients we have good pain relief for 1 to 2 months. There are studies which have shown the relief for 3 months, and there are some randomized control trials we have shown the relief is lasting more than 6 months to a year. So once you are done with this, suppose patient again is coming back to you. Initially patient had good pain relief for a month or 2, and patient is coming back to you. So what you will do for next? Because for long-term treatment we have to go for radiofrequency ablation. So for radiofrequency ablation, as we know, we can do it by intra-articular approach, and we can do it by lesioning the lateral branches of S1, S2, S3. So the intra-articular lesioning we can do with bipolar. This is called as palisade technique. Here we put a multiple needles at a distance of 1 centimeter, and they produce a lesion. So here we are not targeting the nerves. We are just lateral to the joint, or we go inside the joint, but the lesion is continuous. So due to that, the capture of the nerves, because the capture rate is very high. So there is a high likely chance, that 99% chance, that by this approach you can ablate the nerves supplying the SI joint. So lateral branches, as I already told you, so this is the way where you should put the needle. Okay. So actually you take a AP view, then you tilt the C-arm, cephalocaudal tilt, where you can see the foramenas more clearly. This is S1, S2, S3. This is L5 lateral branch. You have to put a needles around the S1 foramen, S2 foramen, 3 needles around S1, 2 on S2 and S3. Okay. This is the way by which you can do a RF lesioning. So this is the fluoroscopic picture, and the sites where you have to put. So suppose if you see here, these are the foramens. So this is S1, S2 and S3, and this is a L5 median branch. So we can do this with ultrasound guidance. Also here we have to see first the caudal epidural space. This is sacral cornu, and then we have to go forward up to see the third sacral foramina, then second and first, and we have to draw a line, and along the line we have to put the needles, RF needles. So there are multiple studies which are, some are retrospective, some are prospective. They have combined, they have shown that the relief is around 50 to 60% post RF lesioning. But the problem with these studies are, if you see the sample size, 9, 28, 38, 22, 26, 28. So here also previously the retrospective studies, the sample size is not enough. So the further studies are required to come to a conclusion. See what is the efficacy of RF lesioning of the lateral and median branches in SI joint pain. So coming to the end, the surgical interventions, interventions are not indicated, most of the times they are not indicated for non-traumatic causes. Only in cases where there are accidents where you have a fracture sacrum or ilium where you want to fix it. So there only you have a surgery has a role. But there are some indications where if patient is having severe pain and he is not responding to conservative modalities as well as injections or RF lesionings, then those patients, and where the social life has been compromised, in those cases we can do a fixation with a titanium implants, and there are studies, they have done a follow-up for 24 months and they had a good results with it. So these are my references. Thank you. So any questions you can ask.
Thank you for insightful presentation, sir. I request Dr. Sridhar Madam to present moment to Dr. Sachin, sir. Now we will take short tea break. 15 minutes.
we're doing deletion now. And the most important thing is that the patient should not feel it go down the legs. And either you don't feel it going down the leg, you're no good. That's great. So and that continues for the next 40 or 45 seconds, and I usually lesion it for 90 seconds. Thanks. Next one.
This spinal cord stimulation trial, this patient was fused almost in the lumbar spine, and you will see the X-ray right now.
Hello again. We just spoke to Ms. Rita, and now we're going to take a look at her X-ray, and especially of the fusion that she had. I don't know if you can see clearly, but this is the fusion that she's had. See the rods and the screws. You can see them here. The levels, I would say, are, if you count this as L5, then L4, L3, L2, L1, and you can see the ribbon there, that's each valve. So she has pretty much all the lumbar vertebra fused together. So that's what we're dealing with here. And my intention is to try to go above the fusion at T12 or T11 and try to see if I can get the lead in right about there. Thanks. Hello again. We're back in the operating room this time, and I'm trying to do the trial on Ms. Rita, who, as you know, has had 5 back surgeries and exemplifies the term failed back surgery syndrome. So we're going to start off. If we can take a look at the X-ray picture there, there's a point, another pointer, which is at the bottom of, I want to say, T11, and I'm trying to enter at between T10 and T11. Let's try to do that now. Continuous please. So, we're going to feed the numbing medicine now, okay? It stings like a bee, alright? Here comes the bee sting, that's the bee sting. And it kind of burns for about 5 seconds. Bear with me, please. I'm numbing the skin now with lidocaine. Picture? Good. Going to numb you a little more there, okay? All the way in. Picture? Excellent. Tell me if you feel anything sharp, okay? You should not. But if you do feel anything sharp, you need to let me know, okay? Do you feel that at all? Pressure? Okay. Picture? I'm entering if you get the picture of the exercise, I'm entering above T11. I'm trying to go to T11 there, so. Picture? Excellent. Look at the angle of my entry here. It's about 45 degrees to the horizontal. Picture? Are you alright, Peter? Bear with me, okay? You're doing very well.
to the visual space now, and if you pan the camera to the X-ray there, continuous. Squash the lead there, coming out of the knee, right there, and it's going to the visual space. Continuous. Trying to get into the midline there, and there it goes. Going up the midline. Trying to stay in the center as much as I can. Trying not to go in the bottom. Stop. Let's come now. What I'm saying is C10, 9, 8 maybe. Okay? Continuous. I'm going to go to P7 please. See right hand. Try to still keep it in the midline there. That's more like 8 keep it in the midline. There you go. Stop. Okay. Keep it forward. Okay, let's count now. Continuous. That's P12, 11, 10, 9, 8. Go up. 7 and 6. Okay, stop. You may be a little high there. So, do you think, Nathan, or do you want me to bring it down a level? We have T6.
Normally T6 is, you get a lot of abdominal stimulation.
Alright, let's get come down a level. Continuous. Stop. That's at the top of T7 right there, okay? So we got the lead in at, as you saw at the top of P7 in the midline. Now what we're going to do is I put the lead up to the programmer, and they're going to program it. In fact, Nathan is going to program it for us now.
Lead up. It's Nathan. I'm going to start turning the stimulation on now, okay? I need you to let me know when you start to feel that tingling sensation you talked about, okay? Feeling any stimulation? Where do you feel that? Is this covering all the areas where you normally work with the tingles? I'm at the very top of the lead now. I'm going to pull down. I'm going to move the stimulation some. Rita, you let me know if it gets too strong at any point, okay? All right, I'll back it down. Is that better? Okay. Are you still feeling it now? Is it still in the same spot? In the back of both of your legs? Is it going all the way down to your toes still? Are you happy with where it's tingling? All right, I'll back it down. Do you still feel it at the middle of the right now? Do you still feel like it's tingling in the areas where you normally have pain? In your lower back, down both of your legs to your feet?
So we have pretty much almost everything covered now from your back down to both legs. Okay. We're not looking for pain over here, but as long as you're feeling the tingling, that's what we're looking for. Okay. So you are having the tingling now from your lower back all the way down to your feet, right? Okay. What I'm going to do is I'm going to leave the lead where it is now, and we will program it again once we are outside, and we'll see how you do with this. Okay. All right. Thank you.
As you
guys saw this is an older video, and I was doing a spinal cord stimulator on a patient who was fused from L1 to S1, right? It was all the hardware. And tried to get it about T12, and then I got it in there, and there was a single midline lead, right? I always try to do a midline lead rather than doing 2 leads on each side. So do one single midline, and she got excellent coverage on both sides. The trick is to be in midline there. So as long as you're in midline, you can get still cover both sides. So for trial, I always preferred a single midline lead, and I put a single midline lead in there, and she got very good coverage going down the back and both legs all the way where she needed it. That's all I needed. So most people do 2 leads. You can do 1 on each side. And the problem is though, if you go a little further away from midline, you start getting into the gutter, right? You go anterior, right? So because the epidural space is a cylindrical space, right? So it's not a 2-dimensional space. It's a 3-dimensional space, right? So once you go you're supposed to be dorsal, right? You're supposed to be posterior here, right? So if you go even a few millimeters to the side, what happens? It slips into the gutter and goes anterior, right? It goes anterior. So yeah, you're not stimulating the anterior column, you're stimulating the posterior column here. So you have to be posterior and stay in the midline, and that's what I did here, right? And this is an older video. So, and then, you know, we draw the needle real quick here. Nathan, let's get a picture of the X-ray there. You can see the top of the lead at the low border of T6. And what I'm going to do now is we'll draw the needle from the epidural space. You can see there. While under fluoroscopy, I'm looking at the picture there. Continuous. And I'm going to withdraw the needle very gently here. The trick is to keep the lead in spot and then take the needle out. So you have to hold the lead in the same space. That's what I'm trying to do here without the. Lead is out now. So make sure you check again, make sure that it is not moved too much. It's an 8 contact lead, as you can see, it's an 8 contact lead. Look at the final position of the tip again. It's exactly where it was. Alright, so and then finally we anchor the lead, because the lead it should not move, right? You have already put the lead inside there, so it should be anchored to the skin and not to move it in any direction. So this is the way I'm anchoring the lead. I'm going to anchor the lead with the stitch. You may feel the lead a little bit, okay? Just a tiny bit. That's the stitch that I'm going to put. I'm going to first put an air knob. Different ways of anchoring it. I use this, do an air knot and then go around the lead and here, so that the lead doesn't move. 3 times around, and then it goes around, and finally 1, 2, and 3. That's the anchor there. Now, what I want you guys to see is this is fixed relative to the skin and relative to the epidural space. So even if you tug it in, it should still be there without moving inside the epidural space. So that's the whole point of anchoring it. And that is the trial. This is the trial, right? This is the trial for the spinal cord stimulator. We put the lead in and we leave the patient go, let the patient go for about 5 days, live with it and see how they do. If they get good relief, more than 50% of the pain relief, then we take the trial lead out and then put the permanent one in, right? So, and this will be the permanent, this will be the last video for the day, the permanent implant, and this is done by a good friend of mine, Dr. Sanapati, and I have to thank him for this. This is a more recent video, so this will be the last one, a permanent implant, right? So let's see, watch this.
guy uses the guide wire as a loss of resistance. So he doesn't, you saw him, he didn't use the loss of resistance, so he uses the guide wire and he just keeps poking at it and then slips into the FU space, which is one way of doing it, I guess. So, and he's very good at it. So
Post-surgical, sir, if there are adhesion side of it, it's difficult.
So I don't do it that way, and that's the reason why I'm pointing it out, that he's never used a lot of resistance. He just used the guide wire. You have the guide wire, right? It's a thicker thing, and then he keeps going in and he loses resistance there. And then he takes the guide wire out and puts the lead in. So that's what he's doing. So. Put both the leads in. You see the needles in there, and he's put both the leads in. Confirm the needle position is taking the needles out. He's got the leads in now. Now he has to cover those leads. Got both the leads in now, as you can see.
This is an index multi-anchor system.
Has to anchor the lead in, so he's using an anchor, he's putting it over the lead. The biggest issue with the spinal cord stimulator is what, guys? Movement of leads, right? That is the biggest issue with it. So you have to anchor the leads very well. That's what he's trying to do. So you fire the anchor and take the thing out. So
Mounting the anchor there and then remove the
that's the anchor and
multiply the other anchor.
same process on the other lead.
And releasing the anchor.
Yeah, he fires the anchor there. Yes.
Now put the anchor in place. Fix the anchor to the fascia, not a double switches.
It's trying to anchor the anchors in place. So yeah, look at the anchor. They come with grooves. That way you know exactly where to anchor them. And
setting the second switch. The anchor.
love to get to something very solid there, because you just can't take a soft tissue, right? It just doesn't stay. And even with that, there's still movement in the epidural space. They keep moving.
So with the plate electrodes, does the displacement is less, but we have to go surgical.
With parallel leads, the displacement is much less, but you have to go laminotomy. Again, what's the point? So you're doing another back surgery. So laminotomy leads. There is one kind of thing called epiducer leads. That you can do with the needle, percutaneous placement, and then it goes inside and you can open it up. It expands. And so that is called an epiducer lead. That
changes the outcomes, like those will go into the area.
Yes, they do. You're right. Laminotomy leads always, parallel leads cover much better than any of the cylindrical leads. These are cylindrical leads, right? The parallel leads are flat and there is no energy wasted this way. All the energy is directed this way, right? So there is cylindrical leads, then there's a lot of energy coming this way, which is waste. So parallel leads, all the energy is going to the dorsal column. So and they cover much wider area also.
Can we use trial lead as a permanent lead? Suppose you have kept the lead.
Yeah, I mean you can. You can, and they are made that trial and permanent. You can use it. So that's the battery.
We are putting in restore.
That is the IPG, as they say.
MRI. Oscillator.
So he's fixed the leads. Now he's going to make a pocket for the IPG. That's the pocket for the IPG. A lot of lidocaine in there. Now it's tunneling from the pocket to the lead. You grab the leads and then you pull it through. The leads are now through to that pocket and it's going to connect to the battery or IPG. The leads are connected to the battery now, and the battery is being put in the pocket. He's anchoring the battery itself now to deeper tissue. It's going to close both the wounds.
stapling the wounds now, and we are done. Covering the wounds. So that finishes the last video for the day. So you've seen radio frequency, you've seen spinal cord stimulation. Movies always are impressive, right? So I think we are all used to movies, so that's why I like showing some movies. So we have some of the faculty here. If there are any questions, I think it's a good time. We have a few more minutes. Any questions, please? We have all, not all, but most of the faculty here. So any questions about anything that you heard or saw today? This is the time to ask. And like I said, the only stupid question is the one.
Leads permanent untaya?
Yeah, this is permanent leads. Permanent. All the time. Battery, two kinds of batteries are there. One is rechargeable, one is non-rechargeable. This was a rechargeable battery. So you can recharge the battery just like your regular batteries. You have a belt that you wear and you plug yourself in. So, yeah, you plug yourself in and by morning you're charged. So, yeah, so chargeable and non-rechargeable and rechargeable batteries are available. Life, they say, for about 9 to 12 years. 9 to 12 years for the battery.
So what would lead migration, like what is the percentage of patients you are seeing where the lead migration?
Unfortunately, it's very high. Unfortunately. And that is one of the reasons why I have backed off on spinal cord stimulation. So it is high, and then the other problem with spinal cord stimulation, like anything else, you get used to it. And once you get used to it, you're back to ground zero. So it is not as helpful as what it was originally. So it may be 6 months, it may be 1 year, it may be 2 years, it may be 3 years. So you do get used to it. Lead migration is very nasty, you'll have to take the whole thing out or then put a new lead in, and so that's not ready once the lead migrates. That is a big problem with spinal cord stimulation.
But post fibrosis, like you have kept a lead, suppose 6 months post placement, there will be no fibrosis?
There will be, yes, there will be. If you are lucky, it's fibrosis in the right place, and you're good. You're good to go. But if you're not that lucky, then it starts moving. So, and that's a problem. So, and it is a real problem. Migration is a real problem.
And before placing the spinal cord stimulator, like workup, like how many days of conservative this treatment will give to the patients?
We probably exhaust everything, and only then, like, for the most part, we do this for failed back surgeries. Like, they've had like at least 6, 7. The most I've had is 12. 12 back surgeries. I asked the patient, why did you stop at 12? Why not 13? Why not 15? So, but that's what it is. So, and for the most part, failed backs do okay because they have fibrosis and they do okay. But sometimes that may not be your friend because then the lead doesn't go anywhere when there is fibrosis. So you're struggling to get the lead in there.
And for CRPS and also?
CRPS is an excellent indication. It's a very good indication for CRPS. Works very well. Works very well. CRPS of a lower extremity, hey, you can get the lead in very easily. And for the upper extremity, it's a little more difficult. You have to go cervical. But there are places when we have done, I've done the thing in the from lumbar and put a lead right up, all the way up to, you can go to the cervical area also.
And what about the lead fracture rates, sir?
Not that much. 5% or less of lead fracture. Unusual. The leads are being, the material is getting better and better and better now, every day.
And the angle of entry, like you want to be
shallow. Not this way. If you go this way, then you have to make that angle, right? So if you drop the needle down, you are a much better shot at going that way. So the shallower the angle, the better the lead goes in nicely.
Thank you, sir.
Any other questions, guys, for anything? Like I was about to say, the only stupid question is the one that you don't ask, right? So there are a lot of stupid questions now, so meaning you're not asking it. All right. So I think anything? It's good? All right.
Excellent.
Excellent is one. So I don't know about excellent, but as long as we can give you some nidus of knowledge, and this is not enough. By no way this is enough. You have to work on your own knowledge, right? So you have to work on your own, developing your own skills. All we are trying to do is to point you in the right direction, right? We're just pointing you in the right direction, and everyone has their own set of skills. Everyone has their own set of hands, right? So you are good at what you do. You have to develop your own skills. And all we are trying to do is to help you go in that direction, all right? So tomorrow we'll start here, the same place, with the at 8 o'clock, and the operating room, we'll have live demonstrations tomorrow, starting off in the morning session, and in the afternoon we have some more didactics, all right? Good night, guys.
Thank you, sir. I would like to invite Dr. Rajshekhar sir on the stage to receive our
Next to my brother.
Not bad, 5-10. Just a second. Thanks. All right, so I guess we'll all see you tomorrow. Then I think I'll see you shortly for the faculty dinner. You're not invited. No, I'm kidding. So yeah, this is faculty dinner. So.